We will start the technical session in a couple of minutes. I request all the participants to be ready with the PPTs and be prepared with the presentations. If any of the participant is facing any difficulty regarding sharing the PPT, I request you to share the PPT in the chat box, or else Miss Gopika, the coordinator for the conference. So it would we would be wasting our time. And the rules and regulations for the participants are to follow as 10 minutes for presentation, in which 8 minutes for presenting and 2 minutes for Q&A session. I request every participant to stick on to the time, and all the best for your presentations. We will start the technical sessions in a couple of minutes. I request all the participants to be ready with the PPTs and be prepared for the presentation.
Gopika ma'am, are you online? Hello, Gopika ma'am.
Um, Thank you for your patience. Now we'll start with the technical sessions. Before that, I would like to welcome our session chair Sufadi, Dr. S.S. Ajita Mishra. Ma'am, could we start with our presentations, ma'am?
Sure, Gopika ma'am, please go ahead. And there is another chair, Gopika ma'am. She'll be joining probably after 15-20 minutes.
Okay, ma'am.
I'll send you the details of her. And can she join from the same link, or you'll be sending another link to her?
It's the same link, ma'am. She can join from the
It's the
same
same
link.
link? Okay. Okay, I'll just send you the details and please let me know. She can join within like 20-30 minutes if you
Okay.
are okay with it, right?
Yes, ma'am. It's completely fine. We could start with that.
Sure, sure, ma'am. Please start, ma'am.
Okay. I request all the participants to be ready with the PPTs. If you're having any issue regarding sharing the PPT, kindly drop your PPT in the chat box. We'll be helping you out with the technical thing. And I request all the participants to stick on to the time, like in which 10 minutes, 8 minutes is presentation and 2 minutes for Q&A. Now I would like to welcome our first participant, Yashashvi Kumar Damahe. Are we having you here, Yashashvi? I guess there is participant is not available, ma'am. Could we move to the next presentation? Now I would like to welcome Ruganayani Patil for her oral presentation. Ms. Ruganayani, are you there? I request all the participants to respond ASAP.
Good morning, ma'am.
Yes. Kindly start sharing your PPT and start presenting, please.
Hello.
Yes. Can you be a bit loud so that it would be audible? Ms. Ruganayani, any issue? Ma'am, could we move to the next presentation? I guess there is a technical issue from Ms.
Sure, sure, ma'am. No problem.
Okay. Now I would like to call upon our next participant, Dr. Selika Dankar. Dr. Shalaka Dankar, you there?
Yes, ma'am.
Yeah. Please kindly share your screen and start presenting, please.
Yes, ma'am. Ma'am, someone else is sharing, so I'm not able to share.
Just a moment, please.
Hello.
Yes. Rugnani, you are presenting? It's okay.
Shall I start, ma'am? Or should I let Prabhini to present?
Hello.
Okay. Ms. Rugnani, we'll have your presentation next. Take your time. We'll start with the other presenter. Okay. Dr. Shalaka Dankar, you can start with your presentation, please.
Yes, ma'am.
Yes, ma'am.
My PPT is visible, ma'am?
Ma'am, is my screen visible?
Hello?
Yes, your PPT. Like I guess Dr. Mruganayani Patel is sharing her PPT.
Hello?
Yes.
Ma'am, is my
Please
PPT?
put your PPT on slide share mode. Your PPT is visible. Just put it on slide share mode. So it will be on the entire screen. Right now, I can only see one slide. And the rest of the slides are in the sidebar. Just put it on slide share.
Ma'am, am I audible?
Yes, you're
Hello?
Ma'am, can I start with the presentation?
Yes.
Yes, yes, Mridlani, please. Mridlani's presentation is not visible anymore, Gopika ma'am. Is she facing some technical issues?
I guess so, ma'am. Dr. Shalaka Dankar, you are there with us?
Yes, ma'am. I'm there.
Yeah, please kindly share your PPT and start with the presentation, please.
Sure, ma'am. Is my PPT visible, ma'am? Hello?
Ma'am, I have stopped presenting.
Yes, Miss Dr. Shalka, you may start with your presentation, please.
Okay, ma'am. Good morning, everyone. Today I'm going to present on the topic telerehabilitation. It's awareness, knowledge and skills in postgraduate physiotherapy students. Telerehabilitation refers to the delivery of rehabilitation services by using information and communicating technology. It uses wide range of activities including assessment, prevention, treatment and counseling, and which are all conducted remotely. During the recent outbreak of COVID-19 pandemic has fundamentally transformed the delivery of healthcare services, and with in-person visits limited due to safety concerns, the need for telecommunication solutions became critical. This shift not only allowed healthcare providers to continue delivering essential services but also paved the way for more widespread adoption of telerehabilitation practices. Utilizing technology in telerehabilitation will not only enhance efficiency for the practitioners, but it will also empower the patients. It will transform the patient from being just passive recipients of the care to the active participants in their own healthcare management. And this involvement of patient will foster better communication and adherence to the treatment protocol, which will improve overall satisfaction with the health services. There has been an explosion in information technology, knowledge, and utilization among the young individuals, which are often referred to as digital natives. These individuals who have grown up with technology possess skills that could greatly benefit the healthcare sector. However, this potential remains unexplored in terms of application within the health training programs and rehabilitation services. Therefore, a need was felt to carry out this study, as the students' paradigm ensure the sustenance and reinforcement of the professional culture and practice. Students, as next generations, are critical to the future of rehabilitation services, and by acquiring familiar knowledge towards telerehabilitation, it can accelerate its adoption and integration in the current clinical practice. Therefore, it is empirical to investigate towards telerehabilitation and can be used the current state and identify the areas of the involvement. Therefore, the study aimed to evaluate the awareness, knowledge, and skills of physiotherapy, postgraduate physiotherapy students regarding telerehabilitation, with an objective to assess their current level in awareness, knowledge, and skills of telerehabilitation in postgraduate physiotherapy students. For this purpose, a descriptive cross-sectional study was designed in which the postgraduate physiotherapy students from various institutes of Nagpur were selected. A p-validated questionnaire was used and it was distributed among students in form of Google Forms. The data was collected and analyzed. Time constraint and space, I'm going to highlight the important findings of the study. There were total 26 questions, out of which 13 questions were used for assessing the awareness and knowledge, while 13 questions were assessing the skills. During the analysis of the result, it was observed that almost rehabilitation applications, which uses video conferencing systems, sensor technologies, augmented virtual reality systems. Maximum student, that is 56.6% students, applications through internet, followed by seminar and conferences. Most of the students were unaware of the platforms because it is not included in the current clinical practice, or some of them indicated that it is not part of current curriculum or the course. While assessing While assessing the knowledge of the physiotherapy students, it was revealed that 82.4% students acknowledge that telerehabilitation will eliminate the distance barrier and help reach more patients, thus, it will improve utilization of time and resources. 65% 65.7% of students see telerehabilitation as a way to enhance traditional rehabilitative services rather than replacing them. 65.7% students recognize telerehabilitation as a valuable tool for for the patient's follow up, particularly for those who are struggling with home exercise programs. 82.9% students agreed that telerehabilitation is a vital tool during epidemics and disasters.
Shalaka,
Yes, ma'am.
sorry to interrupt, and you are exceeding your presentation time limit. Can you please wind it up as soon as possible?
Sure, ma'am. Almost same number of students, that is 37.4% of students agreed that availability of telerehabilitation applications uh, were not that much updated for the patients who are struggling with the use of technology. Coming to the skills, almost all the participants termed themselves as learner, as we can see all the graphs in yellows, which indicate the learner students. It indicated that most of the students were in learning phase when it comes to the digital skills. Therefore, discussing about the results, there is strong indication that telerehabilitation is an effective and efficient method for addressing barriers and to improve the overall quality of the treatment. There is significant agreement on its potential to increase patient follow-up and patient care altogether. Mixed response was obtained on the existence of application designed for the patients who were struggling with the use of technology. For a notable division, it is evident that the effectiveness of telerehabilitation varies when it comes to the digital proficiency of the students, and this is the area where there has to be improvement. To summarize the results or to summarize this research, a significant proportion of students are aware of telerehabilitation and its benefit, particularly in enhancing patients' access to care. While many students have foundation knowledge about telerehabilitation practices, there are gaps in understanding specific technologies and methodologies used for assessment and interventions. Students exhibit varying levels of proficiency in essential skills such as video conferencing and software telehealth application, but identify themselves as learner. Therefore, there is an indication for further training. To conclude my study, it is seen that the future of telerehabilitation and physiotherapy lies in preparing physiotherapy postgraduate students for evolving landscape of the healthcare, and it is crucial to enhance their current awareness, knowledge, and skills in telerehabilitation to fulfill the gap. Thank you.
Thank you for your presentation, Dr. Shalaka. Please, session chairs, you have any question for this presenter?
I'm sorry, Gopika ma'am, I did not get her name. Can you please repeat her name?
Dr. Shalaka.
The name Shalaka.
Yes, ma'am.
Okay. Dr. Shalaka, I just have one question in this. The physiotherapy students were all from Nagpur?
Yes, ma'am.
I mean,
All
was
the
this study
postgraduate
based
students. Yeah,
on
it is.
postgraduate students?
Yeah,
Okay.
yeah, only in Nagpur.
And okay, and the postgraduate students, they're working, like they have their own clinics or something, or they're just students?
Maximum of them are practicing in some clinics, and more all of them are students, but some of them are practicing in clinics as well.
Okay.
Yeah.
So the students who are not practicing, how would they fill the questionnaire regarding telehealth? Like, see, if I'm practicing, I know about the actual problems that I face, or I'll be like, okay, I need to give telerehabilitation to a particular patient, and this is the technology that I need. I'll be focusing more on it. But a person who is not seeing patients or who is not involved in telerehabilitation, do you think that person is like eligible to fill this questionnaire? Maybe the people who are actively working in the field can give you a more valid response for the questionnaire.
Actually, this questionnaire is just assessing their current knowledge and awareness about the telerehabilitation. It is not about their perception about telerehabilitation.
Okay, so it is
Or
just about
opinion.
whether they know
Yeah, whether they
about
know
it or
about
not.
telerehabilitation or not.
Okay, because in your discussion you said that there are people who do not have knowledge, appropriate knowledge regarding the software that they can use, and they are not very
Ma'am,
proficient with technology.
yeah, here I'm talking about the digital skills, means the general digital skills which would be required for conducting a telerehabilitation sessions, like downloading the files, uploading files, downloading and installing software, and all those things. setting up connectivity and all that.
So the postgraduate students, are they involved in any of these things?
Yes, ma'am. As I said in my result, there is mixed response when it is coming to the participation in e-forums and video conferencing. So students were
Okay.
neutral about whether they are learner or mediocre. So they did not respond. They were neutral about that question when it was about participation, actual participation in e-conference and video conferencing.
Okay. Can I just see your questionnaire once?
Ma'am, actually, right now I don't have my questionnaire.
So
Sure.
what kind of questionnaire it is? Like, what are the options that I can answer?
Ma'am, for knowledge and awareness, there were total 13 questions, out of which first three questions were purely on the awareness and rest 10 were on the knowledge. And they were measured on the Likert, 3-point Likert scale on agree, disagree, and neutral.
Agree,
And
disagree, and neutral. Okay.
yes, ma'am. And 13 questions were on digital skills, and those were termed on unskilled, learner, mediocre, and experts.
Okay. Fine, Dr. Shalakya. But next time if you are presenting a research based on a particular questionnaire, just keep this in mind that you need to have your questionnaire handy.
Yes,
Until
sure.
unless we get.
Yes, ma'am.
Hello.
Yes, ma'am, sure.
Yeah. So you need to keep your questionnaire handy.
Okay, ma'am. Ma'am, actually, can tell. Hello.
Dr. Shalakya for your presentation.
Thank you, ma'am.
Hello. Thank you.
Yes, ma'am. The next presenter would be Dr. Yashashvi. She was not present in the first. So, ma'am, are you available? Dr. Yashashvi?
Yes. Yes.
Ma'am, please go ahead with your presentation, ma'am. Dr. Yashashvi, are you available? Okay, ma'am, she is not present, it seems. And the next presenter would be Mridnaini Patel. Dr. Mridnaini?
Yes, ma'am.
Ma'am, please take over the session and go ahead with your presentation, ma'am.
Ma'am, can I start?
Sure, ma'am, you can do. Your timer starts now.
So the topic for my presentation is, does unilateral dominant sports have asymmetry of strength, balance, and movement analysis in male football player, which is a cross-sectional study. So basically the problem is the individual who participates.
Sorry to interrupt you, Mridnaini. Can you please go to your second slide? I cannot see your topic.
Okay, yeah.
I'm only able to see the first slide. Can you shift to the second?
Ma'am, please put it on the presentation mode so that it will be visible.
Ma'am, can you see?
We can see your presentation, ma'am, but it is not moving.
Ma'am, I think so there is some issue with slideshow mode. This is the topic.
Sure, ma'am, sure, you can do. Please go ahead.
Okay. So, starting with the introduction, individuals who participate in the sports with inadequate fitness level have increased chances of injury, especially in the sports with the literature have shown that asymmetry can cause the injury. So, footballers are the profession who require the persistent preference of the dominant leg over the non-dominant leg, and this can cause the injury. So, the current need of the need of current study is strength, power, balance, flexibility could also cause the asymmetry, but the research, current literature shows that the strength and power only have the asymmetry relation in the injury chances. So the unilateral squats can be used for assessing the knee valgus and asymmetry between lower extremity, which can be a potential risk for the injury. Therefore, the current study focus on comparison of strength, balance, and single leg squat analysis, both qualitative as well as quantitative analysis on dominant and non-dominant side. Aim for the study was to compare the strength, balance, and single leg squat analysis between dominant and non-dominant side in male football players. Objective: All these parameters were calculated. The strength was calculated, isometric strength was calculated using hydraulic push-pull dynamometer, balance through Y-balance test, and movement analysis for Scott's qualitative with the help of visual Scott score, and quantitative with the help of Kinovia. Methodology, it was an observational cross-sectional study. Participants were male footballers. Study duration was for 18 months. Study setup was sports complex in Chhatrapati Sambhajinagar. Total included samples were 93, calculated from the reference of the previous study. Inclusion exclusion criteria. Inclusion criteria, age of 18 to 25 years who are having the experience minimum of 2 years playing the football and who practices minimum 5 hours per week. Exclusion criteria, any abnormality which can potentially reduce the lower extremity performance, history of recent extremity trauma, pain or discomfort. Study procedure, ethical approval was taken, then CTRL registration was done. Total 113 subjects were screened, but out of that 93 were included in the study on the basis of inclusion criteria. Then 15 minutes of warm-up was given for every individual. Then the demographic data was taken, and then all the outcome measures were assessed, and then the statistical analysis and results were analyzed for the study. The outcome measures was taken for the study was isometric strength using hydraulic push-pull dynamometer for hip flexor, hip extensor, hip abductors, adductors, knee flexor extensors, and ankle dorsiflexors and plantar flexors. Balance, Y-balance test was assessed, anterior, posterolateral, and posteromedial, 3 balance were assessed. And then last was the single leg squat analysis. So qualitative analysis was done through visual Scott score and quantitative analysis with the help of Kinovia. So basically in the quantitative analysis, the maximum single leg squat depth, the screenshot was taken, and after that the maximum squat depth, hip angle, knee angle, and ankle angle were calculated with the help of Kinovia. Results shows that comparison between both the legs dominant and non-dominant side, it showed a significant difference in ankle angle and squat depth with the p-value less than 0.05. Strength for hip flexor, hip extensor, hip abductors, knee flexors, and knee extensors all were significantly positive, and the balance assessment, only anterior direction shows difference in the dominant and non-dominant sides. So this was the table. So here in squat analysis, only ankle angle were significant. In strength, hip flexor, strength extensor, abductors, and knee flexor extensors were significant. And in balance, only the anterior direction was found to be significant. This was the graphical representation. So in discussion, basically, this was the results. The previous study stated that the unilateral squat is the best way to analyze the asymmetries, and asymmetry causes the risk of injury in future. So the previous study shows that the downhill skier, which was a study conducted, which hypothesized that the dominant leg having the effect of injuries, and that could be either due to strength or sensorimotor control, which conclude that the asymmetry in sensorimotor control is responsible for lower limb asymmetry to the strength, and the mechanism can be reported as a risk factor for the injury. Similarly, a study which was reported, which shows that the difference between both the sides, basically leg balancing, which shows especially in the direction anterior-posterior, have the effect on the injury. And in contrast, the last study which do not show any significant difference on both the sides, that is also mentioned. So conclusion from the current study is unilateral dominant sport, that is football, affects the symmetry level in the footballers in the strength of hip flexor, hip abductor and adductor, and knee strength, that is knee flexor and extensor, balance in anterior direction, and single leg squat performance, that is ankle angle is different and squat depth is different. Study implication, the risk of injury can be reduced by focusing on the parameter which basically causes the asymmetry. Study limitation, hydraulic push-pull dynamometer have poor reliability for the ankle muscle, so ankle results cannot be considered as the final for this. And the last is visual Scott score, which was analyzed only using 3-point grading scale which can be assessed like better for 5 pointers or something like that, so that it can be more reliable. These are the references, uh, and done with the presentation. Ma'am, questions?
Thanks, Dr. Mritnaini, for your presentation. Ma'am, you have any questions for
Dr. Mridnani, can you please go back to your inclusion exclusion criteria?
Yes, ma'am.
Were these players professionally playing somewhere, or are they only recreational sports players?
Ma'am,
Like
they
they
were
only play for their...
recreational plus professional. The inclusion have just the things that they should be experienced with 2 years of experience, and 5 hours should be the practices. So they were with both professional as well as recreational.
See, if you are comparing professionals with recreational, you'll have to keep. And what was your place of data collection? Where did you get these players from?
Ma'am, these were from the sports complex in Aurangabad. So there were 2, 3 grounds from where I have collected my samples for the study.
All of them were getting professional help from their coaches, or some of them were
No,
just
ma'am,
playing for the sake
professionals
of...
were very few. Like I can say only might be 5 or 10 will be the professional. Maximum were the recreational.
Okay. See, next time when you take up a study on sports professionals,
Yes.
either you take people who are playing professionally, or you take all the people who just play for the sake of it. You know why? I'll give you the reason for it.
Yeah.
Usually, people playing professionally, they invest a lot of money in hiring a good trainer.
Yes.
And these trainers make sure that these professional football players get an overall training,
Yeah.
including the muscle strength is checked, their regular exercises and drills are not just playing football, they undergo other kind of strengthening and endurance training as well, agility training as well. Whereas people who are just playing because it's a hobby for them, they're recreationally playing and they just go and play say 5 hours a week, they might not invest so much into their training and nutrition and all this. So because they're not professionals, no? They have got other professions to work on. Maybe some of them are IT professionals and they play only for the sake of fitness.
Yeah.
So you cannot compare a professional player with a person who is playing for a recreational purpose.
Yes.
They're not investing the same amount of diet and same amount of money in the coaches as a professional player.
Yeah.
So whenever next time you try performing, this is a good topic, you have done a good research, just make sure that your sample is more homogeneous.
Yes.
Either all of them are recreational players, or all of them are professionals.
Okay.
Even if they're playing at state level, even you need not take football players who are playing for the main team or a big team.
Yes.
Even if they're playing for state level and all, that is fine.
Okay.
Right?
Yes, ma'am.
Otherwise, your topic is good. Thank you so much for presenting.
Thank you so much, ma'am.
Thank you, Dr. Mritnaini, for your presentation. And the next presenter would be Dr. Vibhuti Gar. Dr. Vibhuti?
Yes.
Yes, ma'am. So I'll be presenting your presentation from our side. And
Yeah,
please,
sure.
you want to change your slide, okay?
Yeah.
Please start your presentation, Dr. Vibhuti.
Yeah, sure. Good morning, everyone. The topic of my presentation is short-term effects of muscle energy technique versus active release technique in improving hamstring flexibility and pain in patients with acute ACL tear, a randomized controlled trial. Introduction: Anderson and Brooke defined flexibility as the range of motion available in a joint or a group of joint that is influenced by muscles, tendons, ligaments, and bones. Flexibility has also been described as a degree to which muscle length permits movement over that which it has an influence. Flexibility of muscle has long been a concern of physical therapists and rehabilitation specialists as well as physical educators and coaches. Claims have been made that increased flexibility resulting from stretching activities may decrease the incidence of musculotendinous injuries, minimize and elevate muscle soreness, and improve athletic performance. The current literature, however, is limited regarding the possible contribution of this hamstring reflex and/or spasticity to the loss of knee extension after acute ACL injury, although there are several studies that describe muscle activity of the quadriceps and hamstrings. Many treatment approaches are used to increase hamstring flexibility, like cold packs, deep heat, superficial heat, MET, ART, passive stretch, and massage. Please change the slide. Um, Ma'am,
I
can you
think the
please change the
presentation
slide?
mode is not working. So I'm putting on into normal mode.
Okay, sure.
Yeah. Please go ahead, ma'am.
Okay, the need for study. There are various methods available for management of hamstring tightness or spasm to regain the flexibility, but limited research exists for evaluating the effectiveness of active release technique versus MET in patients with acute ACL injuries. Hence, the research was aimed to conduct the study to provide scientific evidence for the same. The aim of the study is to compare the efficacy of active release technique versus muscle energy technique to improve the hamstring flexibility in patients with acute ACL injury. The objective of the study is to find out the effect of muscle energy technique in improving flexibility of hamstrings, to find out the effects of active release technique in improving flexibility of hamstrings, and to compare between MET and ART in improving flexibility of hamstrings. Next slide. Okay, so research and methodology. The sample size was 60. Study setting was OPD of MSK department of Ravinay Physiotherapy College, Savangi. The type of sampling was simple random sampling technique. Study design was a randomized control trial, and the duration of study was 12 months. Materials which were used was vast scale, measuring inch tape, and universal goniometer. The procedure was, I'm not okay. The procedure was, there were three groups, and in each group there were 20 participants. Initially, for all the groups, vast scale and range of motion was taken. For the control group A, they were only given ultrasound therapy. For experimental group B, they were given ultrasound for a week and MET, and then the experimental group C, they were given ART plus ultrasound. And the outcome measure for the studies was sit and reach test. And am I audible?
Yes, ma'am, you are audible. Please go ahead.
Okay, sure. You can change the slide. The inclusion criteria of the study was the patient aged between 20 to 40 years, patient with acute history of ACL tear with or without reconstruction, patients with tight hamstrings. Tight hamstrings are defined as 30-degree knee extension deficit with the hip at 90 degrees as described by Bandy and Iron. Subject willing to participate. Exclusion criteria was um, history history of orthopedic problems such as episodes of hamstring injuries, fractures, and surgery for other than ACL at the knee joint in the past 1 year. Subjects with knee joint fixed flexion contracture and non-compliance with the program. The outcome measures used was sit and reach test, then active knee extension test, and VAS scale. Next slide. The results were, in active knee extension test, there were a notable enhancement in post-stretch hamstring flexibility with muscle energy technique of stretching, and there was marked improvement in post stretch with active release technique of stretching, while there were no significant changes in post stretch with control group. In sit and reach test, there were marked improvement in post stretch muscle flexibility with muscle energy technique stretching, and there were also some improvement in post stretch of sit and reach measurement with ART stretching, while there were no such difference in post stretch distance with control group. Next slide. The discussion of the study is the analysis of previous studies related to the role of various techniques in increasing muscle flexibility shows a lot of information about the benefits. There were not many studies done before which compared the potency of two different stretching techniques, that is ART and MET, for improving hamstring flexibility and effects of muscle torque. This research was therefore conducted to compare the effectiveness of MET and ART stretching. For the aim of this comparison, a pre-post test follow-up of both the experimental study group were carried out. The reason behind choosing the hamstring muscle is the most frequent and prone to injuries during the soccer games, and if the flexibility of hamstring muscle is adequate, then possibilities of hamstring strain injuries can be reduced and performance can be improved as well. Additionally, there are well recorded, reasonable, and dependable techniques of testing hamstring flexibilities, such as active knee extension test and sit and reach test. A comparison of the pre and post test and follow up values of the range of motion of the test groups revealed that there was a notable enhancement in experimental groups, whereas no such improvements in control groups. Hence, it can be said that the both techniques are effective individually in increasing flexibility of hamstring muscles. Next slide. Conclusion. The study reveals there is no notable difference in hamstring muscle flexibility following muscle energy technique and active uh, release technique of stretching. Both stretching protocols are equally effective on increasing flexibility, muscle force, and reduction in pain. The present research found no significant difference in muscle force, and both stretching techniques between the test groups. Both MET and ART stretching are equally effective and beneficial in improving hamstring flexibility. Next slide. These were the references which were used for the study. Next slide. Thank you.
Thank you for your presentation, Dr. Vibhuti. Ma'am, you have any question for this presenter?
No, ma'am, I do not have any specific question for this presenter. But I would just like you to go back to your methodology slide once.
Yes, ma'am, sure.
Beta, what was your outcome measure in this? One was VAS, the other one?
The VAS, the other one was active knee extension test, and the other was sit and reach test.
Sit and reach test. Okay.
Yes.
What was the grade of ACL tear that you have included in this? There is written, the inclusion says patient with acute history of ACL tear with or without reconstruction.
Yes,
So what is the grade?
with and without. No specific grades were used as such. Any grade of the injury was included in the inclusion in the study.
And what do you mean by acute history? Like how many days after this injury are you including the patients?
Acute as in the recent injury within 6 months or 5-6 months. But in exclusion criteria, we have just included. In exclusion criteria, we have mentioned it that the history which is past 1 year will not be included in the study. But if the history is the the history of the injury is um, can say between between 3 to 6 months.
Between 3 to 6 months, right?
But yes, ma'am.
What about the patients with, say, grade 3 or complete tear of ACL? Even in those patients, after 3 months, you'll be treating the patient and including them.
Yes, ma'am. Yes, ma'am.
But in that case, beta, if the grade is different, the result that you're going to get is very different for different patients. Imagine a patient with, say, grade 1 or grade 2 ACL injury. You are comparing
Yes,
that
ma'am.
patient with someone who has a grade 3 ACL injury. Is that
Yes,
possible?
ma'am.
Like, can you compare the results between different grades and the duration for which you're taking? Now imagine this, that there is a patient who has grade 1 ACL injury and you're including the
Yes, ma'am.
patient after 6 months of injury, or say
Yes, ma'am.
in the 6th month or in the 4th month of injury, and then you
Yes,
have a
ma'am.
patient who has a grade 3 ACL tear and you're including that patient after, say, 3 months of the injury. Do you think you'll get the same kind of results in both?
No, ma'am. The results will vary.
Yeah, they will vary significantly. A person with just grade 1 ACL injury and who has already like recovered for 4 months or 5 months, and you do not know what kind of treatment they have received in these 3 months, 4 months, because you do not like wait up till 3 months to start treating the ACL injury, right?
Yes, ma'am.
Once the patient suffers from an ACL injury, rehabilitation starts after the acute phase of that edema and inflammation, say 48 hours or so, and then the treatment begins. So
Yes,
once the
ma'am.
treatment has begun and you're taking the patient when they have already recovered for 3 months or 4 months, so how can you compare a person with grade 1 injury who has recovered for 4 months and then you are including them? And in the same study, you have patients with grade 3 injury and they have already recovered for 3 months and you're including the same patient in the same category. Either you need to
Okay,
divide
ma'am.
them grade wise, or your inclusion criteria
Yes,
needs to
ma'am.
mention that what grade of injury you're going to include,
Yes, ma'am.
plus the treatment that they have already received prior to your treatment, the techniques that you're
Yes,
using.
ma'am.
Prior to this, whatever techniques they have already been treated with, you need to keep those also in consideration. Probably they have received a wonderful rehabilitation even before you started rehabilitating them.
Yes,
Three
ma'am.
months is a long time.
Yes,
So
ma'am.
just try going through what all things can actually bias your result in the study. Otherwise, what you have tried is good. Your outcome measures are nice. The only thing is the hamstring tightness that you're concentrating on will be different in patients with different grades of ACL tear and the rehabilitation that they have already received. It will depend on the kind of rehabilitation they have received. So you'll have to just go through it once more. Otherwise, the study is nice. Your voice is breaking.
Yes, ma'am. Yes, ma'am. Thank you, ma'am.
Thank you for presenting.
Yes, ma'am.
Thank you for the presentation, Dr. Vibhuti. And the next presenter
Thank you.
will be Dr. Divya Singh. Dr. Divya, are you available? Dr. Divya? Ma'am,
Yes,
Dr.
ma'am.
Divya.
Yes, ma'am. I'm available.
Sorry, ma'am. Dr. Divya, are you available?
Hello.
Ma'am, Dr. Divya is saying yes, ma'am. Ma'am, we couldn't hear your voice. Please sort out your. Hello.
Ma'am, she'll be presenting in a minute.
Sure, sure.
Hello, am I audible?
Yes, ma'am, you are audible. Please take over the session, ma'am.
Ma'am, can you please share my PPT?
Sure, sure. Please wait. Dr. Divya, please start your presentation. Dr. Divya, you there?
Hello.
Ma'am, you are not audible. Can you please check your audio?
Wait a second. Hello.
Dr. Divya?
Yes, I'm audible.
Yes, ma'am. Now it is audible. Please take over the session.
Okay. So good afternoon, everyone. Title of my topic is Attitude of Physiotherapy Practitioners Towards Elderly People in Nagpur City, a questionnaire-based study. Introduction. As of 2019, over 139 million people living in India are aged over 60, which is over 10% of the country's total population. The proportion of older people is expected to almost double to 19.5% in 2050, with 319 million people aged over 60. This means that every 1 in 5 Indians is likely to be a senior citizen. An aging population increases the demand for health services. Old people suffer from the both degenerative and the communicable diseases due to aging of the body's immune system. The leading causes of morbidity are infections, while visual impairment, difficulty in walking, chewing, hearing, osteoporosis, arthritis, and incontinence are other common health related problems. Attitude that influence behavior may be different across healthcare professionals. Their differences may arise due to their knowledge curriculum on their different role plays in care of older adults. Consequently, profession specific theories or strategies may need to be developed, although professionals may learn from one another. Next slide, please. Okay, so need for my study is physiotherapists are among the health workers who interact with older people on a frequent basis while maintaining and improving older people's health during rehabilitation. Previous international literature provided evidence that attitude towards older people were mixed among the healthcare students. The attitude of healthcare workers, such as physiotherapists to the elderly, is particularly important due to the importance of anti-ageist attitude in the quality of treatment of seniors. Such attitudinal issues were noted in nursing and other healthcare workers, but not much is found among physiotherapists in literature. So, existence of anti-ageist attitude in practicing physiotherapist was the rationale for the present study. Next slide, please. Aim to study the attitude of physiotherapy practitioners towards elderly people in Nagpur city. And the objective is to determine the attitude of physiotherapy practitioners towards older people using the Coggan's attitude towards older people scale. Research design and methodology. Sample size was 120. Study setting was field-based in various clinics of different zones of Nagpur city. Study design is descriptive questionnaire-based study, and the study duration was 1 year of synopsis and 6 months of data evaluation. Next slide. Inclusion criteria is physiotherapy practitioners, postgraduate clinicians, physiotherapists who are willing to participate. Exclusion criteria is physiotherapists who were refused to participate in that study, undergraduate physiotherapy students, and interns. Outcome measure was the Coggan's attitudinal scale towards older people. Next slide. Result and discussion. In this study, it was evident that only a few practitioners had a negative attitude towards older adults, and most practitioners felt positive about the older adults. The result shows that 96 subjects, that is 80% out of 120 subjects, had a positive attitude towards older adults. suggesting a more appreciative attitude towards the geriatric populations. So we concluded that positive attitude towards elderly patient is a good attribute of physiotherapist in Nagpur. Thank you.
Thank you for your presentation, Dr. Divya. Ma'am, you have any question for this presenter?
Can you please go back to your questionnaire?
Questionnaire. Ma'am, I didn't uploaded the questionnaire.
The questionnaire wasn't included, ma'am.
You have used a questionnaire, right?
Yes,
If
ma'am.
I'm
Yes,
not
ma'am.
wrong.
Yes,
Yeah.
ma'am.
So can you show that questionnaire? Was it made by you, or you have already used a questionnaire
No,
that
ma'am.
was that existed?
Ma'am, that was the existed questionnaire and
Okay.
pre-approved questionnaire which was I used. That was a scale which
Okay.
consists of 34 items, and that questionnaire I used to used in my study.
Okay, so you have used that study in order to find
Yes,
out
ma'am.
that what is the response to elderly patient when they come for physiotherapy, right?
Yes,
If I'm
ma'am.
not
Yes, ma'am. Correct, ma'am.
wrong.
Yes, ma'am.
Attitude of physiotherapy practitioners towards elderly. Okay. And this questionnaire was filled by the elderly patients.
No, ma'am. This questionnaire was filled by physiotherapy practitioners all over the clinicians or the postgraduate students.
Okay, fine. So I probably missed that part
So
from
we
your
want to
research.
know that the physiotherapy practitioners' attitude towards older people, towards their patients, towards their elderly patients, or can say.
Okay. Fine. I don't have any specific questions for this research. Just go through the. It would have been really nice if I could have gone through the questionnaire once. Anybody who is using a questionnaire should at least include a picture of it, or maybe the another slide, or maybe an extra sheet for the questionnaire. Because until unless you see the questionnaire, we are like unable to like remember all the scales and the questionnaires that you're using. There are so
Yes,
many
ma'am.
of them.
Yes, ma'am.
So anyways, I don't have any specific question for this. So thank you, Divya, for presenting this.
Okay, thank you so much, ma'am.
Thank you, Dr. Divya Singh, for your presentation. And the next presenter would be Dr. Divya Jain.
Yes, ma'am. Am I audible?
Yes, ma'am, you are audible. Please present your presentation.
Sure. Is my screen visible, ma'am?
Yes, Dr. Divya, your time starts now.
Yeah. So good afternoon, everyone. My topic for the presentation is the effect of progressive resisted exercise along with conventional exercise and conventional exercise program alone in subjects with text-neck syndrome. So as we all know, in today's digital age, mobile phones and cell phones and all other handheld devices are used for people to communicate, work, and entertain. So, however, this technological shift has brought about a new health changes, one of which is a text neck. So what is a text neck? It is an attitude that is caused by bending your neck forward for longer period of time, such as when reading or messaging on a mobile phone. Neck pain, neck stiffness, shoulder discomfort.
Bangkok conference on the topics are nice.
Hello.
Sorry for the interruption, Dr. Divya. Please go ahead.
Sure. Neck pain, neck stiffness, shoulder discomfort, recurrent headaches, and forward head posture are all the symptoms of text neck. According to a poll, text neck syndrome affects 35% of all the smartphone users. This protocol shows a comparative study to see if progressive resisted exercise combined with conventional or conventional exercise alone is more beneficial in treating the text neck syndrome. Now, for the need for the study, the majority of existing research treats individuals with text neck syndrome through conventional exercise alone. This presents a significant gap and an opportunity to explore the combined approach of PRE, that is progressive resisted exercise, with conventional for more effective management of neck syndrome. The aim and objective of my study was to compare the effectiveness of PRE along with conventional and conventional exercise program in subjects with text neck. Coming to hypothesis, the null hypothesis was there will be no significant difference between conventional alone and PRE with conventional. And alternate was there will be significant difference between effect of conventional alone and PRE and conventional in text neck syndrome. Now the methodology. The study setting for the study was carried out at Ravi Nair Physiotherapy College, Wardha, after receiving permission from the Institutional Ethical Committee. Study design was comparative study. The sample size was 80, which included two groups, Group A and Group B, each consisting of 40 participants. The inclusion criteria was participants between the age group of 17 to 22 years, involving both the genders and having an numerical pain rating scale less than 5 on 10. And exclusion criteria were patients having NPRS more than 5 on 10, any recent shoulder or neck or arm injury, or any history of cervical or head trauma, or any kind of surgical intervention in the neck area. The materials used were assessment proforma, NPRS scale, and neck disability index. Now I'll explain the study procedure. My sample size was 80, so I divided them randomly into two groups, Group A and Group B. Group A was purely conventional, wherein I treated them for 4 weeks, and again Group B was conventional with PRE, again 4-week protocol. In Group A, for week 1, we gave the participants only cryotherapy for 5 minutes. In week 2, we implicated active range of motion exercises along with cryotherapy. In week 3, we added cryotherapy, active range of motion, along with chin tuck-in exercises for postural correction. And week 4, we added cryo, active range of motion, chin tuck-in, and shoulder shrugging exercises, again for postural correction. Now coming to Group B, for week 1, same protocol, cryotherapy, but here we added progressive resisted exercise using yellow TheraBand. Like we use TheraBands with light to high resistance. So we first use yellow, then red, then green, and then blue, with 5 repetitions and 3-second hold. So these were the results. First table is the comparison of mean difference in NPRS in Group A and B. This shows the mean value in Group A was 0.67 and Group B was 2.42, which suggests that participants have shown significant improvement in the reduction of pain. However, Group B has shown significant improvement as compared to A. Next chart is the comparison of mean difference in neck disability index in Group A and B. So Group A again showed 4.17 mean difference and Group B showed 13.8. Again, suggesting that both the groups have shown significant difference in the NDI scale. However, Group B has shown significant improvement compared to Group A. To summarize, the study evaluates the efficacy of combining PRE with conventional therapy versus conventional therapy alone in treating the text neck syndrome. The outcome measures used were NPRS and NDI. Cryotherapy, a cost-effective pain management option, is also discussed as a part of the treatment approach. Various studies support the use of PRE for reducing pain and improving muscle strength in neck and back condition. Evidence from related research suggests that posture correction, ergonomic advice, and strengthening exercises, particularly PRE, can improve function and reduce symptoms in musculoskeletal issues. To conclude, both the treatment group, conventional alone and conventional with PRE, showed improvement in pain and function in individuals with text neck. However, group receiving the combined approach demonstrated significantly greater improvement in both pain relief and functional outcome compared to group receiving conventional therapy alone, which exhibited only modest improvement. So this suggests that incorporating PRE into conventional is a more effective treatment strategy for managing text neck syndrome. These are my references. Thank you.
May I know the name of the presenter?
Dr. Divya Jain, ma'am.
Am I audible?
Yes, ma'am, you are audible. The presenter was Dr. Divya Jain. Ma'am, can you hear me? Ma'am, your voice is not audible. Please check your audio, ma'am.
Answers were given to the
Dr. Ajita? Participants, kindly have patience. Our session chair will be rejoining.
Yes, I lost connectivity. I'm so sorry about that. Okay, so Divya, did you give them any kind of ergonomic advices? Mobile position of their head, the position of the mobile phones, anything of that sort? Did you check for any muscle tightness or anything of that sort while you
Yes,
were
ma'am.
treating them with cryotherapy and PR?
Yes, ma'am. We actually checked the strength of the muscle, like more than 3 on 5 on the MMT scale. We were considering those patients in the study.
Okay, and what about the people who might have had muscle tightness or muscle spasm because of continuous use of mobile phones? You checked the strength of the muscle, right? So
I checked
strength
the
of the
strength.
muscle is like he probably, yeah, probably you were trying to establish the fact that there is some kind of muscle weakness.
Right.
Right. Okay. So what about muscle spasm? Probably the person using mobile phone for so long, maybe with a poked chin, poking chin, and also they might even have tightness in the muscles, upper
Right.
trapezius, back of the neck. So did
Yes,
we
ma'am.
try checking that as well?
No, ma'am. That wasn't my consideration.
Okay. So what are the muscles that you checked weakness in?
Ma'am, flexors and extensors, both groups.
Flexors and extensors, both groups.
Yes, ma'am.
So when you were checking for the flexors and the externals, did you find any kind of tightness in any of the muscle, or they were just
Yes,
weak?
ma'am. Commonly, trapezius muscle tightness was found in majority of my participants.
Okay, so did you try releasing that tightness, or did you give them treatment for that tightness?
No, ma'am. There was no stretching or any kind of releasing technique given. Only cryo and conventional method were used. No kind of stretching or.
And do you think that if you would have done that, your results would have been different?
Yes, ma'am. Yes, ma'am.
It could have
Right.
affected your results as well?
Right, ma'am.
So maybe you can progress the same research along
Definitely.
with a multi-dimensional approach instead of
Right.
just PRE and cryo.
Right. Yes,
Can
ma'am.
be expanded, right?
Right, right.
Thank you, Divya. Thank you.
Thank you so much, ma'am.
Thanks, Dr. Divya, for your presentation. And the next presenter would be Dr. Ujjwal Sachidanand Borale. Dr. Ujjwal?
Yes, ma'am.
Sir, please take over the session, sir.
Hello, everyone. Can you hear me?
Yes, sir. Please go ahead with your presentation, sir.
Title for my study is Prevalence of Fat Wallet Syndrome in Male Desk Full-Time Worker in Aurangabad. Fat wallet syndrome is caused by sciatic nerve compression by piriformis muscle due to thick wallet kept in the back of pant in prolonged sitting position in male desk worker. Long-term use of heavy wallet may cause the deep-seated piriformis muscle, the lumbosacral spinal segment, and the pelvis to be out of alignment, which would result in fat wallet syndrome specific symptom. Fat wallet syndrome has following synonyms: wallet sciatica, piriformis syndrome, pelvic outlet syndrome, wallet neuropathy, wallet neuritis, credit carditis, and hip pocket syndrome. Need for this study, the fundamental goal of this article is to highlight the effect of fat wallet syndrome from its as impact on individual's health. Men should be advised to maintain a healthy lifestyle and a normal posture. While they sit or do something, they put their wallet in front pocket. The general public must be informed and instructed not to retain extra document, bills, photos, not routinely use credit cards and coins in their wallet as a preventive step. Aims and objective for the study to find out prevalence of fat wallet syndrome in full-time male desk worker in MGM campus Aurangabad Sample size for the study is 385. Study setting was MGM campus Aurangabad. Type of sampling is cluster sampling. Study design was a cross-sectional study and study duration was 6 months. Studies subject was 385 male desk worker. Inclusion criteria was male participant, desk worker sitting with a wallet in back pocket at least for 5 to 7 hours, male desk worker with at least 3 years of experience and between age group 25 to 35 years. Exclusion criteria for the studies any pre-diagnosed medical condition related to the musculoskeletal system and other system in a disability. Outcome measure for this studies clinical scoring system for the diagnosis of piriformis muscle syndrome. This outcome measure included 12 items. In this, one for each item, unilateral or bilateral buttock pain with fluctuating period, no lower back pain, axial spinal palpation, painless, negative lytic maneuver, sciatic pain with fluctuating period without pain throughout the course of the day. Sciatic pain reproduced by extension of clinical maneuver, stretching, resisted contraction are these. Result for the study, this study found that prevalence of hot toilet syndrome in full-time male desk worker with a probable diagnosis is 8.83 by clinical scoring system for the diagnosis of piriformis muscle syndrome. In 385 male workers, 34 with scores greater than or equal to 8 based on the cutoff score of the clinical scoring system. And in this outcome measure, 6 to 8 is unlikely and less than 6 is not considered for diagnosis of piriformis syndrome. Conclusion for this study is the prevalence of fat volute syndrome in full-time male desk worker with probable diagnosis was 8.83%. According to the findings for the study, males should be encouraged to avoid having their wallets in their back pockets while sitting and other activities, and to keep their wallet in the front pockets while sitting, driving, or riding. Avoid prolonged sitting with wallet that causes compression of sciatic nerve, producing symptom of fat volute syndrome. Thank you.
Thank you for your presentation, Dr. Ujbal. Ma'am, you have any question for this presenter?
Kindly go back to your outcome.
Ma'am, I have not included outcome measure in this. Can I tell you this, about outcome measure? Am I audible?
Yes, sir, you are audible.
Yes, you are. Please go ahead.
Ma'am, this questionnaire is this outcome measure is consist of 12 items. Each item has given 1 point. Point number 1, unilateral or bilateral buttock pain with fluctuating period without pain throughout the course of the day. Second number, no lower back pain. Third number, axial spinal palpation painless. Fourth number, negative lytic maneuver. Fourth number, seated position triggering buttock pain and or sciatic pain. Fifth number, sciatic pain with fluctuating period without pain throughout the course of day. Fifth number, buttock pain using stretching maneuver and palpation. And fourth number, sciatic pain reproduced by extension of clinical maneuver and resisted contraction are these. And the score equal to or greater than 8 is considered as probable diagnosis. So score 6 to 8 is considered as unlikely, and below 6 is considered not considered.
Thank you, Ujjwal. It was a nice presentation, and I do not have any specific questions on this. We can move ahead with the next presenter. Thank you, Ujjwal. Thank you so much.
And thank you, Dr. Ujjwal, for your presentation. And the next presenter would be Dr. Aditi Sanjay Nimkar. Dr. Aditi, are you available? Dr. Aditi?
Yes, ma'am.
Ma'am, please take over the session.
Yes, ma'am. Ma'am, is it visible?
Yes, ma'am, it is visible. Please go ahead.
Uh, my title is Prevalence of Knee Pain, Stiffness, and Limitations in Physical Function in Tailoring Professional Using Modified Womack Scale, an observational study. Introduction is occupational knee pain, stiffness, and physical function are painful condition involving nerve uh, and tendon around the knee caused due to repeated activities and bad posture adapted at work. They develop due to repetitive episodes of trauma which gradually comes into existence. The symptoms may vary from pain to decreased body function. This can interfere with activities at work and can lead to reduced productivities and chronic occupational disability. Tailoring professional require prolonged physical activity. Tailor prepare garments as per the choice of customers on deadlines. The main activity performed by the tailors at their workstations are taking measurement for clothing of the customers, cuttings of the fabric, stitching of the fabric on sewing machines, ironing to the stitched garments, and inspection of the final stitched garments. Tailor face a considerable risk of musculoskeletal disorders like muscle pain and injury as the frequency of postural discomfort comfort increases with years of employment. BT Indriani and Anita Camelias and Fikri Faisai in 2020 determined the relationship between working posture and musculoskeletal disorders in tailoring professionals. It has been found that if the muscle receives a static load repeatedly for a long periods of time, it will cause complaints in a form of damage to the joint, ligaments, and tendons. Western Ontario's and McMaster University's Arthritis Index is a valid and highly reliable scale having three components. Pain having 5 items during walking, using stairs, in bed, sitting or lying, and standing upright. Stiffness is having 2 items after first walking and later in the day. Third is physical function having 17 items using stairs, rising from sitting, standing, bending, walking, getting in and out of car, shopping, putting on or taking off the socks, rising from the bed, lying in the bed, getting in and out of bath, sitting, getting on and off a toilet, heavy domestic duties and light domestic duties. Next is a need of the study is there is a limited literature regarding pain, stiffness, and limitations in physical activities, especially in knee joint and tailoring professionals in Indian setups. So hence there is a need to quantify the prevalence of knee pain, stiffness, and limitations in physical function in tailoring professional in and around the Nagpur district. Aim of the study is to measure the prevalence of knee pain, stiffness, and limitations in physical function in tailoring professional using modified Womack scale. Objective is to find the prevalence of knee pain, stiffness, and percentage of functional limitation of knee joint in tailoring professional using modified Womack scale. Then materials used was Womack questionnaire pain. The modified Womack scale consists of 24 close-ended questions. The subjects will be provided with the modified Womack scale and are required to fill the scale. Research design and methodology. Research design, a questionnaire based survey. Settings, VSPM College of Physiotherapy, Nagpur, and tailors in and around Nagpur city. Target population is both male and female tailoring professional in Nagpur district. Duration is 1 year of synopsis and 6 months of data collection. Inclusion criteria is subjects working for more than 5 hours a day for more than 5 years. Both male and female tailoring professional, age ranging between 40 to 65 years. Tailors using paddle sewing machine and automatic machine requiring footwork. Exclusion criteria is subjects suffering from any previous neurological or cardiovascular conditions. Subjects having history of trauma to knee joint and in last 6 months. Subjects having any history of ankle or foot deformity. Result is 100 tailors completed the questionnaire. The result shows that the highest value of WOMAC score is 46 seen in 8 subjects and lowest score was 11 seen in 2 subjects. Highest WOMAC score in percentage is 47.91 and lowest score was 0. Conclusion of the study shows that the highest WOMAC score in percentage is 47.91 and lowest score was 0. Prevalence of knee pain, stiffness, and limitations in physical function was found to be 99%. These are the references. Thank you.
Thank you for your presentation, Dr. Aditi. Ma'am, you have any specific questions for this presenter? Ma'am, can you hear me?
Kindly
Yes.
go back to your inclusion exclusion slide.
Yes, ma'am.
Okay, Aditi.
Yes, ma'am.
Ma'am, we couldn't hear you properly. Your voice is
No,
breaking.
I was just going through the exclusion.
Okay.
Fine, Aditi. This is good enough.
Yes, ma'am.
40 to 65 years. Now, Aditi, there must
Yes,
have been
ma'am.
people working for very long, like 65 years. If they started working, say at the age of 25 or even 30, their work experience, their work duration is much more as compared to a person who is 40 years old.
No, ma'am. The risk of OA increases with age. So, with
Yes,
increasing age,
so a person who is 65 years old is more at risk for OA as compared to a person who is like 40, right?
yes, yes,
And they're all tailors, right? They're all
yes,
tailors. And
yes.
if a 65-year-old male has been tailoring for, say, since the age of 30, and a
Mm-hmm.
person tailoring for since the age of 30 and is now 40. So that person has been tailoring for 10 years. Now, a person who has been tailoring from the age of 30 years and is now 65 has been tailoring for 30 years, 35 years, right?
Yes,
And as the age increases, there is an indication that or the incidence of osteoarthritis will increase,
increases. Yes,
right?
yes,
And we have this entire range, right, from 40 to 65 years on whom we are
yes,
like we are checking the WOMAC scale. Okay.
yes. Mm.
You could have this is the only suggestion that I have. I don't have any questions for you. You could have divided your this age 40 to 65 into two cohorts probably. Instead of taking them into one group, maybe you could have just divided them into like 40 to 55 and then 55 to 65, something of that sort. You would have got a more precise result as compared to the result that you've got for the age group of 40 to 65, because there are other contributing factors as well.
Okay, ma'am. I
That's the
will.
only suggestion. Otherwise, I do not have any specific question for you. So thank you for your presentation, Aditi.
Yes, ma'am.
Thank you, ma'am, for your presentation. And the next presenter is Dr. Manasvi Agarwal. Dr. Manasvi?
Hello.
Yes, ma'am, you are audible. Please
Hello,
start
am
your
I
presentation.
audible?
Yes, ma'am.
Okay, can you please share the slide?
Sure, ma'am. Please wait. Please start your presentation, ma'am.
Okay. Good afternoon, everyone. My name is Dr. Manasvi Agrawal, and my topic for presentation is Work-related stress and burnout syndrome in physiotherapists working in hospitals in Nagpur. Introduction. Burnout syndrome is defined Burnout syndrome is defined by the WHO as an occupational phenomenon characterized by three dimensions: feeling of energy depletion or exhaustion, increased mental distance from one's job, or feeling of negativism or cynicism related to one's job, and decreased professional efficacy. Occupational stress is defined as a set of emotional, cognitive, physiological, psychological, and behavioral reactions of a worker to certain harmful aspects of the content organization of work environment. Occupational stress and burnout syndrome have been linked to weaker personal relationships, individual well-being, and patient care among the doctors. Burnout syndrome is frequent among those in the helping professions, and it is thought to be caused by the constant emotional demands of these jobs. Workplace stress has a negative influence not only on the employee's health and job satisfaction, but also on the organization's quality of output, absenteeism, and attrition rate, all of which have a negative financial impact. Next. Next. Can you please change the slide? Need of the study. In a survey conducted in 2020 among physiotherapists in Cadiz, that is in Spain, a sample of 272 physiotherapists were participated. The findings revealed that 30.51% of physiotherapists had occupational stress, while 34.56% experienced level closer to average. Certain characteristics of physiotherapists would be leading to occupational stress like long working hours, clinical conflicts, the outrageous demands of patients who need the healthcare. As few research on this given topic has been done, we are interested in carrying forward the legacy by conducting study on it. Therefore, occupational stress and burnout syndrome needs to be evaluated in physiotherapists working in different hospitals. Next. Aim. The aim of the study was to determine the work-related stress and burnout syndrome in physiotherapists working in hospitals in Nagpur. Objective: to observe the work-related stress in physiotherapists working in hospitals. Next, to observe the burnout syndrome in physiotherapists working in hospitals. This methodology: sample size is 105. Study setting: hospitals in Nagpur. Type of sampling: by cluster sampling. Study duration: 1 year. Study subject: physiotherapist working in Nagpur. Next. Inclusion criteria was the physiotherapists who are working in hospitals, those who are willing to participate, completely filled questionnaire, physiotherapists working more than 6 hours. Exclusion criteria: physiotherapists who refuse to participate in the study, physiotherapists working in academic section, physiotherapists working for 6 hours, incompletely filled questionnaire. Outcome measures used were workplace stress scale, Oldenburg burnout inventory. Next. Results and discussion. In the study conducted, a total of 105 participants took part in the study, of which 65.71% participants were female. Majority of participants were between 31 to 40 years of age, which is 41.9%. According to Workplace Stress Scale, which has 8 questions, 45 participants felt moderate stress, which is 42.85%. According to Oldenburg Burnout Inventory, which comprises of 16 questions, which was divided into two components, disengagement and exhaustion, consisted of 8 questions respectively, which shows medium risk of burnout among the participants. The first chart shows the percentage of occupational stress level, and the second one shows the burnout level. Next. Conclusion. We can conclude based on the results of the study that occupational stress and burnout syndrome is moderately present in physiotherapists working in hospitals. notes. These are the references of the study. Thank you.
Thank you, Dr. Manasvi. Ma'am, do you have any questions for this presenter?
No, ma'am, I do not have any specific questions.
Thank you, ma'am. And next presenter would be
Thank you, sir.
Dr. Vasavi B. Dr. Vasavi. Dr. Vasavi, are you here? Okay, ma'am. With your permission, can we move on to the next presenter, ma'am? Dr. Ajita? Dr. Ajita? Dear session chair, can we move on to the next presenter? Ma'am, am I audible? Ma'am, am I audible? Participants, kindly have patience and the session chair will be back soon. Dr. Ajita, am I audible?
Yes, yes, ma'am, you're audible.
Yes, ma'am. So with your permission, can we move on to the next presenter?
Sure.
Yes, ma'am. The next presenter would be Dr. Tina. Dr. Tina, are you available?
Yes, ma'am.
Ma'am, please start your presentation, ma'am.
Ma'am, is my screen visible?
Yes, Dr. Tina, please go ahead with your presentation.
Okay. A very good afternoon to everybody. Myself, Dr. Tina Purohit. Title for today is Hand Grip Strength in Auto Rickshaw Drivers and Normal Indian Adult Population, a Comparative Study. Introduction. Hand grip strength is the amount of static force that the hand can generate around the dynamometer and can be defined as ability to hold objects between your thumb and fingers. Hand grip strength is referred to as a reliable and valid objective parameter to evaluate the functional integrity of the hand as a part of musculoskeletal system. Grip strength not only describes hand normality, but it is also used as an objective evaluator for upper extremities in treating hand damage. The most common type of occupation-related mobility conditions faced by auto rickshaw drivers are body pain. They may be of back pain, arms, or neck pain. Auto rickshaw drivers working in transport sector spend more than 8 to 10 hours a day. Need of study. In India, nearly 80% of passenger transportation is handled by road transport sector, with auto rickshaw drivers playing a crucial role in providing flexible and low-cost mobility. Auto rickshaw drivers, due to their prolonged sitting and fixed hand posture, may be at risk of medial nerve compression, potentially leading to carpal tunnel syndrome. Symptoms such as decreased grip strength, tingling, numbness, and pain can develop. This study aims to evaluate grip strength in auto rickshaw drivers compared to the general population, helping to prevent further complications. Aim. The aim of the study is to compare the hand grip strength in auto rickshaw drivers and normal population. Objective: to find hand grip strength with hand dynamometer in auto rickshaw drivers and normal population, and then to compare the grip strength in auto rickshaw drivers and normal population. Hypothesis. Null hypothesis is there will be no change in hand grip strength of auto rickshaw drivers as compared to normal population. Alternative hypothesis, H1 will be there will be reduced hand grip strength in auto rickshaw drivers as compared to normal population. H2, there will be an increase in hand grip strength in auto rickshaw drivers as compared to normal population. Research design and methodology. Sample size is 100. Study and the sample size is divided into two groups, 50-50. 50 for auto rickshaw drivers and 50 for the normal population. Then study setting was in and around Pune. Sampling method was convenient sampling. Study design, comparative study. Duration was 6 months and population was auto rickshaw driver and normal population. Inclusion criteria. Age group was 21 to 60 years, working for minimum 8 hours a day, and males. This was for auto rickshaw drivers. Then exclusion criteria, recent fractures of wrist, deformities of hand and wrist, metabolic diseases, any recent trauma, subjects with recent fractures, neck or upper extremity. Then outcome measure was Jamar baseline hydraulic hand dynamometer. Results, data was analyzed using SPSS software. Mean and standard deviation of data was assessed to check the descriptive statistics for the variables. So the first graph was hand grip strength in auto rickshaw drivers. This is a double bar graph showing hand grip strength of right and left. The right is denoted in blue color and left in orange. And it was compared. And then this is in normal population. The variables and mean and p-values were found out. In conclusion, in this study, it was established that there is significant reduction in hand grip strength in auto rickshaw drivers from 21 to 60 years compared to normal population. There was also a decline in hand grip strength as the age advances. Also, hand grip strength of the left hand was found to be lower than that of right hand. I'm sorry, I needed to present the discussion first. I'm sorry. So the discussion, the data of auto rickshaw drivers was compared with the normal population of grip strength of similar age group. The population was divided into 10-year age groups. The present study noted lower hand grip strength in auto rickshaw drivers as compared to normal population. A study by Valankar P, Verma C, and Mehta A found out that the grip strength generally peaks at the age of 31 to 40 years and then declines with age. It shows curvilinear relationship between age and hand grip strength. That is, there was an inclination and then declination of hand grip strength with advancing age. As the age increases, the muscle strength decreases due to many reasons, such as decreasing muscle mass, changes in size of muscle fiber, and various comorbidities start to play a role. Also, elderly populations suffer from various deficiencies. The type of work done by middle-aged population are more strenuous as compared to elderly. Auto rickshaw drivers sit while driving, but more importantly, they have to sit in a fixed hand posture for long hours while waiting for the fares. The study by Singh LP states due to fixed hand posture for long hours and fixed hand placement, they might suffer from fatigue and pain of muscles of forearm and hand. Also, vibrations due to rough roads may get transmitted and aggravate the above symptoms. Hence, all the above mentioned causes justify the reduced hand grip strength in auto rickshaw drivers. Conclusion: in the study, it was established that there is a reduction in hand grip strength in auto rickshaw drivers compared to normal population. There was also decline in hand grip strength as age advances. Also, hand grip strength in left hand was found to be lower than that of right hand. Henceforth, we accept the alternative hypothesis that the hand grip strength in auto rickshaw drivers was lower as compared to normal population. These are the references. Thank you.
Thank you for your presentation, Dr. Tina. Ma'am, you have any specific questions for this presenter?
Tina, can you please go back to your methodology?
Sure, ma'am. Yes, ma'am.
Okay. Just a second. In Pune. Okay. How did you collect your sample? I'm sorry, I forgot the name of the presenter.
Tina, ma'am.
Dr. Tina, ma'am.
Wasabi. Tina.
No, Dr. Tina.
Yeah.
Ma'am.
Hello, Tina, am I audible?
Now only you are audible, ma'am. Please go ahead, ma'am.
Yeah. So I'm asking you, how do you collect this data? I mean, you personally approached the auto rickshaw drivers for this?
Yes, ma'am. I went to a few like auto rickshaw stands and I checked their I took their like
Okay. Can you come to the can you explain me the method through which you have checked this hand grip strength?
ma'am. So I went there and I took their name and I checked that if they are fitting in my inclusion criteria, that is from 21 to 60 years. Then I checked the hand grip strength of both the hands. Best of three were noted.
Please come to please come to your inclusion criteria slide.
Yes, ma'am.
Can you we are currently on research design and methodology. Can you please shift it to the slide? Yes. 21 to 60 years, minimum 8 hours. Again, my same question exists here, that hand grip for a person who's
You are not audible.
Ma'am, you are not audible, ma'am.
okay, what I'm saying is a person who is 21 and a person who is 60 years, right? We are keeping them in the same group and checking their hand grip.
Ma'am, actually,
Tina, age will definitely. Yes.
Yeah, ma'am. That's why a group of 10 years, like 21 to 30, 31 to 40 was made, and then the group was like assessed, which strength was assessed.
Okay, so you have cohorts inside this group? Okay, 21 to 30, 31 to 40, 41 to 50, 51 to 60.
So what I got to know that the age was, as the age was advancing, the grip strength was reducing, and the group 31 to 40 had the like more grip strength, highest of all.
And was there a comparison between normal population and the auto rickshaw drivers? I mean, intergroup?
Yes, ma'am. There was a comparison.
Can you please come to that as well? Now, see, this is between the auto rickshaw drivers in different age, and this one is in normal population. Okay. And the one in which we are comparing the auto rickshaw drivers with the normal?
That I did not
To bother you going back to the slide super bad today. The next slide, in which you have, I think, paired the auto rickshaw one with the normal population. Yes. Okay. What was the result of this, Tina? What was the result for your auto rickshaw? The comparison between normal?
So it was reduced, ma'am, as compared to normal ones. Like normal population had more grip strength as compared to auto rickshaw drivers. And also the left hand grip strength was less than the right right.
Okay, and what was their handedness, Tina? Did you check that? I mean, otherwise, were they right-handed or left-handed? Was there any difference in that? Like, for example, usually the people who are left-handed, they have a better grip in their left hand as compared to the right. So, was there any right-handed or left-handed kind of differentiation between the people in the population?
Oh, ma'am.
Because you've got 100 people now. So, some of them might have been lefties, left-handed.
Oh, ma'am, they all were right. The dominant
They all
hand
were right? Was right? Okay. So, in that case, all you have to do is just add this point in your inclusion. That's all. Right? Because see, people who are lefties, usually they have better strength in their left as compared to right. The people who are right-handed have a better grip in their right hand as compared to left. So even that will affect the outcome of the research. Otherwise, it is a wonderful research. Thank you so much for listening.
Thanks for your presentation, Dr. Tina. The next presenter would be Dr. Namastri Vishikar. Dr. Namastri? Dr. Namastri?
Yes, ma'am.
Please go ahead with your presentation, ma'am.
Namastri. Okay, association between head posture. Right.
Yes, ma'am.
Can I start, ma'am?
Yes, ma'am. Your time starts now.
Good morning, everyone. My topic for presentation is association between head posture and disability of patients with neck pain, an analytical cross-sectional study. Introduction. Neck pain is a frequent issue leading many individuals to seek physiotherapy. Assessing patients with neck pain typically includes evaluating head posture as deviations from the normal posture. Neck pain is assumed to have multifactorial causes, implying that there are number of risk factors contributing to its development. Clear, acute biomedical causes, but also socio-demographic factors and factors related to general health, work situation, and leisure activities could be important in the occurrence of neck pain. In addition, work-related risk factors are abundantly illustrated. A maladjusted, stressful work environment, several physical variables, and psychosocial factors such as insufficient job satisfaction and high job demands could contribute to the development or maintenance of neck pain. Valuation of head and shoulder posture has commonly considered the profile alignment of the body parts with respect to trunk. Alignment has been deemed poor when the head is held forward in relation to the trunk or when the shoulder appears slouched forward. My need for study is neck pain is common symptom in the general population and a frequent cause of disability. Abnormalities in head postures are often considered to be associated with the development and persistence of neck pain. Poor posture, which is commonly seen in sedentary occupations or activities, can put additional stress on the neck and upper back muscles and cause strain or pain. Thus, to evaluate the relationship between head posture, severity, and disability of patients with neck pain, the study was taken. Aim and objective of the study is to study the association of head posture and disability in patients with neck pain.
research design and methodology. Sample size was 32. Study setting was physiotherapy OPD of ESPM's College of Physiotherapy. Type of sampling is convenient sampling. A study design is analytical cross-sectional study. Study duration is 18 months and subjects were without neck pain and with neck pain aged above 20 to 30 years. Inclusion criteria: subjects from physiotherapy OPD, both males and females, subjects without neck pain and other problems refer to physiotherapy treatments such as knee pain, sprained ankles, tennis elbow, etc., and subjects with neck pain. Exclusion criteria are history of cervical fracture or trauma, history of cervical surgery, idiopathic scoliosis, bone cancer, and spasmodic torticollis. Outcome measures are craniovertebral angle, coronal head tilt angle, coronal shoulder angle, sagittal head tilt, neck pain disability using neck pain questionnaire, and severity using neck NPRS. Results are: the study found that participants with severe disability had a more reduced craniovertebral angle, indicating an inverse relationship between the disability and craniovertebral angle. However, there was not much difference in the remaining angles among the participants with varying levels of disability. This suggests that the craniovertebral angle may be a more sensitive indicator of disability-related changes in spinal posture than other angles measured in the study. Discussion results suggest that individuals with neck pain have a more extended neck posture compared to the pain-free individuals, but the positions of the shoulder and head do not differ significantly. However, further research is needed to confirm these findings and to explore other possible factors contributing to neck pain. Forward head positions reduce the angle between the skull and the vertebra, causing discomfort in the pain and spine. Prolonged forward head posture might increase the loading to the non-contractile structures and abnormal stress on the posterior cervical structures and cause myofascial pain. Good posture is important for everyone, particularly for those with disabilities, to prevent problems caused by poor alignment. Addressing issues related to the forward head posture and craniovertebral angle is crucial in maintaining the good posture. Conclusion of the study has investigated the association between head posture and disability in patients with neck pain. So the findings of the study demonstrate that there is a relationship between the head posture and disability in patients with neck pain. Specifically, patients with forward head posture exhibit higher levels of disability compared to those with normal head posture. These are my references for the study. Thank you.
Thank you, Dr. Namastri, for your presentation. Ma'am, you have any questions for this presenter?
Ma'am, just give me 1 minute. I need to go through this again. Just one. Okay. Namashri, again, can you please go back to your methodology? Am I audible?
Yes, ma'am.
Hello?
Yes, ma'am, you are audible.
Namashri, am I okay? Yes. $20 to $30. Okay. Inclusion, exclusion, Namashri? Okay, Namashri. I don't have any specific questions for this. I was just checking your inclusion criteria. Thank you for the presentation, Namashri. It was a good topic, and your outcome measures are really extensive. And I don't know, how did you manage taking so many outcome measures? You did it yourself, or you had help from some colleagues or someone? You measured all these on your own? Yes. And can you, like, next time just add a few pictures, the devices that you have used to measure this? There was, have you devised something new for measuring this, or have you used the same conventional devices that are? Yes. Namisha, you're not audible.
Hello.
Hello. Yes. It's okay if you are. Please, you were saying something.
Goniometer. I use goniometer for the measuring the angles.
Goniometer for all the angles?
Yes, ma'am.
Right your head. All of this. Did you require to make any modifications to the existing goniometer, or were you able to just simply check all these using a goniometer, simple goniometer?
Directly on the patient, and for other angles, I take the photographs and I take the printout of the images and then measured. Hello.
Can you present it? Yes, you are audible. Thank you. It's a wonderful topic, Namashri. You can probably extend it, go with a little more number of patients. You can actually get a good publication out of this. Your outcome measurements are also amazing. You can just increase the number of sample that you have. It's a nice topic. Thank you so much for presenting.
Thank you so much.
Thank you, Dr. Namastri, for your presentation. And the next presenter would be Dr. Mrunmayi Mankar. Dr. Mrunmayi?
Yes, ma'am. Can I share my PPT?
Sure, ma'am. You can do that.
Good afternoon, everyone. I am Dr. Mrunmayi Mankar. For today, my topic is effect of square stepping exercises versus Otago exercise for elderly to prevent fall and injury related to fall. It's a comparative study. Introduction. Fall and poor bone health are the major cause of disability and accidental home deaths in older population. Fall among old adults are a serious public health problem that can cause a fatal injury, sometimes also affect psychosocial status and, more importantly, quality of life. About 80% of disabilities stemming from unintentional injuries, which excluded traffic accidents and in adult age 50 years and over, resulted from falls. Fall is preventable event. One way to prevent fall is through training. Walking is a widely acceptable exercise and is used as a mean to develop functional fitness in population-based fall prevention program. However, older adults may experience difficulty in walking in unfavorable weather conditions such as rain, wind, cold, or heat waves. Furthermore, the fear of injury, disease, accident, and crime may prevent from them from walking. I would like to explain square stepping exercise. It is aimed to maintain and improve elderly people physical and cognitive function. As adult faces this situation in daily life, we have attempted to develop square stepping exercise that they can perform indoor, composed of movements similar to walking. And in Otago, it contains 17 strength and balance exercise can be done in home, outpatient, community setting, and group setting. Need for the study. Fall are the main cause of morbidity, disability in elderly. More than one-third of person 50 years of age or older fall each year, and in half of such cases, the fall are recurrent. Aim to find out the effect of square stepping exercise versus Otago exercise for elderly to prevent fall and injury related to fall. Objective to study the effect of square stepping exercise in elderly. To study the effect of Otago exercise in elderly, to compare the effect of square stepping exercise and Otago exercise in elderly using the scale of fall of efficacy, functional reach, and time up and go. Methodology, study design, comparative study, method and sampling, simple random sampling method, sample size 38, study setting old age home, duration of study 6 months. Hypothesis. Alternate hypothesis, there is a significant difference in square stepping exercises in elderly to prevent fall and fall-related injury. There is a significant difference in Otago in elderly to prevent fall and fall-related injury. There is a significant difference between square stepping exercise and Otago exercise in elderly to prevent fall and injury related to fall. Null hypothesis, there is no significant difference between square stepping exercise and Otago exercise in elderly to prevent fall and fall-related injuries. Inclusion and exclusion criteria. Inclusion criteria, both male and female, subject of and above 65 years of age. Exclusion criteria, fracture of lower limb and any ankle trauma, vestibular impairments, visual impairments, severe neurological and cardiovascular condition. Results. Result. The present study included 38 subjects with risk of fall who met the inclusion criteria. The subjects were equally divided into two groups by simple random sampling method consisting 19 participants in each group. It shows pre and post intervention reading the square stepping exercises. The mean and SD of pre fall of efficacy is 50 and post mean SD is 37. The result is statistically significant with p value is more than 0.01. It shows effectiveness after intervention. The mean and SD of pre-functional reach test is 12 and post-mean SD is 17. The result was statistically significant with p-value is more than 0.1. It also shows the effectiveness after intervention. The mean and the standard deviation of pre-time up and go is 21.63 and post-mean is 16.42. The result was statistically significant with p-value is more than 0.01. It shows the effectiveness after intervention. This is the graph for the scales, and this is the graph for intergroup, group 1 and group 2. It shows intervention reading of group A, follow-up efficacy mean is 37.53, functional reach mean is 17.68, time up and go mean is 16.42, where it compared to group B, fall efficacy value of mean is 41, functional reach is 11, time up and go mean is 21. The obtained value is 0.52, which indicate there is no statistical difference between group A and group B in follow-up efficacy. The obtained p-value is 0.01, which is rich. The obtained p-value is 0.64. It's not significant for time up and go. Conclusion: the present study concluded that 4 weeks of square stepping exercise and Otogo exercise program are equally effective using time up and go, follow-up efficacy and functional reach in reducing risk of fall and improving balance. In addition, results supported that square stepping exercise and Otago exercise, square stepping exercise is more effective in reducing risk of fall, improving balance using follow-up efficacy, functional reach and time up and go test. Hence, square stepping exercise can be safely used as intervention for reducing risk of fall and to prevent fall-related injury. Clinical implication. Square stepping exercise is found to be significantly effective in preventing fall-related injury by improving balance. When we see the applicability of square stepping exercise to our setup, it is easy, cost-effective, and can be applied in group. Therefore, awareness and practice training shall be conducted for health professional and healthcare community on the effectiveness of square stepping exercise to prevent fall, and it can be used as a home-based treatment and can also be implemented among elderly of age 50 and above in order to augment their well-being, and it will also aid in improving physical fitness, and it will help to reduce risk of fall and improving quality of life. It will also help individual to participate in various activities during daily life. These are my reference. Thank you.
Thanks for your presentation, Dr. Mrinmayi. Ma'am, you have any questions for the presenter?
Mrinmayi, can you please go back to inclusion exclusion?
Yes, ma'am.
Okay, and your sample size was?
38, ma'am. 19 age group.
Okay, and did you screen them for any kind of osteoarthritis, degenerative changes, or anything of that sort?
No, ma'am. I only include both male and female and excluded the exclusion criteria.
Okay, and please come to your outcome measure.
Ma'am, I didn't mention anything, but I used follow-up efficacy, functional reach, and time up and go test.
Now, time up and go test will be affected if the person above the age of 65 is suffering from osteoarthritis which is a very common condition in elderly?
Yes, ma'am. Yes, ma'am. Ma'am, it can be.
So we haven't done anything to exclude that thing. Maybe you
No,
could
ma'am.
have included the people who were not having that kind of acute pain at that particular time, or maybe who have similar kind of conditions,
Pain.
probably.
Yes, ma'am.
Just
We can.
just pay a little more attention on your inclusion. Rest everything
Yes,
was
ma'am.
good.
Yes,
Thank you
ma'am.
so much.
Yes,
Thank
ma'am.
you.
Thank you.
Thank you for your presentation, Dr. Mrinmayi. And the next presenter would be Dr. Namisha Dasrath Bishikar. Dr. Namisha?
Audible?
Yes, ma'am, you are audible. Please start your presentation, ma'am.
Good afternoon, everyone. My topic is the prevalence of upper trapezius myofascial pain due to tight innerwear in female students aged 18 to 25 years. It is an observational cross-section study. The trapezius muscle is one of the largest muscles in the back. It is often a site where stress is steady, particularly in its upper region, which elevates the scapula. Myofascial pain, characterized by discomfort in muscles and fascia, involves sensory, motor, and autonomic symptoms, including referred and localized pain, decreased range of motion, and weakness. These pain can arise from various factors such as tight clothing, structural inadequacy, stomach issues, and inflammatory diseases. In the context of the upper trapezius, tight brachiosaurus strap can lead to chronic muscle contraction, increasing pressure on the muscle fibers. These may cause ischemia due to narrowed arteries and restrict scapular movement, adversely affecting posture. The aim and objective of my study is to find the prevalence of upper trapezius myofascial pain due to tight innerwear in female students aged 18 to 25 years. Objective to find the prevalence of upper trapezius myofascial pain due to tight innerwear in female students aged 18 to 25 years using questionnaire. Need for the study: the wearing a wrong brachiosaurus size can cause a serious musculoskeletal problems and neurological problems such as back pain, exercise, inducing breast discomfort, upper limb neural symptoms. Due to tight brachiosaurus strap, the musculoskeletal symptoms could be the pain, soreness, pectoral girdle, myalgia, etc. They restrict movement and have effect on posture also. Pain related to brachiosaurus feet may manifest as shoulder grooving, back or neck pain, and neuropathic symptoms in upper limbs. Thus, this is the need for study. Research design and methodology. Sample size was 84. Target population was female students aged 18 to 25 years. Study setting in and around the Nagpur. It is a convenient sampling. Study design, it is an observational cross-sectional study. Study duration 80. The inclusion criteria for the study: female students aged 18 to 25 years, no pathology and injury in the neck, shoulder, upper back, and arms from last 3 months. Any recent fracture of shoulder, neck, and upper back, and those who are not voluntarily willing to participate were excluded from the study. This is the questionnaire which I use, which include the basic demographic data, the brachiosaurus knowledge, the duration of the daily usage, brachiosaurus method, type of brachiosaurus used, how it is born, occurrence of pain, current history of pain in last 12 months, nature and type of pain, frequency of upper pain and requirement of treatment of pain, frequency of factor reported to affect upper trapezius myofascial pain, factors that worsens the pain, and factors that reduces the pain onset and duration. The 5.9% upper trapezius myofascial pain, which are found to be quite prevalent among our studied subjects. We observe a 12-month prevalence of 20.4% and a point prevalence of 77.2% for this condition. Interestingly, the majority of the subjects with upper trapezius pain, that is 90.9% reported not preparing any treatment in past 12 months. These raises questions about the self-management strategies that individual might be using to cope up with this discomfort. In fact, only 9% of subjects or students indicated they use self-medication, and notably none reported receiving treatment in hospital settings. Table 2 suggests that we found that 45.2% of subjects reported wearing a bracelet for all day. In contrast, a small percent, that is 10.7%, indicated they only wear during working hours, while 41.6% wear it for both all day and all night. These findings suggest that a significant number of participants or the subjects are wearing bracelets for prolonged period of time, which raises important consideration regarding comfort and potential and MSK musculoskeletal implications. Extended wear can affect posture and may contribute to discomfort or pain, particularly in the upper body. The table 3 shows that 65.9% of women reported experiencing pain after wearing a bracelet for more than a few hours. Among these individuals, 4.5% reported pain specifically related to thin straps, while a notable 29.5% attributed their discomfort to tight straps. Interestingly, our data also highlighted effective strategies for elevating this pain. The most commonly reported methods were taking off the bracelet, with 81.8% of subjects indicating this as a relief factor, and losing the strap, which is 18.1% of participants. These findings underscore the significant impact that bracelet design can have on comfort and well-being. Given that a sustained number of women experiencing discomfort, it prompts us to consider the importance of educating about the proper fit and the potential ergonomic effects of bracelet. Conclusion. The study concluded that upper trapezius masseter pain was common among the subjects with a 12-month point prevalence of 20.4% and a point prevalence of 77.2%. These are the references for my study. Thank you.
Thanks for your presentation, Dr. Namisha. Ma'am, you have any questions?
I have a question. Am I audible?
Yes, ma'am.
It was a very nice topic. Can you go back to your first slide of the title? So my question is, you are looking at the prevalence of upper trapezius myofascial pain due to tight innerwear. By tight innerwear, you meant bra. So how in your patient you decided whether the person is wearing a tight bra or she is wearing a comfortable and good size bra? So how did you ask any question that are you wearing a comfortable bra or a tight bra? So is there any question that was included in your questionnaire or initial observations?
Yes, ma'am.
Do we still have the speaker with us?
Yes, ma'am.
Yes, ma'am.
So did you get my question or shall I repeat it again?
Dr. Prachi, your voice is not audible. Can you please?
Okay, Namisha.
Okay.
Namisha. What ma'am is trying to ask you is that how did you decide that the bra was tight or it was uncomfortable to the patient? Did you include any questions? Was there some kind of specific measurement or anything that you did to evaluate that the bra that the patient is wearing is tight? How would you judge that the person is wearing a tight bra or a bra which is not well fitting?
And I have asked questions to them.
Okay, we were not able to hear you, Namisha. Can you please come again?
Am I audible?
Yes, now you're audible. Please go ahead.
I have asked questions to them.
Okay, what were the questions? Are those questions included in this questionnaire?
Yes, ma'am. The reported brachythy size.
Okay, so can
And I
you go
have
to the
measured
next page? Next page of the questionnaire. Okay. Congruent, incongruent, brazier size after measurement.
size.
So you measured for this? Did you measure anything? Any kind of measurements was taken that this is the strap size that they should have been wearing, but they're wearing something that is tight?
I've measured the burst size and
Okay.
I compared with the brachythy size they have reported to me.
Okay. Okay. Got it. Please.
Okay. So that was the answer. So that was the answer for my question. I hope I am audible. Am I audible now?
Yes, ma'am, you are audible, ma'am.
Okay. That answers my
Namisha, just one more question. Did you convert your questionnaire into any other language or was it only in English?
In English.
So don't you think converting your questionnaire by making it bilingual or maybe converting it in the local language would help them understand things better? It will help the person who is filling the questionnaire or understand the questions in a better way.
Yes, ma'am.
Because see, you have used pretty technical terms: radiating pain, localized pain, dull aching. So these are very technical terms. A physiotherapist might understand it, but even a well-educated layman person will not understand it. You know, if I tell an IT person that do you have radiating pain or have localized or dull pain, probably he won't be able to differentiate from all these three what kind of pain it is. Your question is to be filled by the patient or by you. You will be filling the question paper or questionnaire, or the patient will be filling the questionnaire.
So will be filling the questionnaire in front of me.
Okay, so the person will be sitting in front of you and filling the questionnaire. But still, like, you know, for every question, if you can translate this questionnaire into their local language or at least in Hindi, probably it will be more easy for the person to understand us. Like, for example, congruent word, incongruent. Now, these are certain words that probably people might not understand, especially the ones who are not very well educated, not very literate. They won't be able to understand the questionnaire. Just this is just a suggestion, but next time, whenever you either you elaborate this research or you try using a questionnaire in any other research, just convert the questionnaire into the local language first.
Sure, ma'am.
Right?
Yes, ma'am.
Okay, Namisha. Thank you for your presentation.
Dr. Prati, you have any question for this presenter?
No, ma'am, I don't have any other question. I just wanted to ask this one.
Ma'am, your voice is not audible.
Yeah, I'll repeat her answer. She said she had just one question. That was what she asked. The first question was hers. She doesn't have any more questions for Namish. Thank you.
Thank you, ma'am. Thank you. And the next presenter would be Dr. Yogita Santosh Narare.
Yes, ma'am. Can
yes,
I share
please
PPT?
start your presentation.
Okay. I am Yogita. Good afternoon, everyone. My topic to compare immediate effect between tendinous pressure and maintain stretch in roots inhibitory technique on reduction of upper limb spasticity in patient with stroke, an experimental study. Introduction. Stroke is a sudden loss of neurological function caused by interruption of blood flow to the brain. It's second leading cause of mortality in the most of country around the globe. In survey taken, nearly 750,000 individuals have stroke and 150,000 die from stroke every year. Remaining 6 lakh people individuals suffers from movement disorder. Roots approach is a very common therapeutic approach to rehabilitate of people with neurological disease. Introduced by Roots in 1950, one of the goal of the Roots method is to increase or decrease muscle tone. Manual pressure is applied to tendinous insertion of the muscle or across long tendon to produce an inhibitory effect in the tendinous pressure. Stretching is currently the most commonly used technique to management of the spasticity. Need for study. Previous literature regarding spasticity and its management gives significant improvement in reducing spasticity with Roots approach that included electrical muscle stimulation, proprioceptor neurofacilitation, passive stretch, myofascial release, electromyograph, biofeedback, motor learning, and Roots inhibitor technique. By reviewing all literature regarding spasticity and its management in the patient with stroke, we found that Roots inhibitor technique had found improvement in reducing spasticity. These include light joint compression, slow stroking, tendinous pressure, and maintained stretch. This study will be helped to evaluate immediate effect of two Roots technique, that is tendinous pressure and maintained stretch, in reducing spasticity and help to therapists choose the appropriate technique while giving the treatment in clinical practice. Aim and objective to compare immediate effect between tendinous pressure and maintained stretch on reducing upper limb spasticity in patient with stroke. Hypothesis. Alternate hypothesis, there is difference between immediate effect of tendinous pressure and maintained stretch of reducing upper limb spasticity in patient with stroke. Null hypothesis, there is no any difference between immediate effect of tendinous pressure and maintained stretch on reducing upper limb spasticity in patient with stroke. Methodology, study population, patient with stroke, study setting, physiotherapy department in tertiary care hospital. Study duration is 6 months, sample size 18, 9 patients in each group. Inclusion criteria, both male and female patient with age group 35 to 70 years. Second, patient include subacute and chronic stage. Third, patient having spasticity grade more than 1 according to modified Ashworth scale. Mini-mental examination scale having score 24 or more. Exclusion criteria, patient who currently receiving drugs to reduce spasticity, frequently epilepsy, hypersensitivity of skin, patient who are not willing to participate, or no non-cooperative patient. Cases suffer serious complications such as heart failure, acute myocardial infarction, renal failure, serious lung infection, and cancer. Procedure. Participants were screened according to inclusion and exclusion criteria. Written informed consent was obtained from the all participants. Baseline assessment was the taken with outcome measure, that is modified Ashworth scale. Patients were allotted randomly in Group A and Group B. Group A, which gives tendinous pressure on bicep tendon with 4 sets 30-second hold, and Group B maintain stretch on bicep muscle, maintain stretch on bicep muscle, 3 sets 30-second hold, 10-second relaxation between one repetition. After intervention, all the participants will assess with the outcome measure, and result is evaluated. Result. All demographic data of the patient table 1, which included 80 patients of having spasticity on bicep, were involved in study in which 3 are female and 15 are male. Were included 9 in each group were taken in study. 8 patients had involvement in right side of the and 10 on the left side hemiparesis. Patient included. We were found pre and post intervention score comparison within group A. Result between pre and post intervention using pair test and data shows as statistically significant for the modified Ashworth value when comparison within group A tendinous pressure. Table 3, where we were found pre and post intervention square comparison within group B. Result between pre and post intervention using pair test and data shows statistically significant for modified Ashworth value when comparison within group B, that is maintained stretch. Table 4, post-intervention comparison between Group A and Group B. Result between pre and post-intervention data shows unpaired t-test and statistically significant when compared between Group A and Group B as per. Conclusion, tendinous pressure technique is highly significant than maintenance stage in the reduction of spasticity immediate after intervention in stroke patient. According to modified Ashworth scale, statistically significant of maintenance stage found to be effective in reducing spasticity when compared within the group. Limitation of the study. The major limiting factor of the study was small sample size. So the future study can be done by taking a large sample size. In the present study, the immediate effect of tendinous pressure and maintenance stage in study. So the future study can be done to see long term effect. In present study, improvement in bicep muscle spasticity was seen. So the future study can also be done to see the effect of tendinous pressure and maintenance stage on all affected muscles. Third, there was absence of control group in the present study. So the inclusion of the control group can be recommended for future study. In this present study patient, those who were cognitive not well, not included, so the future study can also be including them. These are all references of my PPT. Thank you, ma'am.
Thank you for the presentation, Dr. Yogita. Ma'am, you have any questions for this presenter?
Yogita, can you give me a short description about how you applied this tendinous pressure technique? How is it performed?
Patient is lying in supine position. Then
Okay.
elbow is in extended position.
Hmm.
In end range. Give the
Okay.
pressure by thumb pad.
Okay. At what area of the elbow?
Tendinous, ma'am. Insertion of bicep tendon.
Okay. Fine, Yogita. Okay, Yogita, it was a good topic. Thank you for presenting it. I do not have any specific questions for your research. I'll just ask Prachi ma'am if she has got any questions. I'll just let you know, right? Our network is acting up a bit, so I'll just ask her in case she has any questions.
Okay.
Thank you for the presentation. I don't have any specific question for
Yes,
this.
ma'am, you are audible.
Okay, ma'am.
So thanks for the presentation, Dr. Yogita. And the next presenter would be Dr. Shivani Belkor.
Yes, ma'am. Am I audible?
Yes, ma'am, you are audible. Please start your presentation.
Okay, ma'am. Ma'am, my slide is visible.
Yes, ma'am, visible. Please go ahead.
Okay. Good afternoon, everyone. Myself, Shivani Belkode, and my topic is effect of resistance exercise in COPD patients. Introduction. Chronic obstructive pulmonary disease is the most common chronic lung disorder, primarily encompassing chronic bronchitis and emphysema and small airway obstruction. It is characteristic by chronic inflammation in the airway and lung parenchyma, leading to progressively irreversible airflow limitations. Beyond pulmonary symptoms like dyspnea, coughing, chronic cough, and sputum production, COPD also cause extrapulmonary issues such as reduced physical activity, exercise tolerance, fatigue, and peripheral muscles dysfunction. Resistance and breathing exercise are vital for improving muscle strength, endurance, and exercise tolerance, significantly enhancing the quality of life in COPD patients. Medications such as bronchodilator also play a crucial role in symptom management. Diagnosis and severity grading followed by gold criteria based on spirometry, particularly the FEV1 and FVC ratio. Need to study. The study addressed the lack of information on the combined effect of breathing technique and resistance training on the expiratory volume in COPD patient. While resistance exercise improve strength, airflow limitations during exercise this research will explore how combined breathing maneuver and resistance training enhance lung functions in COPD patients. Aim to investigate the prevalence of resistance exercise with breathing maneuver in COPD patients. Objective to investigate the effect of combined breathing technique with resistance exercise on functional capacity and improved volume in COPD patients. Hypothesis. Null hypothesis. There is no statistically significant effect of resistance exercise in COPD patient. Alternate hypothesis. There is statistically significant effect of resistance exercise in COPD patient. Method. Study design. Pre-training and post-training experimental study. Study setting, District Hospital Bhandara. Study population, grade 1, grade 2 COPD patient. Sample size is 55 patient. Study duration is 4 months. Inclusion criteria, age 40 to 60, both gender. Admitted patient in wards, diagnosis COPD. Grade 1 and grade 2 COPD patient. Exclusion criteria, cardiac dysfunction and cardiac abnormality. Other respiratory disorders, patient with a neurological dysfunction. Material. The clinical COPD questionnaire is valued for its brevity consisting of only 10 items that are easy to use in a clinical setting. It measures the health status of patients with COPD across 3 dominants: symptoms, dyspnea, cough, and pain, mental state, feeling of depressions, and concerns about breathing and functional state. The simplicity makes it an effective tool for assessing the impact of COPD on a patient live in routine clinical practice. And the MMRC cell dyspnea scale in straightforward tool for assessing respiratory disability by measuring how breathlessness affect daily activity. Result. This is the graph showing result for 6-minute walk test for pre-training and before pre-training and after training. This is the graph for dyspnea, and this is for pulmonary function test in a patient with grade 1 COPD. Discussion. That study demonstrated that resistance training positively affect health status in patients with grade 1 COPD, potentially marking a significant advancement in early disease management. Resistance training helps break the cycle of dyspnea, deconditioning by promoting an active lifestyle, improving exercise capacity, and enhancing the quality of life. Although compliance and supervision play a crucial role in resistance training effectiveness, delayed reporting on a resistance training protocol and training variable is essential for reproducibility and implementations in clinical practice. The study from the district hospital further supported the resistance training enhancement muscles, strength, power, and endurance, leading to increased exercise tolerance in COPD patients. Conclusion. The study improving 55 grade 1 COPD patients aims to provide valuable insights for design effectiveness resistance training intervention. The finding will help to establish the evidence-based recommendation for key resistance training variable. Although the current evidence is of low to moderate quality, the use of resistance training to improve the ventilation and muscle strength in a COPD patient show promise and should be considered conditionally. This is the reference. Thank you.
What are the resistance exercises that you have used for these patients? Am I audible?
Yes, ma'am.
Shivani, am I audible? Okay. Yes.
Yes, ma'am.
So what are the resistance exercises that you?
Ma'am, I have used TheraBand for resistance training. I have given chest press, squats, and shoulder press with the help of TheraBand.
and thoracic expansion with weight cuff. Thoracic expansion with weight cuff, ma'am. How was that done? Ma'am, with the weight cuff is hello, ma'am. Where did you place the weight cuff? In hand, ma'am. In hand. And
Yes.
then the patient was supposed to do thoracic expansion. Thoracic expansion. Okay. So, what was the position of the hands? Like they were
Position of-
abducted or they were in the normal hanging
In
position
flexion,
and
flexion and abduction. Firstly, I have done flexion and then I've firstly I have done
you've done
flexion.
abduction.
Yes.
Okay. Okay. And what were your outcome measures?
The outcome measure was CCQ scale, ma'am, and MMRC scale for dyspnea.
Okay, both are subjective.
Yes,
right?
ma'am.
Dyspnea scales are subjective. Yes. So any
Yes.
objective outcome that you might have tested?
A spirometry was
Yes.
there.
Okay, so you did spirometry post and pre and post for all the patients?
Yes, ma'am.
Okay, did you get any change in that as well?
Yes, ma'am. Before treatment, it was only 600 cc, and after treatment, there was a few changes in ratio, that has been 900 cc for inspiratory and expiratory both.
This is what 900 cc is what? Acha, this is incentive spirometry. You did not go for the proper diagnostics spirometry?
No, ma'am.
Okay. Just one more question, one last question. Was there any other therapy being used apart from resistance training, like chest PT or maybe active chest
No,
clearance techniques?
not chest PT, but conservative method was given, like pursed breathing, diaphragmatic breathing, segmental breathing was given to the
Why pursed breathing? Why pursed breathing? What was the indication for pursed breathing? Hello? Am I audible?
Yes, ma'am.
Shivani, am I audible? Yeah. So what was the
Yes,
indication for pursed breathing? Why did you give pursed breathing to the patient? Okay, no problem.
For
Another thing, as you
expiration.
yes, for expiration, but why pursed breathing? The patient
Yes.
could have the patient could have done exhalation through nose as well. No? Why pursed breathing? Was there any changes in the auscultation, lung sounds?
Yes, ma'am.
So what was it? What did you hear in the lung sounds? And okay,
Air
we are
entry
giving
was.
diaphragmatic breathing.
Yes, ma'am.
Okay, fine, Shivani. You
Thank you,
need
ma'am.
to research a bit more on this topic because see, COPD, the major problem is mucus plugging. So if the mucus
Yes.
plugging can be removed, rest all techniques can be assessed only once the mucus plugging is gone. If the patient still has mucus plugging, probably the results of any other technique won't be as good as you are expecting them to be. So the first thing that you need to administer in a COPD patient, the basic treatment is airway clearance techniques. That can be active as well. Active in sense ACBT or maybe AD, whatever. You can give any of these. But you need to do this before you give them any other treatment. So next time if you're researching on COPD, just make sure that your group, if there are two groups, both the groups should get a basic ACT and then any other added. Right?
Okay, ma'am. Okay, ma'am.
Okay. Thank you. Thank you for your presentation.
Thank you, ma'am.
Thanks, Dr. Shivani, for your presentation. And the next presenter is Dr. Mayuri Kohale.
Yes, ma'am.
Yes, ma'am. Please go ahead with your presentation.
Hello.
Yes, ma'am.
Ma'am,
Is screen visible?
Yes, Dr. Mayuri.
Yes. Good morning, everyone. I am myself Mayuri Kohore. Today I will be discussing on awareness of stress urinary incontinence and its physiotherapy management among female basketball players, a questionnaire-based observational study. And introduction, urinary incontinence is believed to be one of the most health problems in 21st century. According to the International Continence Society, urinary incontinence is defined as any complaint of involuntary urinary loss, which can be considered a common problem among women with a rate prevalence which ranges from 10% to 55%. Urine loss in athletes seems to be related to how frequently women are subjected to increased intra-abdominal pressure, which is caused by contraction of abdominal muscles in high impact and strengthening activities without proper awareness of pelvic floor muscles. Basketball players are often subjected to 2 hours of training up to 4 times a week, plus games during the weekend. This athletic training often consists of long distance running, sprinting, lunges, jump, and weightlifting.
The presenter's voice is not audible.
Yes, ma'am. Am I audible? Ma'am,
Dr. Mayuri?
Yes, am I audible?
No, ma'am. Your voice is too low. Can you please check your audio, ma'am?
Am I
Yes, ma'am.
audible?
Yes, ma'am. You're audible now. Please go ahead.
Okay. Shall I start from the beginning? Shall I start from the beginning?
I'm sure, ma'am.
Okay. Title. एक minute. My title is Awareness of Stress Urinary Incontinence and its Physiotherapy Management Among Female Basketball Players, a questionnaire-based observational study. Introduction. Urinary incontinence is believed to be one of the main health problems in the 21st century. According to International Continence Society, urinary incontinence is defined as any complaints of involuntary urinary loss, which can be considered a common problem among women with a rate prevalence which ranges from 10% to 55%. Urine loss in athletes seems to be related to how frequently women are subjected to increased intra-abdominal pressure, which is caused by a contraction of abdominal muscles in high impact and strengthening activities without proper awareness of pelvic floor muscles. Basketball players are often subjected to 2 hours of training up to 4 times a week, plus games during the weekend. This athletic training often consists of long distance running, lunges, jumps, and weightlifting, all high impact activities for the pelvic floor. Need for the study. Urinary incontinence is a common problem among female with a negative impact on quality of life. SUI represent a greater barrier to women's participation in sport activities, interferes in their health, well-being, and self-esteem. In athlete, the highest prevalence is found among young athletes who usually practice sports which involve high impact. Both stress urinary incontinence and urgency urinary incontinence significantly affect the uh, life of the participants, such as physical, mental, and social performance, work efficacy, and sexual health. It became necessary to gather scientific evidence for symptoms of urinary loss during competition, while training, and in day-to-day life of female basketball players. In recent years, conservative treatment, particularly pelvic floor muscle training, has been shown to be effective and is now recommended as first-line treatment before consideration of surgery based on low risk, low cost, and demonstrated efficacy. Aim to find out awareness about stress urinary incontinence and physiotherapy regarding it in female basketball players. Objective to find out awareness about stress urinary incontinence and physiotherapy regarding it in female basketball players by using a questionnaire. Methodology, study design, observational study settings, basketball grounds in Nagpur, study population, female basketball players, sampling technique, convenient sampling method, study duration, 12 months, inclusion criteria, women's age 18 to 35 years, high intensity physical activity during last 3 months, perform a sport at least 3 days per week for more than 1 year,
Exclusion criteria: surgical treatment of urological and gynecological illness, disease of respiratory tract, urinary tract infection, no sufficiently completed questionnaire, those unwilling to participate. Result: the conducted study was done by all 50 female basketball players with the age of 18 to 35 years. In current study, the female basketball players majority had more than 3 years of experience, that is 82%, with average more than 4 hours of playing a week, that is 68%. There are less number of female basketball players who has performed a stress urinary incontinence, that is 10%, and there are 32% female basketball players who feel shy in sharing urinary incontinence problem. In recent study, it has been showed that there are 96% of players who know the role of physiotherapy in the medical conditions such as SUI, but less percentage of female basketball players who are aware about the strength training of pelvic floor muscle and other physiotherapy management protocol in stress urinary incontinence. There are 84% of female basketball players were interested in undergoing a specialized physiotherapy protocol to improve strength and quality of life, in which 37 players were from the age group of 18 to 25. The ideas of my question. There are 12 questions. Discussion. The problem of stress urinary incontinence in women is not considered a life-threatening condition. However, due to the prevalence of it, WHO assesses it as one of the most serious health problems today. According to Hilde and Bo, Kegels exercises provide better support to the content of smaller pelvis, lengthening the functional length of the urethra and improving resting pressure in it, activating the periurethral striated muscles, normalizing the abdominal perineal reflex due to the increase in intra-abdominal pressure, and improving the reception of sensory stimuli. According to Joanna Marlina et al., in studies, slightly more than half of women were aware of existence of such medical condition as stress urinary incontinence. According to the Carl et al., the female basketball players also lack of information regarding method to prevent and treat stress urinary incontinence. The presented study result also indicate the need to develop and implement the prevention program aim at increasing the knowledge and awareness of all women about stress urinary incontinence and rehabilitation program related to SUI. Conclusion: the current study concluded that female basketball players are very well aware about stress urinary incontinence. It is clear through this survey that they can share their SUI problems easily. This is thank you, ma'am.
Thanks, Dr. Mayuri, for your presentation. And dear session chairs, you have any question for this presenter?
Am I audible?
Yes, ma'am.
Yes, ma'am, you are audible.
Please go to your first slide of prevalence, the title. Please show me your title. Okay. So you are working on the stress urinary incontinence in female basketball players. So you are looking at the awareness and the prevalence, right? So what is the reason for a female basketball player to have a urinary incontinence, whereas the regular training athletes, they do various type of sports activity, including the strengthening of pelvic floor muscle, like they are doing abduction adduction movements of the hip joint, they are doing flexion extension movement and other post strengthening movements in their regular schedule. So what is the reasons, what is the physiological mechanism because of which the high intensity sports like basketball, they have this problem?
Because the high impact basketball is a high impact sports. That's why they do repetitive jumping and running activities. So it put pressure, stress on the pelvic floor muscles. So that can cause leakage.
So their muscles must be strong, no? Because they are working for their muscle strengthening all over the year. So how much prevalent among basketball it is in other researches or the other countries? So have you included the prevalence in basketball in your introductory part?
Because it create abdominal pressure, intra-abdominal pressure, which can strain the pelvic floor. So the
So how much was the prevalence of urinary stress incontinence in athletes? Overall, how much was percentage prevalence was seen among athletes, female athlete players?
I will go for
Maybe am I audible?
Yes, ma'am.
So how much prevalence did you saw in the previous researches?
Yes, 10 to 50, 10% to 55%. I have mentioned studies. Introduction.
Okay, thank you, Mayuri. Thank you for your answer. It was a nice presentation.
Thank you.
Thanks for your presentation, Dr. Mayuri.
Yes, ma'am.
So the next presenter is Dr. Pranali Avinash Hivase.
Megavati ma'am.
Yeah. Yes.
Ma'am, can we hold this session for a while? There is some important work that I need to attend to. Can we just hold in? Can we take a break for a while?
Sure, ma'am. And can you please mention
How many participants are left for presentation? I think
let
we
me
have
check
reached
that, ma'am.
17th. 17th participant has done.
Yes,
Like
ma'am.
Mayuri was the 17th.
Yes, ma'am. Totally the 17 people we have completed. So apart from that,
Okay.
ऐसा करते ना हम वो आएंगे फिर अपने को फोन करेंगे नीचे टीम मैम की फोटो से बैठना
Ma'am, maybe we can finish with next participant is Pranali ma'am. Hello.
Ma'am.
The next participant is Pranali Avinash Hivase, I guess, right?
Yes, ma'am.
So maybe we can complete this one as well.
Sure, ma'am. We can do that. And it would be so great if you could let me know what will be the break time and all. So you just mentioned a while. So I just need to confirm with
Okay.
the core committee itself. So that is
Sure, I'll just talk to Gopika ma'am once if that is okay. Just hold on 1 second. I'll just call Gopika ma'am once.
sure, ma'am. Sure.
We had a conversation in the morning, so I'll just brief her once.
Okay, ma'am.
Just give me a
Meanwhile, can we start this presentation with the presence of Prachi, ma'am?
Prachi ma'am is actually already gone for that particular program for which I have to go.
Okay, ma'am.
So just give me 2 minutes. I'll just talk to Gopika ma'am and I'll be back on the
Sure,
presentation.
sure.
Ma'am, shall I start the presentation?
Excuse me, ma'am. Ma'am, shall I start my presentation?
So the next presenter would be Dr. Pranali Avinash Shivase.
Yes, ma'am. Shall I start my presentation?
Yes, ma'am, you can do that.
Good afternoon, everyone. My topic is effect of respiratory muscle stretch along with breathing exercise on respiratory parameters in COPD patients of case study. Introduction: chronic obstructive pulmonary disease is a common lung disease causing restricted airflow and breathing problems. Symptoms
Pranali,
include cough.
Pranali, Pranali, sorry to interrupt. I'm unable to see your presentation.
Yes, ma'am.
Yes, now it is visible. Please go ahead. Yes, it is visible. Please go ahead.
Symptoms include cough, difficulty in breathing, and tiredness. WHO predicts that COPD will become the third leading cause of death worldwide by 2030. Respiratory muscle stretch gymnastics is a combination of stretching and breathing used simultaneously, which is beneficial in improving the function of respiratory muscles in the patients with chronic obstructive pulmonary disease. Need for the study: people with COPD have airflow obstruction and reduced gas exchange and alveolar ventilation, whereby air trapped in the alveoli does not escape to the outside, leading to progressive hyperinflation of the chest that alters the configuration of the ribcage and respiratory muscles. A respiratory muscle stretch gymnastics is a group of stretching exercises sequentially performed to stretch specific muscles involved in respiration. It stretches the external internal costal muscles during inspiration and the internal costal muscles during expiration. The respiratory muscle stretch gymnastics is designed particularly to decrease the stiffness of the respiratory muscles and hence increases the lung function. Aim: to study the effect of respiratory muscle stretch along with breathing exercise on respiratory parameters in COPD patients. Objective: studying the effect of respiratory muscle stretch along with breathing exercise on respiratory parameters in COPD patients after 1 week of intervention. Methodology: study design is a case study setting, pulmonary ward of Lata Manchkar Hospital in Nagpur. Study population: COPD patient diagnosed by physician or pulmonologist. Duration of the study is 1 week. Sample size is 1. Inclusion criteria is: patient is conscious and oriented, male, age 55 to 65, patient with who are willing to participate, and patient with stage 1 and stage 2 COPD. Exclusion criteria: patient who has unstable vitals, ventilated patient, patient with auto supplementation, active tuberculosis infection, patient who have undergone recent surgery for heart, lung, or abdomen, and subject with neurological dysfunction. Result: the respiratory rate before was 27 breaths per minute, and after 1 week of intervention, it was 18 breaths per minute. SpO2 was 92%, while after 1 week it was 97%. A peak expiratory flow rate was 280 liter per minute, and after it was 400 liter per minute. Conclusion: the result clearly indicates that there is a reduction in respiratory rate, an increase in the saturation level, and peak expiratory flow rate, thereby indicating that respiratory muscle stretch along with breathing exercises helps in improving the respiratory parameters in COPD patients. These are my references. Thank you.
What were the stretches that you have used, Dr. Pranali?
Ma'am, it was intercostal muscle stretches.
Okay, and how did you perform them?
I performed in the ward, ma'am.
So how did you perform them? What was the hand placement? What was the placement of the patient? How was the patient position?
A patient was in sitting position first. Then I elevated the elbow and sitting position, ma'am. The patient was in sitting position.
Okay, so then you elevated the hands of the patient?
Yes, ma'am. And
okay,
I
and
asked him to bend the opposite side on the opposite side.
Okay, got it. Side bending. Okay, and what else? And any other stretch that you have used?
No, ma'am. And along with that, I have given the breathing exercises.
Okay. So what were the breathing exercises that you have used?
Ma'am, personally breathing while doing the stretching of the intercostal, I had asked the patient to inspire, and after releasing, I asked the patient to expire the air through mouth.
Okay, why did you do that? What was the rationale behind it? How do you think that exhaling through mouth would help the patient?
Ma'am, because after stretching the muscles, it increases the. Hello, ma'am, am I audible?
Hello, Pranali, your voice, yes, your voice was breaking. Now you're audible. Please go ahead.
Yes, ma'am.
Hello. Yes.
Yes.
You're losing audibility again and again. Yes, Pranali, please.
Ma'am, sorry, what was your question?
I asked, why do you think, what is the rationale behind exhaling through mouth?
Because
Okay.
already there is hyperinflation of the lungs, and to increase the saturation of the patient, we ask the patient to expire. There is difficulty in.
Okay. Thank you. Thank you, Frank.
Thank you, ma'am. And Dr. Hasna Ismail, you have any question for this participant?
Megavati ma'am, Megavati ma'am, we need to stop for a while. The program has started, and I'll give you a call once I'm done with my welcome speech. Just give me 5-10 minutes.
Okay, ma'am. Sure. Sure.
Thank you.
Meanwhile, Dr. Hasna, you have any question for this presenter?
No, I have asked whatever question I have. No more specific questions.
Okay, ma'am. Okay. Thank you. The participants, can you please turn on your camera so that we are requested to take. Everyone, please turn on your camera.
Ma'am, when can I start my presentation?
Please hold on for a second, ma'am, so that the session start would be back. Meanwhile, we will be like taking the gallery.
I request all the participants to turn on the cameras for the gallery image. I repeat myself, I request all the participants to turn on the camera for the gallery image so that we could continue with our next session.
Hey, participants, can you please turn on your camera so that we could take the gallery image? Then only we can move on to the session. Okay, thank you, participants. So we are moving on to the next presentation with the presence of Dr. Hasna Ismail. The next presenter would be Dr. Kritika Rati.
Yes, ma'am.
Yes, ma'am. Please start your presentation.
Is my screen visible, ma'am?
Not yet, ma'am.
Is it visible now, ma'am?
Yes, ma'am. It is visible. You can go ahead.
Okay. Good afternoon, everyone. Presentation. Attitude of chronic low back pain patients towards low back pain and observational study. Introduction. Low back pain is an extremely common health problem and it is well documented. Almost everyone will, at some point in their life, experience low back pain. Low back pain affects up to 84% of the population worldwide, and an estimated 28% of individuals suffer from chronic low back pain. Low back pain is classified as acute back pain, which lasts for less than 4 weeks, subacute back pain, which lasts for 4 to 6 weeks, and chronic low back pain, which lasts for more than 12 weeks. People ignore low back pain at initial or the acute phase, as they think that their symptoms will resolve on their own and usually do not take treatment for it. Due to this, the chronicity of the pain increases. Chronic pain affects not only an individual's functional ability but also mental health. Chronic may lead to anxiety, sleep disturbances, depression, and low confidence in individuals with chronic low back pain. There are many factors that affect back pain, like physical, psychological, social, economical, lifestyle, and attitude towards the low back pain. Attitude about the back is an important factor in the development of back pain. Attitude towards any disorder affects its course, management, and the need for imaging studies. Negative attitudes. Hello?
Yes, Dr. Hitika, please go ahead.
Yes, ma'am. Negative attitude towards low back pain in any population may lead to unnecessary psychological distress and an increase in the disease burden. Negative attitude of patients with low back pain may interfere with pain, disability, and mood. Targeting negative attitude towards the back pain has been advanced as a major priority to decrease the burden of low back pain. An important risk factor that has been consistently found to be predictive of low back pain experience is the presence of a negative attitude towards the pain. Therefore, there is a need to observe the attitude of patients with chronic low back pain towards their pain. Hence, the present study has been undertaken to observe the attitude of patients with chronic low back pain towards pain in the Indian population. The need for study. Attitude about the back pain is an important psychological factor in patients with low back pain, which may hinder rehabilitation and delay the recovery. The extent of functional impairment that chronic low back pain patients experience is also dictated by the attitude they have towards their low back pain. Chronic low back pain patients lack knowledge about the causes and contributing factors of low back pain. This implies that during management of low back pain, patients' attitude towards their pain should be identified. Attitude of low back pain patients towards pain has been studied before, but very less literature, to my knowledge, is available of this study in the Indian population. Hence, the need of the study is to observe the attitude about the pain in chronic low back pain patients. The aim of the study was to assess the attitude of chronic low back pain patients towards low back pain. And the objective was to assess the attitude about the back pain in patients with chronic low back pain using back pain attitudes questionnaire. Methodology. The study design was observational study setting, tertiary healthcare center, study population, patients with chronic low back pain, duration of study was 6 months, The sampling technique is convenient sampling method and the sample size is 80. Inclusion criteria: diagnosed cases of chronic low back pain with or without radiculopathy. Patients aged between 40 to 50 years. Patients who are receiving physiotherapy treatment for low back pain. Patients having moderate to severe pain, that is 4 to 10 on NPRS, and all genders were included. The exclusion criteria was pregnant women, low back pain associated with psychiatric disorders, low back pain associated with surgery with spine, and individuals not willing to participate. The material used was item back pain attitudes questionnaire. It is a 10-item questionnaire for exploring the presence or prevalence of certain beliefs and as a clinical screening tool. In the 10-item back FAQ, each scale point is labeled with a descriptive title. The scale ranges from false to true, the intermediate labels being possibly false, unsure, and possibly true. The true response option normally represents an attitude which is negative and unhelpful for recovery from back pain. The responses can be scored from -2 for true to +2 for false. Attitudes that are unhelpful for recovery from back pain attract negative scores and vice versa. This may allow the therapist to quickly interpret scale and component scores and identify where explanations could be directed to address negative attitudes or strengthen the positive ones. This is the questionnaire which I have used. The results. Now, this is the distribution. The first chart shows the distribution of subjects according to the age groups. I have divided the subjects into four age groups: 40 to 42 years, 43 to 45 years, 46 to 48 years, and 49 to 50 years. And the second chart shows the gender-wise distribution of the subject. Males were slightly more than females. The mean score of patients according to their age and according to their genders as shown in the graph. And this shows the mean score of patients according to the individual question. The most negative score is for question number 2, which is you could injure your back if you're not careful. Result: the sample size of the study was 80. Mean age of patients was 45.29 years. Females were 37 and males were 43. And the study resulted that patients have a negative attitude towards their low back pain. Discussion: the aim of the study was to find the attitude of chronic low back pain patients towards low back pain. In the present study, negative attitude toward low back pain was found in the patient. Respondents had more negative views. In particular, they were more likely to report that the back was vulnerable and had negative views about the prognosis of back pain. Overall, this study indicates that patients lack knowledge, awareness, as well as education regarding low back pain, its cause, and management. It has been suggested that recovering from back pain involves an active process, whereby misconceptions are corrected. It makes sense that people would have more positive views about recovery if they'd already found recovery to be possible. It highlights that many patients with low back pain are not adequately knowledgeable about low back pain and hold negative attitudes towards their pain. This study correlates with a study done by Barbosa et al., which indicated that patients have negative attitudes about back pain. Conclusion: this study concludes that patients presented negative attitudes associated with the intensity of pain with a probable influence on the treatment, which showed how important it is to carry out new studies that evaluate therapeutic approaches such as targeted intervention and educational programs aimed at the patient's attitude towards low back pain to determine its impact on pain control and treatment. Clinical implications: low back pain management programs should include education programs aimed at empowering patients with knowledge regarding low back pain. Future recommendations: experimental study can be conducted to find out the effects of education programs on low back pain. These are my references now. Thank you.
Thank you, Dr. Hitika, for your presentation. next presenter would be Dr. Monica Bandibar. Dr. Monica?
Hello, ma'am. Good afternoon.
Yes, ma'am. Good afternoon, ma'am. Please start your presentation, ma'am.
Okay, I'll
Yes,
start.
is listening and she will be evaluating also. Yes.
Just a second. I'm sharing my
Sure, ma'am. Sure.
screen. Uh, yes, ma'am. Is it visible?
Yes, ma'am. Your presentation is visible. Please go ahead.
Myself, Monica. So, my topic is evaluation of foot posture, BMI, and musculoskeletal pain in nurses. Introduction. Nurses routinely perform activities that require long hours of standing and walking. Feet-related and lower limb conditions being the most common, contribute to the incidence in nursing profession of lesions such as plantar fasciitis, muscle fatigue, varicose veins, and edema. Weight of the body constantly exerts pressure on the foot in long-standing position, which may lead to alteration in the foot and affect postural stability due to eversion observed at the foot and internal rotation of the tibia and femur. This causes various overuse injury such as patellofemoral syndrome, plantar fasciitis, and mechanical low back pain. Need for the study. Nurses are at high risk musculoskeletal pain due to physical demands such as prolonged standing and walking. Musculoskeletal pain causes loss of motivation to work and is major cause of sick leave and premature retirement among nursing personnel. Due to long hours of standing and walking, nurses are predisposed to prolonged stress and pounding on surface, which can cause changes in foot posture of nurses. Hence, there is a need to study the association of foot posture with musculoskeletal pain in them. The aim of study was to evaluate the foot posture and BMI with musculoskeletal pain in nurses. Objectives. First one is to assess the foot posture by foot posture index in nurses. Second, to assess the musculoskeletal pain by Nordic pain questionnaire. Third, to find out the association of foot posture with musculoskeletal pain in nurses. Methodology, study design, cross-sectional study, study setting, cross-sectional observational study population nurses, duration of study 6 months, sample size 10, eligibility criteria. Inclusion criteria was age group between 25 to 45 years, both genders, male and female, work for more than 5 years as a nurse, stand or walk for more than 5 hours in a day. Exclusion criteria, subjects with any recent surgery of lower limb, subjects with any congenital foot deformity. Results, total 10 subjects were recruited for study based on the inclusion criteria. Mean and standard deviation of BMI is 25.72 and mean and standard deviation of foot posture index left foot was 5.8 and for the right it was 5.86. Out of 10 subjects, 2 had pronated feet, 2 had highly pronated feet, and 6% had normal feet, and there was absence of supinated foot. Out of 10 subjects, 4 were overweight, 1 were obese, and 5 were of normal BMI. 9 had a musculoskeletal pain, out of which 6 had lower limb pain and 3 had upper limb pain. Conclusion. According to the current study results, musculoskeletal pain were observed in nine nurses. The most common site affected was knee in 4 nurses, lower back pain in 4 nurses, and ankle or foot pain in 3 nurses. The most significant risk factor was prolonged shifts and being overweight, as a 40% nurses were overweight. We found out that among 10 nurses, 4 nurses had pronated fit, 6 nurses had normal fit. The pain was more common in lower extremity due to prolonged standing and walking. Knees and ankle pain was more common in nurses as the weight of the body exerts pressure on foot in long standing. 50% nurses among them had pain that prevented them from working normally. These were my references. Thank you, ma'am.
Thank you, Dr. Monica, for your presentation. And Dr. Hasna, you have any question for this presenter?
Hi.
Hi, ma'am.
Okay, I have a question. Can the presenter share about the step how you recruit your subject?
Ma'am, you are not audible.
Sorry, can you hear me?
Yes, ma'am, we can hear you. And Dr. Monica, you are having technical issues from your side, it seems. And please make sure you are checking your internet connection.
Yes, ma'am.
Yes, ma'am. Please go ahead, Dr. Hasna.
Okay, my question.
Hello.
Hello.
Hello. Am I audible, ma'am? Hello. Husna, am I audible to you?
Hello.
Am I audible to you? Okay. I want you to go back to your methodology slide once. Please go back to your methodology slide.
Okay, ma'am, I'm sharing my screen again because it's connected.
Ma'am, the presenter's name is Dr. Monica, ma'am.
Okay, it was mentioned as Husna at the base of it, so I thought maybe. Okay, I was watching it wrong.
Yes, ma'am.
Okay.
And
Monica, please go to your methodology slide. Yeah. Cross-sectional study and it's just observational. Okay, fine. So, can you please brief me with your outcome measures? How have you evaluated this foot posture? What are the tools that you?
It was foot posture index.
Okay, foot posture index.
Foot posture index.
And do you have
Yes.
that index in your presentation? Can you please show me the
ma'am,
index?
sorry. No, ma'am, sorry, I haven't.
Okay, it's not in the PPT.
No, ma'am.
Okay, so what are the measurements that foot index has? I mean, what are the parameters that it consists of? Hello. Yes, Monica.
Yes, ma'am.
So what I'm asking is that foot index, what are the parameters that it consists of? What do you measure in it? How do you find out that the position of the foot is not appropriate?
Ma'am, the foot posture index involves components which involves talar head palpation, and we score according to that.
Okay.
The scoring is -2, -1, 0, +1, and +2. In talar head palpation, the 0 score is talar head equally palpable on the lateral and medial side. And the +1 is talar head slightly palpable on lateral side and or palpable on medial side. And +2 is
So all
talar
these
head not
palpations.
Yes, ma'am.
Okay,
The
all
first
these
is talar head
palpations have been done. All these
Yes, ma'am.
palpations have been done only by you, or was there another person doing it for you?
No,
Like
ma'am.
all of
It
them
was me
have
only.
been palpated by you?
Yes, ma'am. It was me only.
Okay. Fine. So it was one person palpating for everybody, right?
Yes, ma'am.
Am I
Yes.
right?
Yes, ma'am.
And the sample size was just 10. Why only
ma'am.
10, Monica?
It was
Why
pilot
just 10?
study, so it was 10.
Okay, it
Ma'am,
was a pilot study and you
actually
aim
it
to
was
like expand it?
yes.
Okay, fine.
In future, maybe.
Work for more than 5 hours a day. Okay,
Yeah.
got it. Was there any correlation between this study, like the posture of the foot and the BMI of the people that you have checked?
Yes, ma'am.
Maybe the
We
body
have
weight
found.
is affecting their foot posture?
Yes, ma'am. That is one of the
So did you
reason.
try checking their BMI?
Yes, ma'am. I have calculated their BMI.
Okay, can you please brief me the result? If the person is overweight, did you find any change in the overweight people and the normal weighted people when you checked for your foot index?
Yeah, ma'am. The overweight people had
On
more
the basis of
highly pronated feet.
BMI?
Hello?
Okay, fine. So the posture of the foot was worse in people who had a higher BMI, right?
Yes, ma'am. Yes.
Okay, Monica. Thank you so much. Thanks for the
Thank you, ma'am.
presentation.
Thank you, ma'am. Dr. Hasna, you have any questions for this presenter, ma'am?
No, so far. Thank you.
Thank you, ma'am. So the next presenter is Dr. Deeksha Mehraj Fatanan.
Hello, ma'am.
Hello, ma'am.
Can you hear me?
Yes, ma'am, I can hear you. Please go ahead with your presentation.
Ma'am, I have shared my PPT in your chat.
Sure, I'll be presenting. Yes.
Yes, ma'am. Yes, ma'am, it is visible.
Please start your presentation, ma'am.
Yes. Good afternoon, ma'am. This is Diksha Hatnani. My topic is prevalence of depression and quality of life in polycystic ovarian disease patients in one and only. Introduction. Polycystic ovarian syndrome is a multifactorial and polygenic disease that manifests itself a wide range of indications which are related to the disturbance of reproductive, endocrine, and metabolic functions. Polycystic ovarian disease is a common reproductive endocrine disorder that affects 5 to 10% of reproductive age women. PCOS affects at least 90% of women who visit reproductive clinics because they are unable to ovulate. Ma'am, next slide, please.
Please go ahead, ma'am.
Hello.
Is it presenting now?
No, ma'am, it is not visible.
The next slide, the slide is not moving, ma'am. I mean, we are still on the first slide.
Oh, okay. Let me check with the. Is it presenting now, ma'am?
Ma'am, move to the next slide, please.
Sure.
Second number
No,
slide.
we are.
Yes, ma'am,
Yes.
it is visible.
Now it's moving.
Need for the study as PCOS patients have higher tendency chances to gain weight without any pathological reason. So, in this study, we assess the level of rate of depression and quality of life. Aim to find out the prevalence of depression and quality of life in polycystic ovarian disease patients. Objective to determine the level of depression in patients with PCOS. To evaluate the rate of depression and quality of life in women with PCOS. Hypothesis, there is significant association of depression and quality of life in patients suffering from PCOS. Ma'am, next slide, please. Methodology, type of study, observational type of study, sampling method, simple random sampling with lottery method. Sample size 100 subjects. Place of study Shalini Mega Hospital and Research Center. Duration of study 6 months. Inclusion criteria, it includes patient diagnosed with PCOS as per the Rotterdam criteria. Rotterdam criteria includes oligoovulation or an ovulation, hyperandrogenism, polycystic ovaries, female patients in the reproductive age group 18 to 45 years, and those who are willing to give consent. Exclusion criteria, hypothyroidism, hypoprolactinemia, congenital adrenal hyperplasia, androgen secreting tumors, Cushing syndrome. Ma'am, next slide, please. Results. The present graph illustrates the impact of PCOS among participants. Highest mean value of participants who opted felt like less women because of having PCOS and felt like hated yourself is the ratio. The overall result was of impact of PCOS, that is 4.18. The present graph illustrates the mood among PCOS participants. In this, the highest mean value was 3.74. The result shows that in quality of life of domain, the highest mean value 4.18 was chosen by participants who felt like less women because of having PCOS and felt like hated yourself. The result shows that in depression domain, the highest mean value was 3.7 chosen by participants who felt overwhelmed because PCOS and depression. Discussion. The present study shows that prevalence of depression and quality of life in PCOD patients. We have found that high prevalence of depression among PCOS patients and also reduced quality of life in PCOS patients. Emotional distress in women with PCOS could be due to psychological or pathophysiological factors. Many women consider visible traits such as hirsutism and acne, stigmatizing and potential consequences such as infertility and obesity as distressing. The India study from Kashmir that also used a structured clinical interview found an overall prevalence of psychiatric morbidity to be 52.7% and prevalence of depressive disorders was 25%. PCOS is linked to depression and quality of life. Conclusion. In this study, the majority of women with PCOD were reported to be depressed. They were also seen to have reduced quality of life. Depression, infertility, and hirsutism were found to have a negative correlation with quality of life in all domains. And these are our references in the next slide. Thank you, ma'am.
Okay.
Thank you for your presentation. Ma'am, you have any question for this presenter?
Diksha, what exactly is the prevalence of PCOD?
Depression.
Hello,
It
Diksha,
was,
am I
hello,
audible?
ma'am. Yes, ma'am.
No, I'm not talking about depression and quality of life. I'm asking you,
Yes,
do you
ma'am.
know what is the PCOD? Yeah.
Ma'am, unable. Please pardon, ma'am. Hello, ma'am.
Okay, fine. The second question, hello. Am I audible now?
Yes, ma'am, you are audible.
Hello.
Hello, Diksha, am I audible?
Yes, ma'am. Yes, ma'am. Please.
Okay. So Diksha, fine. Diksha,
Yes, ma'am.
the first question was, are you aware of the prevalence of PCOD in India?
Not.
You know how many percent of people suffer from PCOD?
Among 90%, ma'am.
No, 90 is too much. But anyways, okay. How did you differentiate that the person is not suffering from PCOS? The person is suffering from PCOD. You know the difference between the two?
Yes.
You know what is the difference between PCOS and PCOD?
Yes,
Yeah.
ma'am.
So how did you differentiate? How did you understand that these patients are PCOD and these patients are PCOS? Hello, Diksha, your voice is breaking.
Hello, ma'am.
Is there a problem with your network?
Hello, ma'am.
Yes. Yes, Diksha, you're audible. Please go ahead.
Hello, ma'am.
Hello. Yes, Diksha.
Ma'am, PCOS is diagnosed as per the Rotterdam criteria,
Okay.
and it's
And what about
considered
PCOS? PCOD?
PCOD, ma'am, due to because of metabolic disorder or hormonal imbalance, more than 10 cysts in each ovary. They have, ma'am, papers and prescription papers and done with the test of their. Hello.
All PCOD patients, right?
Yes, ma'am.
They were PCOD patients, right?
Yes, ma'am. Yes, ma'am.
Okay. Why you did not think of PCOS?
Hello.
Ma'am, your
Hello.
voice is not.
Hello.
My voice is not clear.
Yes, ma'am, your voice is
Ma'am,
not.
your voice is breaking.
Acha, okay. Just give me a second. Maybe I should sit somewhere near. Okay. Am I audible now, Diksha?
Yes, ma'am.
Okay. So what I'm asking is, why did you opt for PCOD? Why not PCOS? You know, every second or third female in India suffers from PCOS.
Yes, ma'am.
So why we did not opt PCOS? Why only PCOD?
Ma'am, I have taken PCOS patients, not PCOD.
Can you please go back to your slide? Or I
Hello,
think somebody
ma'am.
else has started sharing
Hello,
their
ma'am.
slide. Yes. Hello.
PCOD. I have.
Acha, okay. Diksha, it's fine. Okay, it's
Ma'am,
okay.
I
It's
can
okay.
Yes.
Fine.
with that. So I have presented that.
We can start. Yeah, we can
Yes,
start
ma'am.
with
I
the
have
next.
presented Dr. Deeksha's presentation, so I can go to the slide if you want to check.
Yeah, sure.
Yes, ma'am. Is the slide visible?
Yes, ma'am. Yes. And now it's gone.
Hello, ma'am.
Hello. The presentation is gone.
Yes, ma'am. I have presented now. Please check into that.
Yes, yes. Now it is visible.
Which slide you want to see, ma'am?
Can we go to the first slide, the title slide?
Sure, ma'am.
Yes.
Okay, so Diksha, this is PCOD patients that you have taken.
Yes, ma'am.
It is not
Yes.
PCOS that you
PCOD.
for,
I
right?
have to.
Okay. Yeah. Okay. Now, when you're writing about in the introduction, it is all PCOS. Go down to your inclusion. See, you have written somewhere it is PCOS, then somewhere it is PCOD. In your aim, it is PCOD. In your need for the study, it is PCOS. Your hypothesis, again, it is PCOS, and objective is PCOS, but your title says it is PCOD.
Okay, ma'am.
Just check your title, it's PCOD. Prevalence of depression and quality of life and
Quality of
polycystic
life
ovarian
among.
disease,
Yes, ma'am.
right? So there's a
Yes,
difference
ma'am.
between disease and syndrome, beta. You'll have to choose one. You cannot take two. And there's a difference. These are two different things, syndrome and disease.
Okay, ma'am.
They are not interchangeable terms. So you'll have to just correct your research on this part. You'll have to see what you are actually taking, whether it is PCOD or it is PCOS. Okay.
Yes, ma'am.
Yeah, that's all. That's all. Ma'am, we can move to the next presentation.
Sure, ma'am. Sure, we can do that. So the next presenter would be Dr. Kiran Mende. Dr. Kiran,
Yes, ma'am.
you can start your
Sure, ma'am.
presentation now, ma'am.
Yes.
The title of the topic is long-term effect of structured
Dr. Kiran, your
training
voice is
versus.
not too audible. Can you please talk a little bit louder and check your audio?
Hello, am I audible? Hello.
Yes, ma'am, you are audible, but your voice is not like loud. So can you please increase your volume?
Yeah, it's maximum, ma'am. Is it audible now? Hello. Yes. Hello, is it clear?
Yes, please go
Yes,
ahead.
ma'am. Go
Yeah,
ahead.
the title of my topic is long-term effects of structured aerobic training versus structured resistance training program on lipid profile in type 2 diabetes. Introduction is type 2 diabetes mellitus is associated with a cluster of interrelated lipoprotein abnormalities, including reduced HDL cholesterol, which leads to dense LDL particles and elevated triglycerides. These abnormalities in patients despite normal LDL cholesterol levels. Type 2 diabetes mellitus is characterized by an increased glucose production, by an increase in hepatic glucose production and deficit in insulin secretion and an increased resistance to insulin.
Dr. Kiran,
Yeah.
sorry to interrupt. Can we come to the methodology directly, or need for the study?
Next
That
is
is.
need. Yeah. The need of my study and the aim is the need is DM is a characterized metabolic non-communicable disease, and the finding of this study will help to increase the knowledge about patients with diabetes, which will help for awareness and implementation of diabetes management program in future. So most of the time, according to WHO and Diabetes Federation International IDF, 1 in 10 adults worldwide had type 2 DM in 2014, and the cost of treating the complications of DM was 8% to 10% of the total cost of treating health problems in the world. So the aim and objective is to study the effectiveness of long-term effectiveness of resistance exercise was aerobic versus resistance training program on lipid profile in patients with diabetes mellitus. Materials and methodology. It is a randomized controlled trial carried out in a tertiary care hospital. Study population was type 2 diabetes mellitus. It was a convenience sampling with 18 months of duration, and 60 subjects were selected, 30 in each group. This is the inclusion criteria. Sedentary patients with type 2 diabetes more than 1 year, with genders aged 30 to 60 years. And then rate of perceived exertion was done. Sedentary defined as never reported having participated in any structural exercise program. Now this is the result which is showing the summary of mean HDL in both the groups. Aerobic exercise and resistant exercise program, where the p-value is showing that resistance exercise is effective more effective than aerobic exercise. Both the groups had improvement in HDL level after intervention. This is a slide showing mean LDL between the two groups, where it is showing that the mean LDL value of resistance and aerobic exercise shows us resistance exercise was more effective for the control of LDL levels. Now this is a slide showing TCL in two groups. The p-value of mean TCL of resistance and aerobic groups are 0.7 and 0.4 as respectively. This shows that resistance exercise was more effective in control of TCL level for the aerobic exercises. Now, in discussion, in a short, we can say that studies have found that exercise may reduce hyperglycemia, and it also shows that the resistance exercise program showed to be more effective than the aerobic exercise program. So it can be implemented in our daily routine, which will lead to increase in awareness for the patients.
And in addition, some evidence supports that the resistance exercise can be effective strategy to improve inflammation levels, glucose and lipid profile, and also the beneficial effect of RT on biomarkers and inflammation profile by other experiments showed a little effect. So we can say that resistance exercise improves inflammatory levels as well as lipid and glycemic profile in this type of subject. So it will be an effective treatment since we come across that each one of us in our family come across this type of problems. None of our family might be having, not a single person is having diabetes. So it should be implemented and more of the awareness has to be given to the population, which will be very much beneficial as we consider with the study. Thank you.
Okay. Can I please, yeah, Dr. Kiran, yes. Dr. Kiran, there is a research in the year 2014.
Yes.
If I'm not wrong, 2014 or I think 2015. I don't remember exactly remember.
2014.
Now, yes, and that
So 12
research
months
has,
yeah.
yes, resistance exercise versus aerobic exercise for type 2 diabetes. That was the base of it. Probably I'm not very thorough with the entire, I think it was some kind of systemic review or meta-analysis, something of that sort.
Yes.
So I just want to know that what is different in your research, because this topic has been like researched a number of times, and the effect of aerobic and resistance exercises have been seen. I mean, they have been assessed a lot of times in type 2 diabetes.
Ma'am, I would like to focus on the population where I have done the study where still the diabetic population is not that much enthusiastic for doing resistance exercise. What we come across is most of the time what has been told to them is to go for a general walk type of aerobic activity. But how much truly we can say that they are going for the resistance exercise program? So the focus of my study was that the population should be diverted, made aware, and they should be told and what actually comes under resistance training program, that awareness has to be given to the population, common population which we are targeting. Even most of the educated people are not that much that they will just go haywire. We cannot go on that way. We have to lift 5 kgs or which muscle group we have to target. That has to be taught and structurally they have to be planned. That was the main aim of my study.
Okay, and the treatment protocol, the exercise protocol for resistance training was made by you, or was it adopted from some other research?
Ma'am, it was taken by articles and then it was planned.
Okay. So it was adopted from some other research and then you have implemented it as it is. You made certain changes to it as per the population's intolerance and all?
Ma'am, I tried to keep it uniform for both the groups. The time duration, we tried to keep uniform, 45 minutes of aerobic and 45 minutes of resistance training. So we tried to have a uniformity in the sessions like that. And also
Okay.
literature support.
Okay. One last question, Dr. Kiran. What were your outcome measures? Can you just list them for me once?
Ma'am, the outcome measures which I mentioned were LDL, HDL,
Okay.
and PCL, ma'am. Wherein the p-value showed for HDL aerobic exercises 0.0031 and RE it was 0.001. And LDL, the p-value for AE was 0.0001 and RE it was 0.001. We showed significant.
Got it.
And TCL p-value 0.04 and RE 0.007.
Got it. Thank you so much.
Thank you.
No more questions from my end. I think we have another chair in case she would like to ask something. I do not have any more questions for Dr. Kiran. If the other chairperson would like to ask something. Megawati ma'am, can we move to the next participant if there are no more questions?
Sure, ma'am, we can do that. And the next presenter is Dr. Shilpa Vivek Chaureshia. Dr. Shilpa, are you here? Dr. Shilpa, are you online?
Yeah. Just a minute.
Sure, ma'am.
Is it visible, ma'am?
Yeah, it is still buffering. I think yes, it's visible now.
Okay. A very good afternoon. I'm presenting the study titled Comparison of Eye Fatigue Scale Score in Patients with and Without Cervicogenic Headache, age 30 to 45 years, an analytical cross-sectional study. So headache is probably the most common problem and disability seen in clinical practice by healthcare professionals, with a prevalence rate of 96% during lifetime and 16% during particular period. The International Headache Society has identified 14 different types and has classified headache into two basic categories: primary headache and secondary headache. Primary headaches include those of vascular origin, such as migraine, as well as those of muscular origin, such as tension type headache. Secondary headaches result from another source, including inflammation or head and neck injuries. Cervicogenic headache is considered as a secondary headache, even though the prevalence is relatively low in patients, but the quality of life comparable to the quality of life is more compromised compared to migraine patients and patients with tension type headache with a lower scores of physical functioning in cervicogenic headache type. Now, the cervicogenic headache is a diagnosis referred to the headaches of cervical origin and is a chronic headache that arises from atlanto-occipital region, which is the most intricate region of the spine with high demands of mobility and proprioception. It is perceived in one or additional regions of head and face, but has most commonly affected occipital area, frontal area, retroorbital area, and the part of neck and shoulder. Few moderately expressed diagnostic criteria for cervicogenic headache also includes ipsilateral blurring of the vision, inability to concentrate, retroocular pain, and pain around the periocular area along with visual disturbances. Now, the visual disturbances have been reported over the years in those with neck pain disorders. Visual disturbances remain subjective and subjective visual complaints and are often dismissed in clinical practice due to the lack of ability to identify concurrent gaze-related cervicogenic-driven functional signs. Prevalence of eye fatigue is considered to be highest among those aged 40 years and more, and it is lowest in less than 20 years. While visual complaints associated with neck pain have received some attention in literature, ocular symptoms associated with cervicogenic headache has not been investigated, and there is lack of literature related to this aspect. Hence, the study was conducted with the research question in mind: what is the difference in eye fatigue score in patients with and without cervicogenic headache aged 30 to 45 years? The aim of the study was to compare eye fatigue scale score in patients with and without cervicogenic headache in the age group of 30 to 45 years. The primary objective was to assess eye fatigue using an eye fatigue questionnaire in patients with headache and in cervicogenic headache and in patients who are asymptomatic. So the inclusion criteria were diagnosed cases of cervicogenic headache aged 30 to 45 years, both genders, individuals having cervicogenic headache and asymptomatic individuals, and smartphone addiction scale score less than 30, individuals with the best corrected visual acuity, and individuals who have given the consent to participate in the study. Eye fatigue was subjectively measured using an eye fatigue questionnaire in which level of eye fatigue was scored using a 7-point Likert scale, and the points which were covered in the eye fatigue questionnaire were tired eyes, congested eyes, red eyes, watery eyes, eye strain, blurring of the vision, double vision, sore or aching eyes, irritated eyes, dry eyes, burning eyes, and difficulty in focusing while studying or watching. Now, visual discomfort, the high score indicates a high level of perceived eye fatigue. So these are the results of the study. From the graph, it is very much clear that the eye fatigue was more in cervicogenic headache patients, and it was 40.07, whereas in asymptomatic individuals, the eye fatigue score was 30.07. In both the groups, the smartphone addiction scale score was statistically non-significant, which suggests that the parameters are comparable. Coming to discussion. The symptoms of visual fatigue is also called as the symptoms of the visual fatigue are basically diverse and include fatigue, pain, headache, along with others symptoms, and these all are categorized in one category that is called as asthenopia. Now, there are several extrinsic and intrinsic factors that are responsible for asthenopia. Cervicogenic headache is prevalent among the chronic headaches, and it is caused by the neck dysfunction, typically of the upper cervical spine. Now, the cervical spine, particularly the upper cervical spine, is the most intricate region of the spine with the high demands of mobility and proprioception due to the abundance of cervical mechanoreceptors and then their central and reflex connections to the vestibular, visual, and central nervous system. The cervical afferents are not only vital for controlling head movements, but also are important for cervico-ocular reflex. Now, the vestibular, visual, and cervical proprioceptive inputs are used to position the head in relation to the trunk, and it is in space. The oculomotor and vestibular systems can be affected by neck muscular proprioceptive system. Now, the neck muscle mismatch is generally present in most of the cervical dysfunctions. Specifically, if the cervical spine involves the dysfunction involves the upper cervical spine, then definitely there is a mismatch between the superficial extensors and the deep flexors. Now, this mismatch is responsible for the affected proprioception and which generally affects the cervico-ocular reflex. Now, the sensory motor control of stable upright posture, head and eye movement relies on afferent information from these three systems, which converge in several areas of the central nervous system. The cervico-ocular reflex works with the vestibulo-ocular reflex and optokinetic reflex acting on the extraocular muscles, which help in assisting the vision during the movement. Now, the disturbances in sensory motor control in neck disorders is basically from the disturbed joint position sense, and it is also because of the altered oculomotor control. When oculomotor control is altered, definitely there is altered smooth pursuit movement, and the saccadic eye movement is evident. It is either because of decrease or increased somatosensory activity, which can result in disturbances of sensory motor function. The functional impairments of the muscles, such as increased fatigability, increased mismatch between the agonist and antagonist, excessive activity in certain muscles such as extensors, reduced activity in certain muscles such as deflexors, all these are responsible for altered sensory motor input, which affects the afferent response to the central nervous system and thus affecting the affecting the COR. Now, this COR, that is cervico-ocular reflex, has a direct effect over the extraocular muscle activity, which are responsible for reduced functioning. Also, because of the persistent pain in the periocular area or the retroorbital area, these muscles get inhibited, and there are number of symptoms associated with the visual system, mainly in the form of fatigue, difficulty in concentration, or diplopia. Now, disturbances to the afferent input from the cervical region in those with the cervicogenic headache is one of the possible reasons behind these symptoms like visual disturbances. An increased gain of cervico-ocular reflex has also been observed in patients with idiopathic neck pain and also in patients with the upper cervical involvement, which is generally present in cervicogenic headache. It is believed that increase in the cervico-ocular reflex and the cervical afferent response gain serves as a compensatory response to a drop in vestibular ocular gain. Now, it has been suggested that this discrepancy between the reflex is also responsible for the various visual symptoms seen in the cervicogenic headache patient. Hence, this study will be...
Sorry to interrupt, and it would be so great if you could wind up really quick. We are exceeding.
Yeah. Hence, this study will be beneficial in knowing the association between cervicogenic headache and fatigue, which is generally seen in certain professions which involves the prolonged use of computers or the screens, digital screens. Thank you. Ma'am, this is done.
Okay, Dr. Shilpa, right?
Yeah.
Okay. May I ask Dr. Shilpa, where are you working right now?
At
You're working
VSP.
somewhere, right? You're a professional?
Yeah.
Yes. So where are
I'm
you
working at
working?
VSPM's College of Physiotherapy, Nagpur.
Okay. First of all, congratulations. Your topic is so thoroughly studied. I mean, you have literally studied it to its core. So
Thank you
there
so
is
much.
not much to ask, but yes, I definitely have some curiosities, and these curiosities are they're coming out because of my own cervicogenic headache and ocular issues. I
Okay.
always feel that whenever I have these cervicogenic headaches, one of my physiotherapists here in my department, he
Yeah.
releases the muscles around my jaw. And
Yeah.
most of the time, he says that, ma'am, probably you keep your jaw muscles very tight because of stress. And that
Yeah.
is one big reason that cervicogenic headaches. And he also releases my fascia of the scalp. I
Right.
don't know. I mean, it's like, putting a little pressure on the hairline and all. So he releases
Yeah.
the fascia as well. That
Right.
actually improves my vision. So
Right.
up to now, I used to always tell him that, whenever you do this, somehow I'm able to see more clearly. And
Right.
he had absolutely nothing to, rationalize why it is happening, because he is just a student. He has passed out from our college just now,
Right.
and a few months back. So he did not have a rationale to it, but he used to always say that most of my patients say this to me. So
May I
now today,
rationalize,
after
ma'am?
actually listening to your research has made it very clear to me that why that was happening, because I never thought it the way you have presented it. Congratulations, it's a wonderful topic and you have really thoroughly studied it.
Thank you
It's
so much.
just amazing. It's an amazing research. Just try for a good publication, or maybe just increasing it, maybe putting in some intervention, like he gives me some intervention and that improves the
Right.
vision and all. So maybe you can conduct this study or proceed or progress this study with some interventions as well.
Right, ma'am. Ma'am, basically when
Thank you so
you
much, Dr. Shilpa.
okay, no, thank you so
Yes,
much.
please.
So may I explain?
You were saying something.
Yeah. When he is releasing the
Maybe we can
hairline,
do one thing. We can
yeah,
connect after the.
yeah.
Yes,
Sure.
releasing the
Thank you so
hairline.
much. Yeah.
Okay, we can connect after the presentation, I guess.
Yeah, ma'am. Yeah, definitely. Okay, thank
Sure.
you so much.
Thank you, Dr. Shilpa, for your
You're
presentation.
welcome.
And the
Thank
next presenter would be Dr. Pooja M. Akhtar. Dr. Pooja?
Yes, ma'am.
Yes, ma'am. Please go ahead with your presentation.
Sharing my screen. So, am I visible?
Yes, ma'am. Your slide is visible. Please go ahead, ma'am.
Very good afternoon, one and all, respected chairpersons, students, colleagues, and my dear friends. So today I am presenting a topic on short-term effects of length of stay on muscle strength and muscle girth in patients who are admitted in medical and surgical intensive care unit. So as we all know, my slides are not changing. Just a minute.
Please put it on the presentation mode, ma'am.
Yes, absolutely. So as we all know that intensive care acquired weakness is not a new concept, and it is a complication which has been observed in severely ill patients, and it has been known to result in systemic weakness as well as loss of muscle mass. So this has already been an established fact that intensive care admissions, it affects the muscle mass and strength, but in critically ill patients and for those who are admitted for a longer duration of time. However, the short-term intensive care unit stay is not known to have a clear picture what is its effect on the muscle strength and girth, and it has been postulated that it may prolong the hospital stay, and on the long run it may reduce the quality of life post discharge. So with this background, I felt the need that maybe muscle weakness, though it is known to be present in critically ill patients admitted in the ICU for longer duration of time, but it is not very well documented in patients those who are admitted for shorter duration length of stay, and also those with medical and surgical diagnosis, those who are not ventilated. So this was not established. Hence, we felt the need to identify, document, and address whether ICU acquired muscle weakness is present in short-term medically and surgically admitted patients, non-ventilated patients who are admitted in the ICU. So we hypothesized that short-term ICU stay may have an effect on muscle strength and girth in patients admitted in medical and surgical ICUs. And we had the aims to record the muscle strength of a lower extremity quadriceps muscle bilaterally and hand muscles bilaterally using handheld dynamometer in patients who were admitted and those who were medically stable at 72 hours post-admission, and the second readings were taken after 7 days of ICU admission. The second objective was to record the muscle girth of upper extremity as well as lower extremity using tape measurements. And the third aim was to document any mean percentage loss that could have been observed in the muscle strength as well as in the muscle girth. So it was an observational longitudinal study which was conducted at a tertiary healthcare academic teaching institute, including the surgical and medical patients admitted in the ICU and those who were medically stable patients. Yes, ma'am. Excuse me.
I'm sorry.
So
Please continue,
we
Dr. Kosa.
patients between above the age of 18 years, either genders, and those who were willing to participate, they were conscious, awake, and cooperative patients. They were clinically stable with 72 hours of ICU stay, and they had a Glasgow coma rating scale of more than 30. We excluded patients, those who were on ventilated, those who were sedated, delirious patients, patients with fractures of upper extremity, lower extremity, or those who documented to have any progressive neurological or musculoskeletal diseases, encephalopathies. So the hand grip strength on the dominant hand and quadricep strength bilaterally was measured in kilograms using handheld dynamometer. The girth measurements were taken bilaterally at 4 different levels using plastic tape in centimeters at 72 hours post-admission and after 7 days of ICU stay. So these are my results. When we observed at the mean change of the hand grip strength on the dominant side, there was a total of 28% of muscle strength loss or the hand grip strength loss after 7 days of ICU stay, as well as the quadriceps muscle on the right as well as on the left. It also demonstrated about 15% of percentage loss of the strength, and these values were statistically significant at p-value less than 0.05. So as we can see, the mean values reduced from 10.3 to 7.3. So a total of 28% loss in hand grip strength, and similar strength loss was observed in quadriceps muscle also. When we looked at the girth circumference of the arm and the forearm for the upper extremity, so we observed a decrease in the muscle girth after 7 days of ICU admission, and the values were statistically significant. So a rough percentage loss was observed somewhere between 3 to 3.5% of the girth mass was lost in these patients in the upper extremity, and all the values were statistically significant. And when we observed the girth circumference of the lower extremity, when they were measured at the thigh region and at the calf region, similar results were observed with a 2.5 to 3% of muscle loss, and the p-values were statistically significant. The mean values decreased in the thigh region as well as in the calf region on tape measurements. So to summarize my results, a total of 75%, those who were recruited between the stipulated 1 year duration that we planned our study. 6 patients died in the duration, 29 were discharged and 7 took DAMA. So only a 33% of the data was with us, with a mean age of 48.5 to 115. With a predominantly, there were 57 percentage of male population, and their BMI ranged from 23, which was within the normal range of the BMI. So the hand grip strength decreased from a mean value with depicting a total 28% of loss in the hand grip strength, and the quadriceps muscles demonstrated a 15.6% loss in their strength after the 7 days of ICU stay. So with this, I would like to conclude that it is not just the long-term ICU stay that affects the girth and strength, and not only in critically ill patients, but in patients who are
admitted in the ICU for their general or medical diagnosis, and the duration to as low as 7 days also depicts the loss in muscle strength and the girth measurements that we have documented with handheld dynamometer and tape measurements. So these are my references, and thank you so much for your patient listening. Any questions, please?
Thanks, Dr. Pooja, for your presentation. Ma'am, you have any question for this presenter?
Dr. Pooja, can you please go back to your inclusion once?
Yes, ma'am.
Can you please go back to your inclusion criteria?
The inclusion criteria?
Yes.
Yes, ma'am.
This is summary and conclusion. Okay.
Shall I go to the summary?
Yes. No. Just give me 1 second. Okay, clinically stable with 72 hours of ICU stay, right?
Yeah. So, ma'am, actually, we had patients
So,
with asthma, COPD, liver cirrhosis, acute appendicitis. So, we waited for 72 hours so that we could have a clinically stable diagnosis wherein the patient could do the handheld dynamometry with the hand or with the lower limb. So, that was the only thing that we waited for 72 hours post-admission.
okay. And what was the maximum duration for which the patient was in the ICU?
Ma'am, we recorded our second endpoint was on the after the 7th day, that is on the 8th day early morning. But the patient continued to stay depending upon their stability parameters, because the literature says that as short as 7 days of ICU stay itself starts beginning with around 4 to 5% of the muscle loss in healthy individuals. So we were wondering whether there is any effect of short term in ICU patients, those who are not ventilated. The patient continued to stay depending upon their diagnosis and their the existing medical condition. But we took our second endpoint after 7 days, ma'am.
Okay. Actually, Pooja, why I asked you to go back to your inclusion criteria, the kind of patient we are talking about here is they are not suffering from any serious health issue. Their Glasgow Coma scale is more than 13. And I mean, they're not ventilated, they're conscious, they're cooperative. I was just wondering, why are they in the ICU then? What exactly is the condition that requires...
Patients with liver cirrhosis, uncontrolled diabetes mellitus, acute exacerbation or asthma, because we wanted awake patients so that they could follow our commands for doing the
Now
handheld.
see, okay, as you said that asthma patients with acute exacerbations were also there in the ICU. Now understand this, that if they are on derifylin, it is a very common drug prescribed for asthmatic patients who are suffering from acute exacerbations, especially when they are in the ICU. Now, if the patient is on derifylin, one of the side effects of steroids or of derifylin is the patient suffers from generalized weakness in the body, not just the chest muscles, also a generalized weakness throughout the muscles of the body. Now, if the other patients were on such kind of steroidal drugs, probably their muscle strength was more, I mean, the effect on the muscle strength was more because of, or as you have checked the strength of the muscle, right? You haven't undergone.
Yeah, we did not do a comparison of two different heterogeneous groups, right? We did a pre and post in the
No, I got your point. Yeah, I got your point. The pre and post, see, imagine a person comes to your ICU, and when the person comes, they come with some kind of acute episode of a particular problem. As you said, there were so many other different kinds of problems. So now the patient has come, and now the patient has been prescribed with some kind of steroidal drugs. In ICU, providing steroidal drugs or administering steroidal drugs is a very common scenario. If the person is on some kind of steroidal drug, the power of the muscle that you're checking, the muscle might not have deteriorated. There is no muscle loss, but the power of the muscle is reduced because of a general debility of the body.
I got your point. What does the literature say that the pre-existing condition or the status of the muscle is also a risk factor for developing ICU acquired weakness. So as you rightly said that if there is a chronic respiratory disease
Yes.
patients not only into the ICU stay to combat the acute exacerbation, but if he had long-term intake of steroids, so definitely the baseline muscle condition of the patient was already poor. So these patients are at an exaggerated risk of
Yes.
developing ICU acquired weakness. So these patients need to be catered with more responsibility rather than the other general surgical ICU patients.
Okay, got it.
Absolutely pleasant. Thank you, ma'am.
Thank you, Dr. Pooja, for your presentation. And the next presenter would be Dr. Neha Gotmare. Dr. Neha, are you online?
Hello.
Yes, ma'am. We can
Ma'am,
hear
can
you.
you see my screen?
Yes, ma'am. It is visible. Please go ahead with your presentation.
It's visible.
And please put it on the presentation mode.
Yes, yes. Ma'am. A very good afternoon to everyone. Today, the topic of my presentation is prevalence of cervicogenic headache with the age group of 18 to 40 years using cervical flexion rotation test, a cross-sectional study. These are the agendas for today's presentation. Headache is found most commonly in 96% of the general population,
Dr. Neha,
affecting the
sorry to
quality of...
interrupt.
Hello?
Slide is not moving, ma'am. Please put on your presentation mode so that it will be visible.
Now, is it moving?
Yes, ma'am. Now it is moving, and try put it on the presentation mode itself.
And can you see the introduction slide?
Yes, ma'am. Now it is visible.
Okay. Headache is a common disorder affecting 96% of the general population, affecting the quality of life and laboring the productivity. It has been classified as primary headache as well as secondary headache. Primary is idiopathic and secondary headache has an underlying cause. So one of the common secondary headache is cervicogenic headache, which is resultant of musculoskeletal dysfunction referring from the upper cervical vertebra. Cervicogenic headache has a distinct and impactful form of discomfort and affecting the neck range of motion, which can be clinically or manually examined using cervical flexion rotation test, which has a high degree of sensitivity and specificity. The present study wants to explore the prevalence of cervicogenic headache with the focus on CFRT, aiming to the uniqueness and importance of the diagnostic precision. As 90% of the 90% of the cases are been misdiagnosed, leading to the ineffective treatment, the study wants to address the gap using the cervical flexion rotation test, which has a high specificity and sensitivity. With increasing devices use poor posture in the age group of 18 to 40 age group, it is important to accurately determine the prevalence of cervicogenic headache and provide proper intervention. So the study aims to find out the prevalence of cervicogenic headache amongst the adult with the age group of 18 to 40 years using cervical flexion rotation test. It was a cross-sectional observational study with a convenient sampling inclusion criteria, subject fulfilling the cervicogenic headache international study group diagnostic criteria, both the genders, frequent episodes of headache in the past, the patients who were not willing to participate, systematic illness, any prior spinal injury, any cervical condition or congenital condition, history of whiplash injury, and any neurological condition were excluded from the study. Ethical approval was obtained. 200 participants were screened according to the selection criteria and 149 fulfilled the criteria. Participants were explained about the procedure. Informed written consent was taken and cervical flexion rotation test was done for finding out the cervicogenic headache. 103 participants were positive and this is how cervical flexion rotation test was done. The result shows that when cervicogenic headache was assessed using the cervicogenic headache international study group diagnostic criteria, we found out 73% of patients to be participants to be positive, which is
Dr.
which
Neha,
can be
the slide
yeah.
is not moving. Can you please put it in normal mode and present, and we are trying to view your slide. It is not moving. Yeah.
Ma'am, now it is.
Yeah, now it is moving. Thank you.
Okay. This has been supported by Torber John and Antonasi et al. Found that cervicogenic headache international study group criteria to be more specific for diagnosis of cervicogenic headache with the diagnostic accuracy. In the study, we inadvertently, the sample selection was within the age group of 21 to 30 years, and the present study found that the percentage was supported by Mitul Thakur and Mrutyunjay et al. With 15.6% prevalence in the age group of 18 to 40 years using International Headache Society diagnostic criteria. The prevalence using the cervicogenic headache flexion rotation test, we got 69%. Ma'am, is the slide visible?
Yes, ma'am, it is visible.
Yeah.
Please go ahead.
It was when we we found out the data analysis of cervical flexion rotation test, we found that 69% were positive amongst the 149 samples. And it was supported by Sarah Abro, Krutika Kare, Rutuja Malware with and Tala Hassan. They found out in their study also a high prevalence of cervicogenic headache on the different population. Vedival et al. In 2022 found 10.4% using Google form in the age group of 15 to 24, which is contradicting the present study. But it is in the age group of 15 to 24, and the study which we are doing, it is on 18 to 40 years. Cervicogenic headache originate from the dysfunction of the upper cervical segment, typically in the individual with the prolonged posture and repetitive neck strain. It's commonly seen in the young population, attributed to the postural stress, mechanical loading on the cervical spine, careers or education which demand sedentary lifestyle, and poor ergonomic using handheld devices and other stress factors. It has been found that flexion rotation test in a systematic review to be very specific and sensitive in diagnostic cervicogenic headache, which also supports the results of the present study. So the study concludes that 69% of prevalence of cervicogenic headache in the studied population using cervical flexion rotation test. So there is a need to emphasize in need of increased awareness and early intervention strategies, and CFRT can be used as an early screening tool. Future scope, it can be studied impact of cervicogenic headache on the quality of life and the productivity, and the efficacy of different intervention also can be studied. These are the references. Thank you.
Thank you for your presentation, Dr. Neha.
Yes.
Do you have any questions for this presenter?
Hello.
Yes, ma'am.
Hello, Dr. Neha.
Yes, ma'am.
I do not have any specific questions for you. We can move ahead with the next participant. Your presentation was really good, and cervicogenic headache is something which is actually at the rise right now.
Yes, ma'am.
So the topic is really nice. You can expand it. I do not
have
any specific question.
Thank you, ma'am.
Thank you, Dr. Rajita. And the next presenter would be Dr. Raunak Gupta. Dr. Raunak.
Hello.
Hi, ma'am.
Ma'am, is my screen visible?
Yes, ma'am, it is visible. Please put it in presentation mode and go ahead with your presentation.
Yes, ma'am. Good afternoon, everyone. My topic is assessment of peak expiratory flow rate and chest expansion of shopkeeper of commercial area situated near roadways of Southeast Nagpur and observational study. Traffic related air pollution trap is the main source of ambient air pollution in majority of Indian cities. The adverse health outcomes of TRAP includes cardiopulmonary mortality, acute myocardial infarction, asthma, respiratory symptoms, bronchitis, allergy, and cancer. Outdoor workers, especially shopkeepers, are more susceptible to occupational exposure as little or no attention is paid
to their health by the authorities. Need for study. Shopkeepers near the roadways are at risk of harmful effects of roadway pollutants, leading to air pollution, which results in respiratory function compromises. The present study is designed to find out PFR, that is peak expiratory flow rate, and chest expansion among shopkeepers of Southeast Nagpur. My aim and objective of the study is to estimate the prevalence of peak expiratory flow rate and chest expansion in shopkeepers working in congested commercial area of Nagpur. Statement, shopkeepers exposed to air pollution in commercial area situated near roadways of Southeast Nagpur will demonstrate impaired respiratory function. So methodology, study design, the study is an observational study and it was done at VSPM's College of Physiotherapy and shops in Southeast Nagpur, which is a congested area. And sample size was 350 and target population was shopkeepers exposed to traffic related air pollution. Now coming to inclusion criteria, we included shopkeepers who were working for 8 to 10 hours per day and duration, minimum 5 years of experiences in their shop. And we excluded those shopkeepers who has known case of respiratory disorder, obesity, and then recent surgeries, abdominal surgeries, thoracic surgeries, lumbar and cervical surgeries, and then known case of carcinoma receiving chemotherapy, case of long COVID, and yeah. And the results that we obtained was according to their gender first, total there were 350 participants. And out of 350, 330 were male and only 20 were female. And according to their age, we have divided it in 4 parts. 25 to 34 years, 108 participants, which is around 30%. 35 to 44 years, which was the maximum, where it was 148 participants. 45 to 54 years, 80 participants, and 55 to 64, 14 participants. Now coming to distribution of participants according to peak expiratory flow rate in liter per minute, less than 50%, as the graph is showing, 146 participant, which is 40%, showed less than 50% in PFR for their PFR value, which is less than 350 liters per minute. And 50 to 79%, 204 participants, which is maximum, like they showed above 350, which is the normative value. And yeah, and coming to chest expansion among male participants, for second intercostal level, p-value was 0.025, fourth intercostal space 0.075, and xiphoid processes 0.009, which is non-significant. Then coming to the discussion part, the shopkeepers working in congested areas with high volume roadside traffic are at risk with longer trap exposure, that is traffic related air pollution exposure. The normal reading of PFR in adult is in between the range of 350 to 450 liters per minute in a healthy individual. The mean age of study sample was 39.33, which is around 40. And the decline in PFR in among 146 participants out of 350 was noticed as their range was less than 350 liters per minute. And 204 participants showed in between 350 to 450 liters per minute as per peak expiratory flow meter readings. However, chest expansion values were found well within the limits of normative data. And thus, we concluded that shopkeepers working in areas with high traffic volume were having less ventilatory lung volume capacity due to traffic-related air pollution. And these are my references. Thank you so much.
Thank you, Dr. Raunak. Ma'am, you have any specific question for this presenter? Dr. Ajita?
Hello,
Ma'am.
Dr. Ronak.
Yes, ma'am. Hello. Hello, ma'am. Am I audible?
Yes, ma'am, you are audible, and I think ma'am is having some technical issues. Kindly have patience.
Okay, ma'am.
Hello, Dr. Ronak.
Yes, ma'am.
Okay, I'm so sorry. I had some glitch in my internet connection.
Yes, ma'am.
Okay, Ronak, you have taken shopkeepers and you have checked their respiratory function, right?
Yes, ma'am.
What were the parameters that you have checked?
Ma'am, I have checked peak expiratory flow rate and chest expansion at 3 levels.
Peak expiratory flow rate in how many seconds?
Ma'am, it was I took 3 times and I took the best of 3. Like, yes.
No, what I'm asking you is FEV1 can be checked. You said peak expiratory flow rate.
Yes, ma'am.
Hello?
Yes, ma'am.
Peak expiratory flow rate.
Yes, ma'am.
Okay. I just got confused with the FEV1.
Yes, ma'am.
Okay, so peak expiratory flow rate and
Ma'am,
what
and
else did
chest
you check?
expansion. Chest expansion at 3 levels.
Chest expansion. Why did you check for chest expansion, Dr. Rona?
Ma'am, because it was written in my parent article, as well as I wanted one more additional thing to check in respiratory functions, and it was more feasible method. So I took it, but it was found non-significant. I mean, the values were
Yes,
within
actually,
normative values.
see, it has got no relevance to the pollution that they are enduring.
Okay.
Instead of your chest expansion measurement, you could have tried getting their FEV1 values or maybe FVC values.
Okay.
Or maybe you could have taken their history for sputum or respiratory, dyspnea levels or something of that sort. That would have been more relevant. But anyways, PEFR is also a good measurement. And see, in this you said that it was more feasible. Never say that. Never say that was more feasible. So I took this. Certain things that are irrelevant and which we think that will not give us any kind of result, we are taking it just because they're feasible makes no sense. Right? So we don't say that it was feasible, so we took it. We just say that it was there in the parent article, so we opted for it, but it did not show any. Right?
Okay.
This is for whenever you present next.
Okay.
Got it?
Yes, ma'am.
Yeah. We don't say that we took it just because it was feasible.
Okay.
We don't take things in research because they are feasible. We take them because they're relevant. Okay.
Okay, ma'am. Sorry.
Hello, Dr. Ronak. It was a good topic. But yes, you can be a little more specific about the outcome measures. Try taking some more significant outcome measures. Study what exactly the air pollution can do to the respiratory parameters of a particular person.
Okay, ma'am.
Right? Just try checking that, and maybe you can improvise this research a little more. But
Yes.
otherwise, it was good.
Sure,
Thank
ma'am. Thank you.
Thank you, Dr. Raunak, for your presentation. And the next presenter would be Dr. Srinidhi Biani. Dr.
Yes, ma'am.
Srinidhi?
Good afternoon. Good afternoon, everyone. Am I audible?
Yes, ma'am.
Ma'am, would you please share my screen? Okay. So the title of my presentation is Comparison of Aerobic Capacity and Perception of Fitness Between Cyclists and Gym Members by using Queen's College Step Test and International Physical Activity Questionnaire, a comparative study. Aerobic capacity of athletes is an important element of success in sports achievements. VO2 max refers to the intensity of aerobic process and actually denotes the maximum capacity to transport and utilize oxygen during exercise done at increasing intensity. VO2 max is the highest rate of oxygen consumption attainable during maximum exercise. It reflects physical fitness of an individual having athletic capacity. Maximal oxygen uptake as a measure of aerobic capacity has been determined as international standard of physical activity. The maximal oxygen consumption attained during a graded maximum exercise to voluntary exhaustion has long since been considered by the WHO as the single best indicator of cardiorespiratory fitness. Ma'am, next slide, please. There are a need for the study is there are varieties of fitness tools present in this fitness freak era we all are living in. Few out of many available options as swimming, cycling, gymming, aerobics, etc. There are several burning issues building up regarding the sort of all the different forms of blooming fitness options available in the Indian market. So to bring about the transparency of what regime is more effective and are easily opted, we are comparing two forms of physical exercises among the availables. Also, there is a dearth of literature regarding comparison of aerobic capacity and perception of fitness between the two cyclists and gym members, subjectively and objectively. So, there is a need for the study to compare the aerobic capacity among cyclists and gym members, subjectively and objectively. Ma'am, next, yes. Aim for the study is to compare the aerobic capacity and perception of fitness in cyclists and gym members. And objectives are to quantify and to compare VO2 max in cyclists and gym members by using screens for its step test, and to quantify and compare perception of fitness among cyclists and gym members by using IPAC scale. Ma'am, next slide, please. Material used for the study are Queen's College Step Stool, which the height of the stool was kept at 16.25 inches. Standardized metronome used for Queen's College Step Test, which is set for 96 beats per minute. Stopwatch, sphygmomanometer, weighing scale, stadiometer, and printed IPAC scale. Methodology was the study design is a comparative study. Study setting is BSPM's College of Physiotherapy, gym, cycling clubs in and around Nagpur district. Type of sampling is sample of convenience, and target population was males of 20 to 30 years of age. Inclusion and exclusion criteria. I've included the males age ranging between 20 to 30 years having normal BMI. Cyclists doing cycling for at least more than 6 months in and around Nagpur district. And gym members running for at least more than 6 months in and around Nagpur district. Subjects excluded were having history of musculoskeletal trauma in last 6 months. Subjects having any cardiorespiratory, musculoskeletal, or neurological disorders. So this is the procedure which have been followed. If time permits, I will definitely explain that in the end. Next slide, please. Okay, so the result of the study is, in this present study, it is seen that on comparison of aerobic capacity of cyclists and gym members was found to be statistically significant higher in cyclists, that is 52.3 ml per kg per minute, than gym members, which was 48.5 ml per kg per minute. Similarly, in this study, it has been seen that perception of fitness among cyclists was found to be statistically significant. Statistically significantly higher than gym members, that is 1920 mDs in cyclists and 1800 in gym members. Both were under hip active category. Ma'am, next slide. So in this given chart, it has been shown that comparison of aerobic capacity in gym members and cyclists. Gym members are having 48.5 and cyclists are having 52.3 ml per kg per minute. And next slide. In this, there is a comparison of perception of fitness between gym members and cyclists. So using IPAC score. Here, gym members is having 1800 METs and cyclists are having 1920 METs. Both lie under hyperactive category. Ma'am, next slide, please. Okay. So in the discussion, the intensity of cycling activities which involves some high intensity periods and where there indeed observed that during recovery, the average VO2 was significantly higher than performing continuous intensity exercises. The cycling is found to have some more advantages to increase energy metabolism after cessation of exercise. Also, in addition for painful step test, there is stair ascending and descending action, which is brought about by quadriceps and hamstring muscle. So it is well trained in cycling as compared to gymming, because in gymming we focus on full body workout, which includes other body parts as well. Also, strength training improves cycling performance, fractional utilization of VO2 max, and cycling economy in female cyclists. In the particular study, it was shown that adding heavy strength training improved cycling performance, increased fractional utilization of VO2 max, and improved cycling economy. The main mechanism behind this improvement seems to be increased quadriceps muscles cross-sectional area and fiber types shift from type 2AX to towards type 2A. Ma'am, next slide, please. Okay, so in conclusion, that will concluded that on comparison of aerobic capacity, which is the mean relative VO2 max of cyclists and gym members, was found to be significantly higher in cyclists than gym members. Also, it has been seen that perception of fitness among cyclists was found to be significantly higher than gym members, which were. Next slide, please. Okay, so these were my references. Thank you.
Thanks for your presentation, Dr. Srinidhi. Ma'am, you have any question for this presenter?
Dr. Srinidhi, can you please go back to your conclusion slide?
Hello.
Hello.
Yes, ma'am.
Dr. Srinidhi, conclusion.
Yes, ma'am. Yes, ma'am.
The last conclusion slide.
Yes, ma'am. Ma'am, so in this study, it has been concluded that on comparison of aerobic capacity, the cyclist between cyclist and gym members, it was significantly higher in cyclist, and also the perception of fitness was higher in cyclists as compared to gym members. Nevertheless, both were found into HAPE active category in the perception of fitness. Hello.
Dr. Srinidhi, I just wanted to ask you, the gym goers, what kind of exercise were they following? All of them were following the same kind of exercise regime, like cardio and then strength training and warm up, cool down? Was the pattern of exercising for all the gym goers the same?
No, ma'am. A specific regime or specific protocol was not given to gym members. It was a generalized training which a gym member does, which a gym goer does on everyday basis. No, it was not prescribed to. It was nothing was prescribed to them that this specific training has to be done. It was a very generalized protocol which they follow by themselves. Hello.
Ma'am.
Hello. Hello. Hello.
Yes, ma'am.
Hello. Yes, ma'am. Hello. Hello.
Dr. Ajita, are you online?
Hello.
Yes, Dr. Srinidhi, are you sure that the cyclists were not doing any kind of gymming?
No, ma'am, I have not discriminated that whether the cyclists were going to gymming, but this was the thing that the participants which I took were doing were the people who were a part of a cycling club. So they used to do cycling every day from last 6 months minimum. But this was not excluded that whether they were doing gymming or not. Hello. Hello.
Yes.
Yes,
Hello, ma'am.
Dr. Srinidhi, thank you for your answers. Thank you. Thank you for your answers, Dr. Srinidhi. I do not have any more questions. Thank you.
Okay, ma'am. Thank you. Thank you so much.
Thank you for your presentation, Dr. Srinidhi. And the next presenter would be Dr. Nutan V. Bansod. Dr. Nutan? Dr. Nutan, are you here? Dr. Nutan, are you online? Okay. So, ma'am, with your permission, can we move on to the next presenter? Dr. Ajita? Dr. Ajita? Participants, please have some patience. The session chair would be joining soon.
Hello.
Yes, ma'am. Yes, ma'am.
Ma'am, there was a call actually on my mobile. Because of that, there was interruption in the network.
Okay,
Yes.
ma'am, no problem. And the next presenter would be Dr. Nutan. So can we move on to the next presentation?
Sure, ma'am. Sure, we can.
Yes. Dr. Nutan, I'll be presenting your PPT from my side. And are you online, sir?
Yes, ma'am. I am online.
Yes, Dr. Nutan, thank you. And yeah, I'll be sharing your PPT right away. Dr. Nutan, please go ahead with your presentation.
Yes, ma'am. Hello, everyone. My title is Assessment of Exercise Capacity by Incremental Shuttle Walk Test to Measure Walk Distance in Adults, an Observational Cross-Sectional Study. So, the physical inactivity is leading to increase in non-communicable diseases at an early age. As per the Ministry of Health and Family Welfare 2022, the status of non-communicable diseases leading to death in India has increased from 37.9 in 1990 to 61.8% in 2016. Early identification and quantification by simple and reliable exercise testing method can help to improve the exercise capacity. Incremental shuttle walk test guides an individual to walk at progressively faster pace every minute, achieved by the pre-recorded signals. Also is a simple, reliable, and valid and safe even for the patient of heart diseases, lung diseases, and musculoskeletal disorders. Uh, Ma'am, next slide, please. Need for study. Urbanization have led to various problems. There is urgent need for detection and lifestyle changes for decreasing non-communicable diseases and improve exercise capacity. A study done by Bela Agarwal in 2016 found that the physiological responses to incremental shuttle walk distance were affected by gender and increase in age. Aging has detrimental effect on exercise performance. Incremental shuttle walk test has no ceiling effect and correlates better with exercise capacity, and it is a prognostic marker which is externally paced. Aim of this study is to assess the exercise capacity using incremental shuttle walk distance with incremental shuttle walk test in individuals of age group 30 to 50 years. Objective of this study is to find out the exercise capacity in 30 to 50 years of age group using incremental shuttle walk test, and to find out and compare the incremental shuttle walk distance using age and gender based equation with actual ISWD in 30 to 50 years age group, and to analyze the effect of age and gender on the incremental shuttle walk distance. Ma'am, next slide, please. Methodology. It is an observational cross-sectional study. Research setting was VSPM's College of Physiotherapy, Nagpur, and the population targeted was normal healthy individuals between 30 to 50 years age group, duration of 6 months, and sample size was 180, and it is a convenient sampling method.
Inclusion, both the genders were included, and the age was 30 to 50 years, and subjects who were willing to participate, and part Q questionnaire less than one. Exclusion was any musculoskeletal, cardiovascular, respiratory, neurological conditions, and metabolic diseases, learning disorders, recent trauma, any fractures in lower limbs, and smokers. Equipments were blood pressure machine, pulse oximeter, box, scale. Uh, next slide. Results. This graph shows that there is steady decline in walking distance as the age increases in both the genders. Next, ma'am. From this graph, it is found that the male walked more distance compared to female. P-value were significant. Next, ma'am. Values were compared between observed ISWD and predicted walking distance, and there was 3.64 percentage overestimation seen in the predicted values. Next, ma'am. Discussion. The influence of age on walking distance can be seen in our findings. A steady decline in both genders were noted as the age increases. This can be explained by loss of muscle mass, aging, age-related isometric strength loss, decline in skeletal muscle function, and VO2 peak that typically occur parallel with aging. The influence of gender can be seen in our study. Male walked more distance compared to female, which can be explained by the greater absolute muscle strength, muscle mass, and height of the men in comparison with women. A model of linear regression analysis using predicted ISWD as dependent variable was applied. There was significant correlation with observed walking distance, and the observed walking distance explains 67% of variance seen in predicted walking distance. The 33% which cannot be explained can be due to various factors which are not considered in the equation, like BMI, height. Conclusion, there is steady decline in ISWD walking distance as the age increases in both the genders. It is found that male walk more distance compared to female. There is significant correlation of predicted walking distance with observed walking distance. Ma'am, next slide, please. These are my references. Thank you so much.
Thank you for your presentation, Dr. Nuthan. Ma'am, you have any questions for this presenter?
Dr. Nuthan, why did you choose this topic? Because the assessment of exercise capacity by incremental shuttle walk test to measure walk distance in adults. Now understand this, that no matter whether it is a shuttle walk test or it is any kind of cardiovascular test, as the age increases, the distance is going to go down. Right? As the age of the person will increase, the distance covered with by that particular person, incremental test, whether it is shuttle test, it is a 6-minute walk test, or it is any test, that will reduce because of the deteriorating cardiovascular condition of the person. As the age increases, the cardiovascular endurance capacity, it decreases with age. Secondly, all the tests have already proved that the levels or the distance walked in a particular test is always a little more for males as compared to females. So why did you choose this topic for research? What is different from the things that have already been proved in other researches? What is different in your research?
Ma'am, I wanted to assess the exercise capacity in the normal healthy individuals. So and to produce the normative values, that this is the normal reference values that you can see in this age group, which are not still available for incremental shuttle walk test in India. That's why, ma'am.
Okay, so there is no normative value chart for the Indian population. And what exactly is your age criteria, Dr. Newton? Can you please come back to
Ma'am,
inclusion age criteria?
30 to 50. And ma'am, there is a normative value chart actually by study done
Yes.
by Bela Agarwal actually, but I want
Yes.
to go it's specific. I wanted to go uh,
Okay,
30 to
specific in
50
sense with age.
uh,
Okay, with
with
age. Okay,
age
30 to 50.
50
Okay,
years.
but Dr. Nutan, there are so many other things that could have affected the person's, incremental shuttle walk distance
Yes,
in
ma'am.
this age group. Some
Yes, ma'am.
males have
Uh,
achieved their menopause. Some
yes,
of might be
uh, uh, I excluded
menstruation
as much as
phase.
can in this study actually, as much as possible. But
Okay, what is the? Can you go back to inclusion? Can you go back to inclusion exclusion?
yes, ma'am.
Okay. No, I cannot see the inclusion exclusion slide, Dr. Nutan. Can you slide back to the inclusion exclusion slide?
Yes, ma'am.
Ma'am, can you see it now?
No, the screen is still stuck with the conclusion slide.
Let me share again, ma'am.
Okay.
Is it visible now?
Yes. Just give me 1 second, okay?
Sure, ma'am.
Going to participate, ask your question. Okay, fine. Thank you, Dr. Nutan. Thank you.
Thank you. Thank you so much, ma'am.
Thank you, Dr. Nathan, for your presentation. And the next presenter would be Dr. Neha Rajesh Padwai.
Yes, ma'am. I am sharing screen.
Yes, ma'am. Dr. Neha, are you sharing your PPT?
Ma'am, did you see it?
No, ma'am.
Okay, 1 minute. 1 minute.
Dr. Neha? Dr. Neha, are you facing? Yeah. Yes, ma'am, your PPT is visible. Please unmute yourself so that you could present. Ma'am, your PPT is visible. Please unmute yourself.
Hello. Hello.
Yes, ma'am.
Hello.
Hello.
Can you hear me?
Yes, ma'am, we can hear you.
Hello. Should I start? Okay.
Yes, yes,
Good
Neha, please start. Dr.
afternoon.
Neha, please start.
Dr. Neha, I think she might be having some technical issues, ma'am. Ma'am, with your permission, can we move on to the next presenter and
Yes, ma'am. Yes. Let us proceed with the next.
Yes, ma'am. Dr. Pallavi Bakode.
Yes, ma'am. Just a second.
Yes.
Is my screen visible?
Yeah, it is buffering. I think we'll just give it a second.
Yes, ma'am. It is visible.
Yes, now it is. It is visible.
Okay.
Yes,
So,
ma'am.
good evening, everyone. I'll start with my presentation. So, a topic of my study is immediate effect of cost-effective hip protectors on balance, mobility, and fear of falls in elderly individuals. Introduction. In order to carry out ADLs, balance is the
Dr.
most
Pallavi, we request you to put it on the presentation mode.
Just a second. It is not on presentation mode.
No, you'll have to put it on slide show.
It's on slideshow already in my. Now?
Yes, ma'am.
I think it's okay. It's
It's
visible,
okay.
so it's fine.
It's
Please go
okay.
ahead.
Please go ahead.
It's the slide is visible, so that's fine. Please.
Okay. All right. So the topic was immediate effect of cost-effective hip protectors on balance, mobility, and fear of falls in elderly individuals. Introduction. In order to carry out ADLs, balance is the most important component for activities like sitting, standing, walking. And fall leads to fear of falling and anxiety about ADLs. And this further leads to reduced mobility, increased dependence on family members or caregivers. And femur fractures are the most common and serious injuries resulting from fall in geriatric population. Certain interventions aim to reduce the incidence of femur fracture in elderly population, and one of them includes the use of hip protectors. And hip protectors have proven to reduce the morbidity rates by reducing the incidence of femur fracture. So need of our study was to make the cost-effective hip protectors, and the current hip protectors which are available are slightly expensive, which cost about 745 rupees to around 4,000 rupees. And thus, we wish to create a cost-effective hip protectors, which can easily be made available to majority of geriatric individuals. So aim was to find out effectiveness of cost-effective hip protectors on balance, mobility, and fear of fall. So in this study, we have found out only the immediate effect. Objectives were to find out time static stance and step test time pre and post hip protector administration, to find out tuck test time, and to find fear of fall score pre and post hip protectors administration. Methodology. The study design was observational. The study population was community dwelling elderly. Sample size was 96. Sample technique was convenience, and study duration was for 6 months, but only the immediate effect was seen. Inclusion criteria was ambulant elderly between 65 to 80 years of age, and exclusion criteria was any bedridden elderly, any recent history of fall and neurological disorders, and any eyesight, hearing related or communication issues. So this cost-effective hip protector was made with the material which was easily available, and material which was used was a strong denim cloth, a sponge, and the Velcro straps. So hip protector was made in the form of belt, where the sponge was fitted on each side of the hips, covering the IT area of femur, and it was attached with the Velcro straps to hold the hip protectors in place. Then, after making the dummy or a rough hip protector, a pilot study was done on 10 normal elderly individuals, and the corrections were noted. The suggestions which were given by the elderly individuals were noted, and this was the final product which was made, and it was applied on the elderly individuals. The study is still ongoing, but in this particular study, we have only seen the immediate effect. No, in time
Dr.
statics.
Pallavi, Dr.
Yes.
Pallavi, sorry to interrupt, but
Yeah.
I can only see your first slide. Did you move the slides?
Yes. Yeah.
We can
And
also seeing the first slide only. Yeah, now it's okay. Now it's
yeah,
okay.
okay. Now we can see the
Oh,
because you said that as you can see here, so I was like, I
Oh,
couldn't see here.
oh, I was,
It's
I
okay.
was.
It's okay.
I was showing all the slides. Okay, so I was on this
Yeah.
particular slide. So this was the protector which was made after the pilot study, and all the suggestions were taken into consideration. And this was the final product which was made and which was applied on the elderlies, and the calculations were made. So in our study, we found out that there was no significant change in the time statics stance time. In the tuck test, time up and go test, there was a significant change which was observed, and the p-value was less than 0.05. In step test, again, there was no significant change which was seen. And in the fall efficacy scale, there was a significant change which was seen. So in the outcome measures that we had taken, only the tuck test and the fall efficacy scale had a significant change on the components. Discussion in the above study, there was significant change differences that we have seen in timed up and fall efficacy scale. So time up and go test shown good enhancement in outcomes since it's a dependable, economical, and secure method for assessing functional mobility. And the geriatric people were more confident after using the hip protectors. And in fall efficacy scale, again, the geriatric individual had less fear of a fall wearing the hip protector, as it reduced their anxiety and they had some sense of security with the help of hip protectors. So conclusion was there was immediate effect seen after wearing the cost-effective hip protectors on balance, mobility, and fear of fall. So there was a mobility and fear of fall. There was a significant difference statistically, but on balance, it was clinically seen, but statistically there was no difference. And the current study is still ongoing. The study is still ongoing with respect to the compliance of individuals. And these are my references. Thank you.
Dr. Pallavi,
Yes.
the concept is really nice. And okay, I just want to ask you one question. The sponge that you have inserted,
Yes,
like, you
ma'am.
know, for the protection,
Yes.
what is the extent of it? Like how far it goes? What is the area that it is covering?
So we started right from the pelvic area, the ASIS of the individual, and which is covering, it is coming to the below the neck of the femur, basically, much below the neck of the femur. Because the IT femur, the neck femur fractures and the IT fractures are the most common ones. So we made sure that it is covering the entire area. So probably just above the shaft of the femur.
Okay, and it wasn't uncomfortable for the patient to walk with that sponge thing?
No, it actually the patients were the geriatric individuals are not uncomfortable. They were more secure and more confident.
And what was the thickness of the sponge? Like what was the bulge thickness?
The bulge thickness was around probably 2.5, it around 1 inch, 1 inch or 3 centimeters probably.
Okay. And it was inserted inside the jeans, right?
Yeah, inside the denim, like the denim cloth, a
Yeah,
strong
the
denim
denim
cloth.
material. Yes,
Yeah.
yes.
And
A
it was
strong.
secured
Okay.
inside, yes.
It's a very nice concept. Thank you so much, Dr. Pallavi. And I'll just wish you all the best for the further research that you're doing on this, because this is something that the geriatric population really needs now.
Yes,
You know,
absolutely.
the cost of healthcare on our economy because of the geriatric falls and malunions, non-unions at such an age is so prevalent that we definitely need something that can actually protect them from all this.
Yes, ma'am. Yeah.
So yeah, it's a good concept, and I just wish you all the best for your future research.
Thank you, ma'am.
Thank you.
Thank you.
Thank you, Dr. Pallavi.
Thank
And
you,
we are circling back to Dr. Neha. Dr. Neha, are you available?
Yeah, ma'am. I'm available. Should I share?
Oh, yes, ma'am. You can do that.
Okay. Should I start?
Sure, ma'am. ma'am, you can do that.
Okay. My topic is effect of Jacobson's relaxation exercise, the self-stretching exercise, deep breathing exercise on the physical activity level,
Dr.
insomnia, and
Neha, we
quality.
couldn't see your presentation. Sorry to interrupt. We couldn't see your presentation, ma'am.
Okay.
Yes, ma'am. Now it is visible. Put it on the slideshow mode and go ahead with your presentation.
Okay. Can you see it? Is it visible?
Yes, ma'am. It is.
Dr. Neha, your presentation is visible.
Okay.
What I would
Started.
suggest is that instead of reading the slides, explain your research. What exactly have you done? Explain.
Okay. So, ma'am, I studied on the physical activity level, insomnia, and quality of life of medical students. Just we know that medical students are always in a pressure of their exams. They are always in stress due to parental pressure, teacher pressure, and they it may lead to compromise their sleep, or it can lead to insomnia. And also we know that the physical activity level is also compromised, and this both lead to get decrease in their quality of life. So I just want to see the effect of the Jacobson's relaxation technique, self stretching exercises, and deep breathing exercises on physical activity level of this medical students. So my sample size was 90. Study duration was 1 week, and my study population was medical students. My inclusion criteria
Dr.
was,
Neha, Dr.
yeah.
Neha, please change the slide. We are still on slide 1. Please come to the inclusion slide. Yes.
Inclusion criteria in that female and males between 18 to 25 years of age, then any examination after 1 week, then those who intend to take part in the study. Then exclusion criteria was students who are contraindicated for physical activity and stretching, students who are unwilling to participate, students with comorbidities like diabetes and asthma, those who are under 18, age of 18, or over the age of 25. Then my outcome measures were insomnia rating scale, in that Athens insomnia score, then international physical activity questionnaire, and also take the socio-demographic data of the all the students. So
Please
next
change the
slide.
slide, Dr. Neha.
Yeah, yeah. Uh, in that I have just given the interventions like Jacobson's relaxation exercise. In that we have to just contract the same muscle and relax the same muscle. Then in that I have taken toes, calves, quadriceps, gluteus, abdominals, hands, shoulder, mouth, and eyes. In deep breathing exercise, it's normally inhale and exhale deeply. Then in self stretching exercise, trapezius stretch, tricep stretch, wrist extensor stretch, wrist flexor stretch, and calf stretch, and hamstring stretch. Next results. In that when we compare this it age wise, we see that maximum population were at the age of 22 years, and minimum was of 24 years. Then when we compare the gender wise, the patients were male percentage was 15.56 and female percentage was 84.44, so females were more than males. Then we compare Athens insomnia score at pre and post treatment. We notice that the there was significant changes in pre and post score. Post score was great than the pre score, in which we can I also see that IPAQ questionnaire in the International Physical Activity Questionnaire. We say that when in starting with vigorous there are four components in this scale: vigorous physical activity, moderate physical activity, walking, and sitting. More people were mostly sitting, and then walking, then moderate physical activity, and then vigorous physical activity. So when we compare sitting, sitting was just the sitting was just 0.3 or 3.07. The physical activity was 1.19. That shows students were more active after exercise. The mean value of moderate physical activity pre-treatment was 0.56 and post-treatment was 0.77. The mean value of walking was 3 and post-score was 3.65 and 3.64. The mean value of sitting was 6.69 and 7.63 pre and post respectively.
Dr. Neha, can we
Yes,
come to the
hello.
conclusion part? You're not audible. You're not audible. Your voice is very low. Can we come to the conclusion part of it?
Yeah,
Can you explain
yeah,
what did you
yeah.
conclude? Yes.
The study demonstrated the value of deep breathing exercises, self-stretches, and Jacobson's relaxation technique for improving medical students' quality of life, physical activity level, and sleep. After 1 week protocol, the Athens Insomnia Scale score was decreased. That means we show the efficacy of these exercises. The more they score, the more the insomnia. The less they score, the less the insomnia. The students' level of vigorous and moderate physical activity was significantly changed by International Physical Activity Questionnaire, but the walking and sitting components didn't perform as well. There is a chance that the study will last longer and employ more interventions in these factors.
Okay. Dr. Neha, what were the muscle groups that were stretched? You said na self-stretching. So was the self-stretching I mean, for what muscles did you apply self-stretching?
I go for trapezius stretch, tricep stretch, wrist extensor stretch, wrist flexor stretch, calf stretching, and hamstring stretching.
And what was the duration of all these stretches?
Ma'am, it was that 30-second hold and 3 repetitions.
3 repetitions and just one session, or there were multiple sessions in a day?
No, ma'am, one session in a day.
Okay. So, beta, next time when we are going to present something like this, always make sure that your intervention should be mentioned along with the number of repetitions, hold time, and number of sessions. Just make a table and mention what were the number of repetitions, how long did you hold it, and then uh, for how many sessions you did it. Another question that I have is Jacobson's relaxation exercise. Were the patients instructed for it? Were you giving them the continuous command which is required, or they were provided with some recorded instructions, or they just did it on their own?
I just given them instructions, continuous
Okay.
instructions, like you said, because it is necessary. We have to just say just contract, relax. I have given
Yes,
these
yes.
instructions.
Okay, so for every patient, you have given them separate instructions?
Yeah, ma'am. Yeah, ma'am.
Okay. And what was your sample size?
Ma'am, sample size was 90.
So for 90 patients, how were you able to give them instructions? How many sessions did they do?
Ma'am, one
It
session.
was
One session
just
for
one session?
1 week. Uh, I mean,
Okay.
one session a day, and it was for it last for 1 week.
Okay, so one session per day for the entire week and 90 patients. How did you manage giving them instructions? Just imagine
I
giving
I
instructions
take the
90
help of
a
my
day.
colleagues. I take the help of my colleagues. I
Okay.
didn't perform alone. I take the help of my colleagues.
Okay. Okay, so see, again, I'll tell you something. Whenever you go for a specific technique like progressive muscular relaxation or Jacobson relaxation technique, if the instructor changes, the effect of the relaxation technique changes. The instructions, the way that you were giving them, your voice, the calmness in your voice, the speed of your instructions, the way you instructed your patients, your colleagues might not have the same kind of, might not, I am definitely sure that between two people, the sound, the voice modulation, the calmness of the voice, everything changes. So I just have one suggestion for you. Next time, whenever you are intervening with a kind of relaxation technique, any kind of relaxation technique, go for recorded instructions. Just ask your patient to play the instructions, you record it in your own voice and just listen to it, whether your voice is calm and whether the patient will be able to relax at those instructions. Just record it, provide that instruction to the patient and ask them to do it, perform the relaxation. You can take a feedback from them by asking them, did you perform your relaxation session today or not? Okay, instead of taking the help of anybody else, because that will change your result, just go for a recorded instruction audio. Get my point?
Yes.
Okay. Otherwise, your topic is really nice. You can, in fact, expand this research by making two groups and comparing the interventions that you're giving. You can do that as well.
Okay. Thank you.
Thank you so much.
Thank you for your presentation, Dr. Neha. And presentation of Dr. Pallavi Elati has been scheduled in the last, ma'am. So, with your permission, can we move on to Dr. Gaurav Bhatnagar?
Sure, ma'am. Sure, ma'am.
So, Dr. Gaurav, are you online?
Yes, madam. 1 minute, I will share my screen.
Oh, sure, sir, sure.
Are you able to see my PPT, madam?
Yes, sir, it is visible now.
Mm, Madam, just a minute. Just. Yeah, madam. Sorry. Yeah. So, 8 minute slideshow. Yeah, madam. It is full screen now.
Yes, sir, it is.
Yeah.
Yes.
So, effectiveness of compressive myofascial release versus ischemic compression on pain and cervical lateral flexion range of motion in patients with unilateral active trigger points on the of the upper trapezius. Is it changing?
Yes, sir, it is.
Introduction. Yeah.
Yes, sir, it is.
So active trigger points are the common source of musculoskeletal pain in the people. Trigger point is defined as hyperirritable locus in skeletal muscle, and that is associated with the hypersensitive palpable nodule in taut band of muscle. Active myofascial trigger point of upper trapezius muscle cause symptoms like pain, autonomic phenomena, restricted range of motion. Manual therapy has got profound role in treating trigger points. Myofascial release is a type of soft tissue stretching that involves applying compression and sustained myofascial stretches to the target area to produce release. Ischemic compression is the application of progressively strong, painful pressure on trigger point to eliminate trigger points. On performing ischemic compression, tissue attains recovery by reperfusion, thereby relieving transient blood flow occlusion. Both the techniques are being used for treating the trigger points, but to the best of my knowledge, hardly any study available which had compared the two techniques. Therefore, the purpose of this study was to compare the effectiveness of compressive myofascial release and ischemic compression techniques on pain and active cervical lateral flexion range of motion in patients with active trigger points of upper trapezius. So type of study was randomized control trial, study sample patients with active trigger point of upper trapezius, sample size 34, study setting, physiotherapy, OPD. So inclusion criteria, both male and female were included, age 20 to 40 years, between 20 to 40 years, unilateral active trigger points on upper trapezius, patients who were willing to participate, and NPR is greater than or equal to 4. Exclusion having trauma, participants having trauma or accidental injury, history of surgery on particular cervical spine, other pathological conditions involving cervical spine, or participants on medication related to pain were excluded. So actually we have selected pain and range of motion for the cervical spine. So ethical committee approval was taken from the institutional ethical committee, recruited total 34 participants who met the inclusion criteria. They were randomly divided into 2 groups. Baseline data was also collected. Group A then received compressive myofascial release. Group B received ischemic compression. Outcome measures were assessed at pre and post intervention period of 2 weeks. And data analysis using students t-test, p-value less than 0.05 were considered significant. So in this way, we have given compressive myofascial release to group A. Participant was in sitting position, back supported with pillow. Then treatment began with compression to inactivate the active trigger point in 3 cycles of 30 seconds each, followed by broad stroke with the clinician knuckles to relax upper trapezius muscle constriction for 4 to 7 minutes, followed by cryotherapy for 15 minutes. For ischemic compression, forward lean sitting position supported by a pillow. So ischemic compression is accomplished by compressing trigger point in the trapezius, variable intensity, using thumb pressure for 60 seconds at each trigger point, which is repeated 3 times, followed by cryotherapy for 15 minutes. So these are my stats and results. So both we have done intergroup and intragroup. So first intragroup, within group comparison, like in NPRS, group A MFR. So there are changes pre-post which are significant. Then in group B also, in ischemic compression one, there are changes in the NPRS that were also significant. But between group comparison also, there was a change, and the group A is showing more reduction in pain as compared to the group B. Then cervical contralateral flexion range of motion in group A.
Dr. Gaurav.
Yes.
Dr.
Yes,
Gaurav,
madam.
I'll just interrupt you for
Yeah.
a second.
Yes,
What
madam.
is your outcome measure? Can you please tell me your outcome measure once?
Madam, pain and range of motion for cervical lateral flexion.
So pain has been measured by using what?
NPRS we have used.
Okay, and range of motion, cervical range of motion, lateral
By
flexion and all?
universal goniometer only.
Okay, fine.
And
Please continue.
specifically, we have included lateral flexion, contralateral flexion, basically. If my right side is having a trigger point, then my left side range will be decreased, contralateral flexion. So,
okay, got it.
So,
please continue.
In contralateral flexion, when compared between the groups, then group A was showing more increase in the contralateral flexion range of motion than the group B, which received ischemic compression. So these are the graph. So first is comparison of pain by using NPRS at 2 weeks between the groups, and then between group comparison of cervical contralateral flexion at 2 weeks. So we can see in group A more range of motion, more improvement in range of motion. Similarly, in group A, more reduction in pain. So discussion, the need for an objective evaluation of stiffness reduction after myofascial trigger point treatment has recently been investigated. Similarly to our findings, some studies reported a significant decrease of upper trapezius muscle stiffness after myofascial trigger point therapy. This may be responsible for the increased contralateral cervical flexion. The local therapeutic effects basically of ischemic compression include stimulation of the mechanoreceptors with associated attenuation of pain signals, mostly due to a depletion of specific neurotransmitters and a temporary obstruction of the local blood flow, followed by a rapid inflow of oxygenated blood to the area upon the release of the pressure. The treatment of myofascial trigger points by ischemic compression thus produces rapid pain relief as well as normalization of the biomechanical properties of the local muscle fibers, which restores the normal functional condition of the muscle, including improved range of motion and lower risk of injury. So in MFR group also, the probable mechanism for these improvements may be due to upregulation of activity of pain modulation in the tissue. In one study, the range of motion of neck improved significantly as the reduction in pain and spasm was seen, which increases the range of motion by using MFR. So study showed significant reduction in pain. This could be due to stimulation of mechanoreceptors. Pain gate effect on both A delta and C slow path fibers in the posterior horn due to stimulation of mechanoreceptors, that is A beta fibers. So we concluded that myofascial release and ischemic compression basically both were effective, but on intergroup comparison, we have found that group A was myofascial release was more effective than ischemic compression in reducing pain and improving the cervical contralateral flexion range of motion in patients with upper trapezius trigger points. So these are my references. Thank you, ma'am.
Thank you, Dr. Gaurav.
Yes, madam.
Ma'am, you have any question for this presenter?
Dr. Gaurav, in
Yes, madam.
2018, there was a research to compare the effect of myofascial release and ischemic compression on pain, cervical lateral flexion, and function in acute trapezitis.
Yes, madam.
And again, the outcome measure for them was VAS for pain. And they have also checked the cervical range of motion contralateral, as you said, opposite side. So they have
Yes,
also
ma'am.
checked the same thing. Along with this, they again had another outcome measure, neck disability index.
Disability,
They
NDI.
had, yes.
Yeah.
So I did not see this research in your reference. And I cannot understand what exactly is different from, I mean, how your research is different from this particular research.
Basically, madam, we have used compressive myofascial release, so by using knuckles of the therapist. So compressive myofascial release was used because of some instrument and assisted is also there, ISTM. In that also.
No, even they haven't used ISTM. Even
Okay.
they have used the same simple
Compressive
MFR
one.
and ischemic compression. Yeah, that's all.
But we have used that compressive myofascial release technique.
Yeah, both. What you have used, the compressive ischemic technique and the MFR, they have used the same thing. Did you try going through this research? What I can do is I can share it with
madam, okay.
you, this research.
Yes.
And just go through it once.
Yeah, madam.
Probably, it is a research in 2018. All you have to do is type your topic and 2018. So this research was done by Snehal Desai and Dr. Kiran Jethwani.
Okay.
Your topic is nice, and what you are comparing has really not been compared very often. So there are not many researches comparing
Actually,
these two
we want
techniques.
to.
That's true.
Sometimes what happens.
Yeah, that's true.
Reproducibility should be there. Like some scientists have done the investigation, but if we are not able to reproduce or something like that, so
no,
we can
I understand what you're saying.
Yeah, madam.
Yeah, I understand what you're saying. But
Huh.
just go through this research.
Yeah, I will also
See, I
go
don't
through. Yeah,
mind
madam.
you. Yeah, I don't mind that you have done the research. Your outcome parameter, they have used VAS, you have used something else. So
Yeah,
it's okay.
analysis.
There might be a difference in the technique also, the way you're doing it and all.
Yes,
But
madam.
I really think that this particular research should be your parent article, which I could not see in your references.
Yeah, that I think I have skipped because of this PPT. I have only selected few references.
But this should be on the top of it.
Top of the, but maybe it is
absolutely directly related to your research, right?
Yes, madam.
Yeah, just go through this research once. It is very much like yours, and probably you can expand your research based on this. They have given you a neck disability index as well, right?
Yeah.
Thank you so much for your presentation.
Thank you.
Thank you, Dr. Gaurav.
Thank you, ma'am.
And the next presenter would be Dr. Kinjal S. Patel. This is a e-oral presentation, ma'am. Sorry,
Okay, ma'am. Okay.
So the timing would be like around 5 minutes only, 4 minutes for the presentation, and 1 minute for the discussion. So, Dr. Kinjal, are you online? Dr. Kinjal?
Hello.
Yes,
Hello.
ma'am. Can you hear me?
Yes, ma'am.
Yes, Dr. Kinjal. You can
Yes,
proceed
ma'am.
with your presentation. And the thing is like 4 minutes for the presentation and 1 minute for the discussion. And please complete your
Okay.
presentation on time.
Okay. Okay. I presented from the Ankita madam's laptop, ma'am.
Ma'am, please hold on a second.
Hello.
So, ma'am, you have signed up for poster presentation. Are you willing to present as a poster or oral?
Hello.
Ma'am, we can hear you,
Yes.
ma'am.
Yes, ma'am.
Ma'am, is it an oral presentation or poster presentation, ma'am?
Oral presentation, ma'am.
Oral presentation. Okay, then the
Yes,
time
ma'am.
limit is 8 minutes, ma'am. 8 minutes for the presentation and the rest for discussion.
Okay, madam.
Okay.
Greetings of the day, everyone. Myself, Dr. Kinjal S. Patel. I am PhD scholar from Baikaka University, Karamsa, Danan, and I am assistant professor in Krishna School of Physiotherapy and Rehabilitation, KPG, Vadodara. Today's my topic is Healthify Knee Exercise Application for people with ONE, Development and Expert-Driven Validation Study. So, in introduction, osteoarthritis is degenerative joint disease that causes pain and decrease physical function and quality of life. It is most
Dr.
common.
Kinjal, Dr. Kinjal, sorry to interrupt you. You've got only 8 minutes, so I would suggest instead of reading the introduction, can you please get to the point where you can explain us your research? Like you can explain us what you have done in this. Because if you keep reading this at the point where you need to explain us the actual thing, your time will be over. So
Okay.
instead of reading this, explain us what you have done.
Okay, ma'am. Ma'am, I have developed an application for osteoarthritis of knee patient, which is named as a Healthify Knee Exercise. It is specially for rural population. So the population who are not understanding English language or other language, they are mainly understanding the Gujarati language. So my need of study is osteoarthritis is significant health issue, which is chronic health issue in rural population where the healthcare services and rehabilitation program may be limited. So there is lack of resources and awareness about the effective management of this condition. So for that, I have developed an application in Gujarati and English language with video and audio instructions for uh, managing the condition through the rural population. So in my application,
Can you show us the application?
yes, I have my
Maybe an
pictures of my
outline of it.
application.
Yes, the pictures of your application.
This is the pictures of application in which the one model is there and one is therapist is there who instruct each and everything in Gujarati with the audio and video presentation, and below the video there is a Gujarati description and English description, so uh, the language barrier can be removed through the application. So in the rural population they can perform an exercise at their home with the help of video instructions and the description instructions which is given below the videos.
Okay, Kinjal, are all these videos and all this application, I mean, all these information, it is in one app kind of a thing?
Yes, ma'am. There is 6 videos in one app.
Okay, so this app can be downloaded on the phone, and just correct me if what I'm saying is wrong. This app can be downloaded by the rural people on their mobile phone, and then they
Yes,
can
ma'am.
listen to watch the video and perform the exercises, right?
Yes, ma'am. Yes.
Okay. And before they download the app and before they start doing the exercises, will there be a physiotherapist assessing their condition?
Yeah, ma'am. Once
Like
in the
assessing them for,
yes,
yeah, diagnosis will be made?
once we conducted camp over the rural community at their places.
Okay, only then you will prescribe it.
Then I will take the population and apply one group. Then we will give one group for the app based exercise, and on the other group we can give the usual care exercises, same exercises to the both group.
Okay. Okay, Kinjal, just one last question. As you know, I was a faculty in KPGU when it was built. It was in the year 2014-15. So I have gone through this problem where I'm not a Gujarati, I'm a non-Gujarati. So I found it very difficult to explain the exercises to the rural population coming to the OPD. And you know that in
Okay, ma'am.
KPGU, the OPD runs very well.
Yes, sir,
You
ma'am.
might be working with Paras Bura, sir, right?
Yes, yes, ma'am.
Yes, he's a good friend of mine. So I know what kind of OPD we used to have there, and most of the patients are from the village area. So what the thing that you have done is really amazing because this was really needed, not just for osteoarthritis, knee, or not just for knee, for probably for a lot of other conditions as well. Now, what I want to know is if the patient is doing these exercises, do you have a feedback mechanism as well in the app? Like if they have done the exercise properly and the number of times they have done it, number of sessions, will you get a feedback or will they get a feedback? Okay, today you have done so and so sessions, or today you have done this number of repetition, or is it
No,
only
ma'am.
for a visual feedback?
It is not given in the application, ma'am. But for the feedback, I'll call them once in a week, and then I'll provide them diary for the session write down, that if they perform the
Right.
session through the application and they mark
Right.
that I am doing this exercise this day, this time, how many times they have done. So
Very nice,
I'll
very nice,
give them
Kinjal.
diary for the records.
This is an amazing concept. Thank you so much for presenting it. And yes, this is really worthy. I mean, like this is something that was really needed.
Thank you, ma'am.
More such apps for other conditions as well, so that people like us who find it difficult to work in Gujarat because we do not know even if the knee is called dhichin, if I'm not wrong,
Yes,
right?
ma'am. Yes, ma'am.
Hello.
Yes,
Yeah.
ma'am.
So for me, even learning these terminologies was a little difficult, and back then I did not get the idea of making something like this. But this is really nice, Dr. Chinjal. Thank you so much for presenting this.
Thank
I
you.
do not have any other questions. All I can
Okay.
request you is try finding more ways for us, people like us. Thank you.
Thank you, ma'am.
Thank you, Dr. Kinjal, for a presentation. And the next presenter would be Dr. Shyam Chaudhary, and he have submitted his presentation video. Ma'am, with your permission, can we play this for you?
Sure, ma'am. Sure.
Yes, ma'am.
So there will be no question answer session for Dr. Shyam Chaudhary.
Yes, ma'am. If you could give me the set of the questions, we can email him and we can get the answers from him.
No. That's okay. That's okay. That's a long process. Let us first see the presentation.
Okay, ma'am. I hope the screen is visible, ma'am.
Yes, ma'am. The screen is visible, but yes, I think the video is about to play. I can see your cursor. मेरे को मेल नहीं आया Ma'am, I'm unable to see the video. Is it running? I mean, is it still
Is it actually
not being
running, ma'am?
present? Hello?
Ma'am, I'm actually presenting the
Are we still online?
Yes, ma'am.
Okay. Someone else is present. May I know the name of the presenter? Efficacy of quadriceps activation. Okay, got it.
Yes, ma'am. Dr. Shyam Chaudhary.
Okay. Yes, ma'am. Is there some audio as well in this, or it is just the PPT presentation?
Yes, ma'am. Yes, ma'am. The audio is it is actually there.
Okay.
Or
I cannot hear any audio in this.
Yes, ma'am. So that we can email you the presentation to you so that you could evaluate it, ma'am.
Yeah,
Ma'am,
sure, you can.
possible?
Yes, you
Ma'am,
can do that,
also-
please. Please do that.
Yes, ma'am.
Yes, please email me the video. I'll just go through it once this presentation is over. I think just 2 more presenters are left.
Yes, ma'am. 3 more presenters are left, ma'am.
Yeah, so once these presentations are over, I'll just play the video on my laptop and see it. If there is an audio, I would like to listen to that audio.
Sure, ma'am. Sure. That is not a problem. We will email the video presentation right away. And with your permission, we are actually moving on to the next presenter. It is Dr. Kushbu C. Olodwala. Dr. Kushbu? Dr. Kushbu, are you online? Dr. Kushbu? Ma'am, Dr. Kushbu is not online, it seems. And with your permission, can we move on to the next presenter?
Sure, ma'am, sure.
The next presenter would be Dr. Ankita Shah.
Yes, ma'am. Yes, ma'am. I'm here.
Yes, ma'am. You can please start your presentation.
Yes, ma'am. I'm sharing the screen. Is it visible, ma'am? Hello.
Yes, Dr. Ankita, it is visible. Please go ahead.
Yes, ma'am. I'm Dr. Ankita Shah, Assistant Professor at Physiotherapy Department, and I'm a PhD scholar at Gujarat
Excuse me,
University.
ma'am. Sorry to disturb you, but I think I missed my turn, or I don't know what happened.
Yes, ma'am. We actually called out your name. We have started the next presentation, and we will be circling back to the your presentation, and the next will be yours. Please have patience.
Okay, ma'am.
Thank you.
Okay, great.
Dr.
All,
Ankita, please go
yes,
ahead.
ma'am. Okay, yes, ma'am. So today's my topic is cross-sectional study of physical activity and menopause, prevalence and implications for health. So as we know, menopause is like a current women's issue, and the menopause is a period of life when the ovaries depleted of the oocytes, and there's a cessation of the menopause. Physical activity, we all know there are many advantages of physical activity, and here I have assessed the physical activity of menopausal women through the IPAC. So IPAC decides the physical activity level in high, moderate, and low physical activity levels depending among the MET levels of the activities. Aim of my study was to investigate the prevalence of physical activity level among the menopausal women and implications on their health. So methodology, this is the inclusion criteria. I took 390 postmenopausal women aged from 40 to 60 years with the willing of consent, and this is the exclusion criteria. I excluded all of the women who are having secondary any disorders or diseases which can hamper with the physical activity level. Menopausal status was assessed by the proper definition by WHO, that is cessation of the menopause or cessation of the menstruation from last 1 year, and physical activity was assessed by the IPEC long form questionnaire, and I collected the data through the English and Google IPEC questionnaire, both the forms, and I collected the data through the Google forms. Results. So this is the demographic data of my patients. This is the age group. I found 37% of the women aging from 56 to 60 years, 31% of the women from 45 to 50 years, and 32% from 51 to 55 years. This is the physical activity level among the menopausal women. I found out 62% women were physically active and 38% were physically inactive. And among the 62 percentages, 38% women, like 148, number 148 out of the 390 sample, they were moderately physically active, and only 94 and number of 94 women were vigorously physically active among the 390 samples. This is the domain-specific physical activity level. I found that the job-related physical activity level among the women was 41%. The N is equal to 99. Transportation level physical activity was 9%. Household and household maintenance and caring of the family, women were included or women show physical activity level through the household work, that was 31%, and recreation time, leisure time was 19%. So during the recreation work time of the day, women are the very least active for the physical activity. So discussion, as we say, there are lots of benefits of the physical activity level.
Dr. Ankita, are you there?
Hello, yes, ma'am. Hello.
Your voice was lost in between, so I was just asking you, are you still there? Yeah, please continue.
Yes, ma'am. Yes, ma'am. So, as we saw that there are multiple benefits of physical activity level. As the physical activity level helps in reducing the severity of the menopausal symptoms, it helps in beneficial of the bone mineral density. It also helps in like mental and psychological well-being of the humans. But in our study, we found that there are specifically only 41% women were reportedly being very physically active as a result of their jobs. Suggesting that occupational activity is not a primary source of exercise for many women, and 31% of women, like 75 out of 390 women, were engaged in physical activity due to household activities. And 90 percentage of the women, like 46 out of 390 women, they were doing their physical activity, or they were active during only their leisure time. So they were not engaged in any household work. They were neither engaged in the job work, but they were doing exercise yoga during the leisure time, and that's how they showed the physical activity level. So in conclusion, the menopausal women like engage in physical activity primarily due to work and household responsibilities only, rather than their leisure or self-care activities. This trend underscores the need of increased awareness and encouragement for this women, prioritizing the intentional exercise and self-care. And by promoting this structured physical activity, we can help improving well-being and empower the women to take control of their health during the transformation of their lives. And these are my references. Thank you, ma'am.
Okay, Dr. Ankita, I just have one question.
Yes, ma'am.
Have you tried, this is a cross-sectional study, I understand that.
Yes, ma'am.
But
Yes, ma'am.
what do you think? What is your what is your opinion on this? The household work is that equivalent to the workout that a person would do in their leisure activity, in their leisure time? Because long back, we are not talking about this current population. Long back, there was a time when there was no concept of working out.
Yes,
Whatever household work a female used to do was the kind of workout that they required. So what in your opinion is that in these two groups, we'll forget about the working women group where they're not doing any kind of physical activity, and probably they're not even contributing well enough in the household work. But what about the females who are doing all the household work by themselves, and the other group which is involving themselves in some kind of workout?
So, ma'am, according to me, when we are doing when the women are performing household work, so it is like it is divided into like segments or work to rest ratios. So I guess the intensity and the time duration that is not maintained properly during the household work. Like if someone is cooking, like then she can stand for 1 hour or 2 hours continuously. But after that she sits down. Then after like 1 or 2 hours rest, she begins for doing another household work. So I guess that will not give that much, like that will provide a good physical activity level to the women, but that will not be like improve her cardiovascular endurance or her strength for a longer period, or in a sustainable manner. If a women encourages, or if women takes part in a proper exercise program, then there are the chances that women can improve her aerobic power, her endurance, and her muscular strength, everything. But in how the household course, I think, according to me, and I have read some certain literature also, household work will not lead to improvement in her endurance level, or her aerobic capacities, or her strength levels.
Okay, got it, Dr. Ankita. Thank you so much.
Thank
It
you.
was a
Thank you so
wonderful
much.
presentation. Thank you.
Thank you, ma'am.
So the next presenter would be Dr. Kushbu C. Bodwala.
Good evening, ma'am. Should I share my screen?
Yes, ma'am.
Ma'am, is there any more presenters?
Ma'am, only one presenter.
Do we have any other presenter?
Yes, ma'am. Dr. Pallavi Yelati, she is the only one who's left, and she will be presenting in the last after this presentation.
Ma'am, is my screen visible to you?
No, not yet, ma'am.
Now?
Am I the only one who is unable to see Dr. Khushbu's? Yeah, now it is visible,
Now
Dr.
it is
Khushbu. Please
visible
tell.
now. Yes.
Okay, ma'am. So today's my topic for the presentation is effectiveness of trunk rehabilitation on trunk control, balance and functional status in post-stroke hemiplegic patients. So the World Health Organization has defined the stroke as a disturbance in the cerebral function and the symptoms lasting more than 24 hours or the longer, and which lead to or which are having the cause of vascular origin. Worldwide, it is having 20 millions of people who are suffering from the stroke each year, and 5 million may be disabled by the stroke. So the balance is basically explained as upright position maintained by the patient in ways of support, and that leads to stability. So the trunk being the central key point for the body, proximal trunk control is prerequisite for the distal motion of the limb, and that leads to functional activity. Trunk control is the ability of the trunk muscle to allow the body into upright position, adjust their weight shift, perform the selective movements of the trunk, so that we can maintain the COG within the base of support during the static and dynamic postural activities. So the objectives of my study is to check the effectiveness of conventional physiotherapy treatment for the trunk control, balance and functional status in post-stroke hemiplegics. Second aim was to check the effectiveness of trunk rehabilitation program on the same outcome measures. And the third goal is to compare the effectiveness of trunk rehabilitation on trunk control, balance and functional status in post-stroke hemiplegics. So many studies
Khushbu,
were done in.
Dr. Dr. Khushbu, I cannot see your slide moving.
Just wait a second, ma'am.
Ma'am, it is not moving. Your slide is not moving. Please put it on the presentation mode or
Okay. Now is it
no.
moving, ma'am?
Yes, ma'am, it is moving now.
Okay. So in the past, there were so many studies were done on the stroke patient to check the effectiveness of various techniques, but that is basically done on acute and chronic patients, and there are very less studies which are specifically done on the trunk control. So the goal of my study or the significance of my study is to provide the literature by finding the effectiveness of trunk rehabilitation and trunk control, balance and functional status in the stroke patient. So for that, we have taken the data from the various OPDs of Surat, Gujarat, and study design was experimental type of study. So sample size was calculated with the help of G power, that is actually 30. That is also including the 20% of the dropout chance. Participants were subacute stroke patient and the purposive sampling was used. The duration of the intervention was around 4 weeks and duration of the total study was 1 year. So we have included the patients with the male and females and having age group of 45 to 75 years. First episode of CVA were included and the duration should be less than 18 months. Those who are able to walk with or without the assistive devices, scoring of TIS should be less than 21 out of 23, and subjects who were willing to participate, they were included. Those who are having other neurological problems apart from the stroke, they were excluded. Any sensory issues regarding and that is affecting the balance, they were excluded. Any perceptual dysfunction or lower extremity musculoskeletal problem, recent surgery patients were excluded. So we have taken the ethical clearance from the institutional ethical committee, and purpose were explained to the patient and consent form was taken. Subjects were preliminary based on the inclusion and exclusion criteria, and on the first day we have gathered the demographic data. Then they were divided into group A and B, where they were asked about TIS, BBS and FIM, and other demographic details were filled. So group A were basically conventional physiotherapy treatment group. In that we have given certain stretching and strengthening of weak muscle, bed mobility activities, mat activities, ambulation, transfer activity, weight bearing activities, and gait training we have performed, and that is given for the 45 minutes for the 5 days a week for the 4 weeks. So group B is experimental group. In that we have given the certain specific exercise for the trunk muscle, that includes our trunk rehabilitation program. In that supine activities involve pelvic bridging, unilateral bridging, then flexion rotation of the upper limb and lower upper trunk and lower trunk. In sitting exercise, there were flexion extension of lower trunk, lateral flexion of upper lower trunk, rotation of upper and lower trunk, forward and lateral reach were given to the patient. That activities were progressed with the reducing the base of support, advanced balance limit and increasing the hold time. That is also given for the 45 minutes a day for the 5 days a week and 4 weeks of duration. And afterwards, at the end of the fourth week, we have gathered the different outcome measures, that is TIS, BBS, and Barthel index for the functional status. So these are the three basic outcome measures, and we have done the whole statistical analysis with the SPSS version 20. Here we have taken the baseline data of age, gender, BMI, MMSE, and Brunstrom. Out of 30 patients, we were having 10 females and 20 were male. Here we have checked the normality of the data with the help of Shapiro-Wills test, and paired t-test was used for the within group comparison, while unpaired t-test was used for the between group comparison. So here we are having the data of age, BMI, MMSE, and Brunstrom scale. So we have calculated mean and ST for both the group, that is A and B. This is a graph which suggests the male-female gender ratio. So here we have applied the PAT t-test for the basic three outcome measures, and the p-value for the all the three outcome measure, that is your trunk impairment scale, BBS, and Barthel index. P-value is less than 0.05, which suggests that significant improvement in group A. And for group B, again we have checked the p-values, and that is also less than 0.05 for all the three outcome measures. Now we have applied the unpaired t-test for the between group comparison, and the p-value for that is that is between A group and B group. So trunk impairment scale value is p-value is less than 0.05, that is 0.2. BBS, that is 0.00, and Barthel index, that is 0.1. So all three suggest that there is a significant improvement in the group B compared to group A. So here we have done the comparison, and as I told you, that is for group B, there is significant improvement in the group B, that is that is our experimental group. So similar kind of studies by Rajpurinder Kaur Rai, that has performed the trunk rehabilitation program, and they have assessed balance and gait, and they have also found certain positive results for the improvement in the balance and gait. The same type of study was done by Karthik Babu, and which also supports our study. So the improvement is basically done by the various mechanisms which I have explained. That trunk rehabilitation exercise basically improve the activation of the core muscle, and weak muscles are getting strengthened. They are leading to increased awareness regarding trunk position. Anticipatory postural mechanisms are getting developed, and that is creating the good trunk control for the patient. And here the balance is also improved just because not just because of selective flexion and extension movement, but also the rotatory movements are occurring at the upper and lower trunk, which leads the proximal stability to the muscle, and distal mobility is created. So that is ultimately leading good balance, and good trunk control is leading to improvement in the functional status of the patient. So here the conclusion suggests that both the treatments are effective individually, that is conventional physiotherapy is also effective for the patient, as we have found the significant difference, and group B is also effective individually. But whenever we are doing the comparison of both the group, B group is having more effectiveness, as we are providing additional trunk rehabilitation exercise. So the limitation of my study is that sample size was very small. We have taken the purposive method of the sampling, so the all the population cannot be accessed properly. Follow-up of the patients were not taken, and we have already taken the participants who are independent for the walking. So that is the limitation of the study. Further study can be done with large sample size, and wide range of area can be covered. So the clinical implication of this study suggests that there is always window of opportunity to improve the condition by early rehabilitation program. So the less dependency would be there. After rehabilitation of the trunk muscle balance training, that can improve sense and functional status of the patient. So ultimately achieving a good quality from the patient. So these are the list of reference. Thank you, ma'am.
Dr. Kushbu, I just have one question for you. The stroke patients that you opted, that you included in your study, they were hemorrhagic stroke patients or ischemic stroke patients?
Both the group, both the types of strokes were included in that. But only the condition is that we have only taken patients who are having first episode of stroke.
Who have? Pardon? Can you please come again?
We have taken both the types of stroke, that is
Dr. Khushbu, you're not audible.
hemorrhagic and ischemic, both the types. But we have included only the stroke patients.
Can you please type it in the chat box?
Khushbu?
I think there is some problem with her network.
Yes, ma'am. She got disconnected. She might be having some technical issues. Okay, ma'am.
Okay.
We'll be informing her to type out her answer in the chat box itself. And
Sure.
with your permission, let's move on to the next presenter, Dr.
We have
Pallavi
another
LRT.
presenter?
Yes, ma'am. Only one
Okay,
more presenter.
yes.
This is our last
Yeah,
presentation.
Sure.
Yes, ma'am. Dr. Pallavi, are you online?
Dr. Pallavi? Yes, I'm online. And thank you very much. Actually, can you hear me? Am I audible?
Yes, ma'am. You are
Yes.
audible, ma'am.
Yes, I'm here to say thank you. Actually, after seeing so many presentations and my students, my colleagues, they presented the paper, then I decided to just thank BioLeak, then Dr. Ajitha and Dr. I think Prithvi or something, Pavitra. So here I'm not going to take much of your time, and I'm thanking you from bottom of my heart for organizing such a wonderful conference and so many presentations, patient listening, very good questions, quality questions. So all the participants will have insight about the research. And thank you very much. And I would like to see all the people on the screen, specifically Dr. Ajita, because she was asking so thorough questions and good questions. So here I request Dr. Ajita Madam to switch on her camera. Then Sir also, one more chairperson. Can I have all of you, those are present here on screen in the gallery?
Dear participants, we are requesting you to switch on your camera.
Those are here because many of them, they might have left this conference.
Hello, Dr. Pallavi. I am actually sitting in
Yes.
my car and attending to the session. So my network can be an issue right now.
Yes,
I'm Ajita.
you are Ajita. Oh, yes, madam. Nice meeting you. You are situated
Nice
at?
meeting you too. Bhopal.
Yeah, thank Bhopal. Okay, close to our place only. We
Where
are
are
at
you, ma'am, from?
Nagpur. We are at Nagpur, and maximum presenters were there from our college, VSPM
Yes.
College of Physiotherapy, Nagpur. And they were so happy with your questions, madam. They were very happy with your questions, and they got so much insight from your nice questions. Thank you, all of you. Thanks from my bottom of heart. Thank you very much.
Thank you so much, ma'am, for your kind words.
Over to you. Over to you, Bainik.
Thanks, Dr. Pallavi, for your thank you note and all. And dear participants, here we are at the end of the day 2 of Rehab Conclave 2024, which is organized by BioLeaks in association with Swan Sunanda University, Bangkok, Thailand, Modern University for Technology and Information, Egypt, INTA International University, Malaysia, and PMS College of Physiotherapy, Nagpur, India. On behalf of BioLeaks, we would like to thank our poignant keynote speakers, our honorable session chairs, and all our dearest participants for making Rehab Conclave 2024 a grand success. We are so grateful to extend our special thanks to our dearest session chair, Dr. Ajita, for your contribution. Thank you, ma'am. And Dr. Pallavi LRT of PMS College for being one of our strongest pillar for this conference. Once again, thank you all the participants for your patience and for your presentation. And regarding the certificate, it will be provided next week. Dear participants, you will be receiving your certificate with the next week. The winners list will be provided next week also. And once again, thank you everyone for your presence. And thank you.
Thank
Have
you,
a
ma'am.
great day.
Thank you so much.
Thank you so much, and all the best to all the participants. Thank you, BioLeague, for having me as a session chair. Thank you and all the best.
Thank you, ma'am. Thank you, ma'am.
So,